started even before the Indian Orthopedic Society. It was established in 1965, and this year we are celebrating 60 years of our society. Can I have my PPT, please? So, okay, so we are celebrating 60 years, 6 decades of excellence in clinical work, in academics and teaching, in research and innovation. The Bombay Orthopedic Society, you might have heard of such names of legends like Dr. K.T. Dolakia, Dr. R.J. Katrak, Dr. K.V. Chaubal, Dr. Tarapurwala, B.B. Joshi, Dr. Tanna, Dr. Ladd. All of you have known these legends, and it is over these legends' shoulders that we have climbed to reach where we have. Orthopedics began in Bombay in 1936 when at the B.J. Wadia Children's Hospital an orthopedic unit was established. In 1942, Dr. Katrak established the Department of Orthopedics, which was an academic teaching unit at the GS Medical College and the KEM Hospital in Bombay. In subsequent years, the Bombay Orthopedic Society kept growing. Starting out, we used to have a couple of academic programs a year, and we used to have bi-monthly clinical meetings. As time went by, the number of orthopedic surgeons increased and the need for academics, tutoring and teaching increased. So gradually, the Bombay Orthopedic Society started having bi-monthly clinical meetings. We have a bi-monthly master series, which is a CME on specific topics. But what Bombay Orthopedic Society became famous all over India and in the neighboring countries was for its fantastic courses. We used to have at one time almost 27 different courses which were attended by many orthopedic surgeons across our country, and these courses were extremely popular. We've also got a postgraduate teaching program where every 2 months they meet and they present clinical cases to senior examiners. We have fellowships and observerships, and VIROC is our premier event. The Bombay Orthopedic Society runs a biannual journal of clinical orthopedics, and I invite guests from all over India to contribute their articles to the journal. The journal is indexed with DOAJ, and we are looking for an indexation with the PubMed. The Bombay Orthopedic Society, led by Dr. Harshad Argekar, has established an app which will help you to get consents, specific consents for specific procedures in patients. Dr. Agashe led the osteoarticular tubercular research, which was published, original research, multicentric, done in Bombay. So where do we stand today? Bombay Orthopedic Society in India is considered an academic powerhouse. It has directly or indirectly influenced more than 1/4 of all practicing orthopedic surgeons across the country. Our legacy is strong, but as you will see today, with all the youngsters who are going to speak and present their work today, that our future is even stronger. We've always strived to innovate and improve. We've tried to spread the message of education across our country. We've always wanted to collaborate with other societies, whether they be city-wide societies, state-wide societies, or national societies, in various aspects to spread the message of orthopedics. The goal being to elevate orthopedic care across our country and across the globe. In this 60th year of the Bombay Orthopedic Society, we have started a number of new initiatives with the aim of building bridges, sharing knowledge, experience, expertise, and innovation with colleagues and societies across the globe. Every month, we have a worldwide webinar with different societies across the globe. In fact, just last night, we had a webinar in collaboration with the British Association of Spinal Surgeons, and the webinars are directed at general orthopedic surgeons. So I invite all the guests who are there from across the country that you all can attend these webinars for free. Information and link about the webinar is available on the Bombay Orthopedic Society website. Every month we are traveling to different cities across the country. And we are taking the top Bombay Orthopedic Society talent to these cities and holding CMEs over there. Next weekend, we are in Rajkot. A couple of months ago, we were in Raipur. And in Raipur, not only did we have a CME for orthopedic surgeons, but we actually had a postgraduate teaching program too. So Bombay Orthopedic Society is genuinely attempting to spread orthopedic education. This is our second ReLive Surgery Symposia. The first one in hand surgery was attended. We had about 20 different centers across the country. And it was immensely successful. We showed about 17 hand surgeries on that day. Today, the ankle foot symposium, we are planning to have divided it into two halves. In the first half, we will have cold orthopedics. And in the post-lunch, we will go on to trauma. So we have planned to show you 12 surgeries. Depending on time available, we can do less or more. With us, we've got some fantastic faculty, which I will leave the convener of this program to introduce. The Bombay Orthopedic Society is also coming in with a series of small books, which will be very useful for orthopedic surgeons across the country to keep in their clinic and read before they go in for surgery. They will be released in December. In November, like today, we have a live pediatric orthopedic surgery symposium. I hope that all of you will take the opportunity and join us on that time. And finally, as chairman of the VIROC, our annual conference of the Bombay Orthopedic Society, this time it is a special one. It is the Diamond Jubilee Conference of the Bombay Orthopedic Society, and therefore BOS today is recognized as the best orthopedic meeting in India. It is probably the second most commonly attended after IOCON, though everybody agrees that the program of VIROC is far better than IOCON. And this year, as part of our VIROC, we have a number of new things. We've organized 4 pre-conference workshops on endoscopic spine, robotic hip and knee, complex elbow reconstruction, and management of soft tissue injuries. So these are all cadaveric workshops, one-day workshops, and I welcome people from all across India to come and attend these workshops. They are unique, they are one of a kind, and you will gain and benefit tremendously from these workshops. The main conference is from the 26th to 28th of December. What is new is the introduction of practical master classes. In the evening, we'll have smaller sessions of 50 to 60 people between 5 and 6 in the evening, where we will actually demonstrate and allow the delegates to participate in CTV correction, application of negative pressure wound therapy, how to print 3D models of bones, and how to implement the utilization of these models during surgery. So a lot of these things are going to be there, and I'm sure you will learn and gain tremendously from attending them. On Sunday, the 28th of December, in the afternoon, we have half-day workshops on shoulder arthroplasty, a sawbone workshop. But what we've also got are the arthroplasty and orthopedic trauma boot camps. What is this boot camp? It has been seen
What
that
are
as
the
a general orthopedic surgeon out in practice, we are not really updated about the newer things that have come into the market. When I started hunting for things for orthopedic trauma boot camp, I came to know that there is something called as a tightrope, which as a spine surgeon, I had no idea that there is something called as a tightrope. So we thought that we should introduce these newer products to the orthopedic surgeons. So on Sunday afternoon, we are going to have a big room where different products are going to be there on different tables. And the delegates will move from one table to another every 20 minutes. And they will be introduced to the product by the company people themselves, but also by a set of orthopedic surgeons who are utilizing these products on a regular basis. So it's a way to introduce you to the newer innovations that are happening in orthopedics. The Maharashtra Orthopedics Association is running a day school in musculoskeletal radiology, and the theme is precision orthopedics using intraoperative imaging. So it's going to be a fantastic CME over there. And finally, not least, for the first time ever in any conference across India, we have something called as the Tech Corridor. This is to introduce our delegates to the newer things that are available in technologies that are available in orthopedics. So we are going to have a robot studio where there are going to be 4 or 5 robots. Delegates will be allowed to go through and play with the robots, and intermittently there will be workshops where formal training and education will be imparted. Similarly, we have a studio on mixed reality where our augmented and virtual reality platforms will be available. And we have an artificial intelligence lab where various applications of artificial intelligence will be shown. And along with that, there will be workshops on how to edit intraoperative photographs and videos. What are the newer apps on your smartphone and how to use them? So a lot of different newer things we are planning. Along with that, a highlight is going to be the social program on the 27th evening, where we've got Mr. Shankar Mahadevan performing. So imagine that for a delegate coming from Ludhiana, in one registration, he is not only enjoying the conference, he is going to learn a lot of new things in technology, innovations, etc., and enjoy Shankar Mahadevan and our hospitality before going back home. So I take this opportunity to invite each and every one of those people seated here in the audience today, as well as people who are seated here across the country watching us on the Zoom platform, and invite them to be here with us. Let me now stop here and introduce the convener for the program today. The convener for the program is Dr. Ashish Phadnis. He's a trauma and reconstructive surgeon who is the head of department of orthopedics at the Jupiter Hospital in Bombay. He is also a prolific techno-savvy person and has done a lot of work on artificial intelligence, etc. Recently presented a paper on that at the CCOT meeting. He is going to convene this ankle foot symposium. He will give you more details about what is to be expected. But each part, just to tell you about, give you some basic rules. We are going to have each video, the presenter will come up here. He will show you the history, the examination, the X-ray, the MRI. And he will tell you the diagnosis and what his treatment plan is. Once he tells that, then he will go on to the video. The video will run for about 10 minutes. And then the session will be opened out to everybody in the audience, both in Bombay and all those who are online, to ask questions. And question and answers will be done. So this is the pattern of this thing. People in the various centers, the audiences should pass the question on to the moderator at that center, and the moderator should ask the question giving the person's name so that we can answer the question at that time once the videos are over. Generally, we try to restrict each case to about half an hour. And without much ado, let me now hand the mic over to Ashish to tell us what the program is for today.
We can go to the wire off page. Thank you very much, sir. And to set the proceeding, I think without wasting more time in brief introductions, as Sir recapitulated, we would be running these videos and you will get a chance to ask the questions as and when they come. I'm the convener. I can say for sure, just for the purpose of logistics, I'm not a foot and ankle surgeon, but we have got a lot of stellar faculty from the foot and ankle world who are with us, and especially my co-conveners, Dr. Pradeep Moonot and Dr. Abhishek Kini. Dr. Pradeep Moonot will be joining us in some time, and I would invite Dr. Abhishek Kini also to convene the session. And I think we can start with our case videos and the first case and first video with Dr. Dhrumin Sangoi, who's our dear colleague and an experienced foot and ankle surgeon. And Dhrumin is going to take us through insertional tendoachilles tendinopathy with excision of the spur. Okay.
Thank you, Dr. Ashish. Thanks, Bombay Orthopedic Society and Dr. Gautam Zaveri for giving this platform to teach everyone about something about foot and ankle, which we do. So my topic for today is Hagelund excision and insertional tendoachilles tendinitis, a common problem which we all see in our clinics. So 5 minutes and 10 minutes, 15 minutes we have. I'll try and club and manage to finish in that time. So everyone comes and everyone has seen such patients who come with heel pain. They have the pain at the back of the heel. Some people have pain at the bottom of the heel. Now it is very important to distinguish where the pain is. In foot and ankle, you need to know the pain generator. Where is the pain? Because MRI will tell you 100 things, but you should know where the patient is pointing the pain and what the MRI shows and correlate that. So this was a 52-year-old male. He had pain at the back of the heel. He was a yoga teacher, so definitely he does all these yoga positions, he does all the stretchings, and he had pain. He had tried physiotherapy, medications, and all conservative measures for last 2 years. So whenever the patient comes, my first question to them is, what have you done till now for your pain? That is the most important. We cannot offer them just by seeing the x-ray, there is a big bump, okay, you need surgery. No, that's not the right way. So what have you done till now? So they should have tried anti-inflammatory medications when there is pain. They should have tried high heel shoes to offload the tendoachilles. They should have tried gastroc stretching exercises. This is the most important thing. And around 60%, 70% of your patients will not need surgery once they do this. And we have many patients who have high Hagelund's bump in the back of the heel, but they are doing fine and walking fine. So once they have tried all this, still there is pain. So what's the pathogenesis? Why is the pain not going? So then you need to find out more. We have the X-ray. So what will be the next step? The next step is the MRI. If you have any questions, please note down. At the end of 15 minutes, we have a 5-minute time for discussion. You all can ask everyone at the various centers in India. Please do that. So next is the MRI. So sorry for the poor image, but this is the MRI. And if you visualize, do we have a pointer? Yeah. Yeah, so these are the sagittal sections. Now for Haglund's problem and for Achilles problem, this is the most important section. Axial coronal might not give you, it may give you some, but this is the most important. So you have to see the calcaneum bone, that's the calcaneum bone, and you have to see the tendoachilles outline. Usually you see a good black line of the tendoachilles, and whenever there is whitish thing, that means there is inflammation, there is fluid there, and there are some micro tears in it. So that gives the patient the pain. and that's how it goes. So for me, MRI is a must for every patient who goes under surgery, because we don't want to miss anything. We want to give them one surgery which lasts them lifetime. So always do your MRI. What if the MRI shows that the tendoachilles quality is not very good? You have to keep a plan B, which is FHL transfer, which my colleague Dr. Dennis will show in the next talk. So always have an MRI even if you are operating a simple Hagelund's bump. If you are not operating, then you can manage them conservatively, then MRI is not needed. So now going into the surgery. Okay, so we've done everything. We have decided we are operating on this patient. He wants to get pain relief. Another important thing before I go there, expectations of the patient. This patient was a yoga teacher. He tells me I want to do headstand at 3 months after my surgery. So you have to set the expectations right. I said, no, you cannot. You can do that only at 1 year. Uh, so setting expectations right is very important. Otherwise, your foot and ankle patients will always be unhappy. Okay, so going into the surgery. So this is the position which I give. Now, many of you all, this position is a new position which the patient is lying down. You can see he's lateral at the upper end. However, his feet becomes prone. So we are operating at the back. You will say put the patient prone, but the anesthetists are not happy. Many people don't have the spine board with them in their OTs. So this is called a recovery position. It is published in JBJS by Edward Daw and well utilized all across for foot and ankle surgeries. So this is a position which every one of us sleep. They sleep on the side and then they turn their pelvis in front so that the leg goes prone. So you put a tourniquet and then put the affected leg down. You don't turn lateral so that your affected leg is up. You turn them lateral so that your affected leg is down and tilt the pelvis slightly more. So automatically the foot becomes prone. Okay. Uh, So let's start and I'll speak while we go through. So that's the position, that's the most important. Keep everything ready, inventory, whatever you want, implants. Always keep back of the mind the FHL tendon if you all need. Once you find the disease tendoachilles is not good enough. Uh, so mark out the Hagelund's bump and your tendoachilles. Now there are two approaches. One is a midline approach, which I'm going to do. One is a paramedian approach. So it is important to see multiple surgeons whilst in your training, whoever young orthopedic graduates are here, and then select your choice, which will you do. So I've also seen surgeons who do a paramedian approach and reflect the tendoachilles from the medial side, not to go laterally, sural nerve is there, so from medially, or you go midline and split the tendoachilles. So careful soft tissue dissection, always important in this part of the foot where you are operating. Another important thing, he'll always see the skin condition, always see their diabetes status, always see their HbA1c. Do not rush into surgeries in these patients. HbA1c should be less than 7. Sugar should be well controlled. Thank you again, BOS and Dr. Gautam Zaveri, for giving us good AV who came to our operation theater and recorded this for us. And that's how we can see the video so beautifully. So thick flaps, you should not undermine the skin edges because that is your good layer which you will cover it. So once you start dissecting on both sides, you will start seeing the tendoachilles in your view. And you should always go down. You always have to go down. So never fear to extend your incision inferiorly because most of the bump is there. So I'll fast forward it a bit. So that's your exposure. Okay. So most of the time in pure Hagelund's bump, which this patient had, this tendoachilles, although on MRI it showed very inflamed, there was no calcification in it. If there was calcification, then you have to excise it. Then you lose some substance of the TA. Those are the situations when you keep your FHL on standby or keep a plantaris graft, which you can get there on standby. Uh, but in this case, the tendoachilles was not very bad, and we do a midline split there. Now it has to be a vertical split in one line, not to faff around with the fibers of tendoachilles. Clean 15 number blade, always change your blades often so that don't lose their sharpness. And then you try and reflect your tendoachilles from the calcaneum attachment on either sides. Now tendoachilles has a very broad attachment. Even if you reflect around 60% on either sides, you can see the whole Hagelund bump, and still your tendoachilles is attached on the extreme ends. So that's the advantage which we get with this tendon. So once you start periosteal elevator next, always subperiosteal dissection, try to keep as much of the fibers in view. Then I put a Homan's retractor on either sides so that the whole Hagelund bump is visible to you. Yeah. So now people often confuse between Hagelund bump and calcaneal spur. Whenever you see the X-ray, you see two things. One is the bump on the posterior superior aspect of calcaneum, and one is the small tiny spur, which patients point out that this is causing pain. That is not the one causing pain. The Hagelund bump is causing pain, not the small tiny spur. Even plantar calcaneal spur people have for plantar fasciitis. That never causes pain. That's a myth. The pain is caused by inflammation in the plantar fascia, not the spur itself. People say that I've come to you, I want to get the plantar spur excised. That's the surgery. That's never a surgery to be done. Okay, so this is the next video. Okay, so yeah, once you have exposed, use your electrocautery. Okay, cursor is going in between. Yeah, so this is the Hagelund bump, which we have started taking it out with the osteotome. You can use a thin saw if you want, but often these bones are very soft. Uh, and once you start taking out with a sharp osteotome, you will be able to do it very conveniently. I'm losing the cursor in between. So you should try and take it out till you see the good yellow cancellous bone. So this was a midline split, and you can see that the periphery of the tendon is still attached onto the calcaneum. Edges are very important, as you can see now in this step where I am cauterizing the edges, because always patient tells pain is on the side of the calcaneum on both sides. So everybody removes the center Hagelunds, but everyone forgets the edges. So you should take time and go on either sides to keep the both the edges and remove them as well. So we'll keep going on that. Again, nibbler osteotome, that's all what you need. No fancy instruments here and no complicated stuff. Taking out the edges as in this is important. So you need to spend time, not to be in hurry. There's a simple surgery, you'll say we'll finish it in 30 minutes, but spend time on this step. And always, if you take more bone, you are fine, not to worry. You have enough of calcaneum bone. One important point to remember here is not to go too far anteriorly, you will go into the subtalar joint. So often as you try and go, you will almost be able to see the talus and calcaneum and the subtalar joint there. So try and be at the back. Avoid avoid eroding the cartilage of subtalar joint. So again, I was not happy. Maybe I took a little bit more bone out. Because once you put your tendoachilles back, you should have a flat surface. Patient should not feel that the bump is still there. So try and take more as much as possible. So and close the TA and then feel with your thumb. It is easy to feel with the thumb. You shouldn't feel any prominence there. Do we have a timer? We are going. All right. So again, this video, yeah. So see this step, always close the skin, feel where you feel the bone is still palpable and go back and remove again. And see the tendoachilles is still intact. As you can see this test which I did right now, squeezing the calf, the ankle is moving. So that suggests that it has a broad attachment. So once you have done that, next is your job is done. You've removed the calcaneal, the Hagelund spur. Now you have to reattach the tendoachilles to as best as you can. You have created a defect there. Now you have to repair the defect. So that's just a image. So what I do now, there are many configurations available. People do 4 configurations, 2 knotted anchors, 2 anchors with threads, and 2 knotless anchors. We can do 1 and 1 if there is a budget constraint, but in a thin patient where the surface area is less. Or more often, I do this inverted triangle. So I use 2 knotted anchors through which threads come out, where I tie the tendoachilles, and then everything I put onto 1 knotless anchor. So there you go. So double loaded is good for me. You get 4 threads. You get a good layout of the fibers in the tendoachilles. You have to go up to the mark. So there you can see there are peak titanium bio available. I don't think all suture I haven't tried all suture anchor here yet. I've tried it in ATFL, just worrying about the strength of it in tendoachilles. This tendon needs a lot of strength, so your fixation should be strong. Uh, okay. So once you have all your 4 and 4, 8 threads, you have to start taking them through the tendon substance. Now, many people do their stitches differently. What I have been taught is like multiple locking stitches all the way across up and then come down. So around 3 or 4 locking stitches, which I do while going up, and then I come down. And you have to make sure that you space them equally so that you don't create bunches or knots in the substance. So you have to uh, start from the far edge, or you can start from the middle, and the second one you can take from the edge. So as you can see here, I'm going on the far lateral edge of the tendoachilles substance. Keep going up, keep locking it. Uh, Not all need to be locked. If you are thinking that it's creating too much of fibers on the substance, you can not lock so that it gets buried more in the tendon substance. So it is important to go sufficient length up, not just 1 or 2 stitches and come down and reattach it. You have to go up to give them the good mechanical strength. Yes, so this one had a small, very thin fiber tape. Yes, correct. So some anchors have fiber wires, some have fiber tapes. I think fiber tape gives a bit more thicker substance and a better hold. But of course, fiber wires work well as well. There is no data published as such that showing fiber tape is superior over fiber tape. Uh, it may, but as I said, if we bunch it up, then it creates, if we keep it well spaced in the substance, and what I do is make sure I pull both ends so that it gets deeply embedded in the tendon substance. So I don't feel much in that. Yeah, so that's how the configuration you should get after you've done that. And then you are ready to tie it down. So that's already tied down, I think. Uh, yeah. So there you go. You've tied the TA. Still, you will find that you have not tied it sufficiently enough. The tendon doesn't sit very well. So there where your knotless comes into picture, and that helps you to seat your TA completely down. So there is where your knotless goes in. Cursor गायब हो जाता है. हाँ. So this is an inverted triangle. That's the knotless anchor. If there is a big Hagelunds and a big calcaneum, you can use 2 knotless anchors. Sometimes 1 is sufficient enough. So this is just like a shoulder rotator cuff double row technique, which the general orthopedics you all must be more aware of. Uh, okay. So that's how it is. You can see the knotless anchor. Okay. Still, you can see that some fibers are off. So you have lots of threads with you. So take some bites and make sure you cover your knotless anchor in. And always do this test on table. You should be able to get a good plantar flexion after your repair. Okay. Yeah. So that's basically the surgery. Okay. Important points, never leave a bump high enough. Always feel with your thumbs. Always go for the corners. Midline split, I prefer more. There is another technique where you lift the tendon and remove the bump. Uh, and always use strong sutures. Never compromise on that, on the implant. Uh, and meticulous soft tissue handling. So once the closure is done, you can take an X-ray intraop as well if you want to remove the bump. Make sure that sufficient amount you have removed. And they go in a plaster. So after the surgery, all the patients where the tendoachilles has to heal properly go in a plaster for 6 weeks. 6 weeks you remove them, make sure that the tendon is working well, and you can start putting them on weight bearing. So we can, with such a robust repair, we can reduce that, and I've started reducing it to now 2 weeks to 4 weeks in some patients who are reasonable and whom you can trust on. You can remove the plaster. This is his, and always expectation. So this patient wanted to do a headstand, and in spite of telling no, he did it and came at 6 months. So he was a yoga teacher. He wanted the push of strength in his tendoachilles. So he is now already 6 to 7 months, but you have to inform them that till 1 year you cannot do that. Now if it ruptures, it's his fault. I have told him till 1 year he cannot do it. Okay, thank you.
Thank you, Dhrumin, for this wonderful presentation. Before I give an opportunity for questions, I'm going to ask my own question. And the question is, all of you saw Dhrumin press the calf and the ankle was moving. What is the name of that test? Anybody? Who said that? So that's it. Anybody out there in the audience? Let's have a show. Anybody in any
Thompson
of the
test.
other places has answered this question?
Thompson.
I'm Dr. Arjun from Indore.
Anybody? What is that test called? In Bombay, the answer has already come through.
Thompson test.
Sangli, what is this test called?
Thompson test.
Hello, Indore. Can you hear us?
Thompson test from Meerut.
Yes, tell me, what is it? What
Hello?
is the name of the test, Meerut?
Thompson test.
Yes, very good. So at over here in Bombay, Intas has been kind enough to give us some lovely chocolates over here. which we are giving. I hope the Intas rep in your place gives the moderator a chocolate and he can distribute it to the person who gives the right answer. So without much ado, let us ask questions to Dhrumin. The questions are open to the house. Let me start first by asking you, Dhrumin, which you mentioned beautifully, the selection of the patient is important. You should make sure diabetes is under control, the local skin condition is good. All that is wonderful. Now, when you're doing this operation, you showed those fancy suture anchors. All these suture anchors that you put in must have cost 30 to 40,000 rupees at the very least. Now, what about low cost surgery for this?
Uh, yeah. So, see, suture anchors, we have local companies available. They have good material. They might cost you a bit less. But for this surgery specific Hagelund excision and reattachment, you need the suture anchors. I wouldn't try and do low costing by decreasing my implant material and giving them less of a stronger hold, which we have done with this. Other than that, there are other surgeries, like we have a Zadek osteotomy, which we do for Hagelund's prominence, that uses 2 screws. So again, that is a technical challenging operation. You have to learn how to do that. That will cut down your cost, but that changes the surgery as well.
Abhishek, you being the co-convener and a senior person, lived your life in an era before suture anchors. What was done?
Not
that old. I agree partially with him. Uh, I think the technique is important. Once you have a raw surface where the tendon, actually the suture anchor doesn't heal the anchor, heal the repair. It is your osteointegration of the tendon. So we do use pull through sutures. It is more demanding, but it is technically possible. You may need to be more conservative in your post-op. Yes, if I use anchors like this, which most of us do, I might be more courageous to start early mobilization. But sometimes, as you know, we do cater to a wide socioeconomic strata where cost might be a constraint. And with, I think you can do pull through sutures. We've done that in the past. Yes.
So now, we've got the master who presented the case and a master above that. And we've got a grand master here now, Dr. Rajiv Shah, who is the president of the Ankle Foot Society of India, of Asia Pacific, everything. So he's going to possibly tell us about an era before all these suture anchors came in.
So thank you, Dr. Gautam, for the kind introduction. So in the 2020 Foot and Ankle Clinics of North America, I was invited to write that what do you do if you do not have these fancy toys? And we have been doing this in the absence of these fancy toys also. So there are 2 ways you can do it without anchors. The one is you can take a vertical parallel sutures which goes through the bone. Take in a 2 mm K wire, pass it vertically under image control and come out anteriorly. The similar way the other one, and then you can pass the sutures through the calcaneus vertically. And the other method is a horizontal sutures, where you anchor the tendoachilles with an horizontal suture. The proximal horizontal suture will again give a 90-degree insertion over the bone to the tendoachilles. And for the edges which you want to sit over the bone, you can take a simple, vicarial OS needle and then take a small bite through the bone and you can tie it. So that's possible. That's possible.
Another question I had, Dhrumin, was that you told us how you decide the end point of removal of the Hagelund. Where do you decide to take your first cut with the osteotomy? Which is the point on the calcaneum posterior aspect where you start doing your osteotomy?
Yeah, so I don't have the image, but y'all should see, for that, for young people to start, y'all should always go on internet, see the images of Hagelund before, after. And when you start your surgery, put a K-wire. Put a K-wire where above the K-wire you all are going to resect your Hagelund, and make sure you mimic that. So it should be a generous quantity of Hagelund bump removal, and you should see the yellow cancellous bone that is there. But to begin beginners, I did that. I always passed a K-wire in the beginning to see how much bump I'm removing, then take my osteotome and remove that. And then after, as I said, closing the skin, feeling with your thumb, that's important.
Any questions from the audience over here? Yeah, Prasad.
From Moonot, I have a question, sir.
Yeah, go ahead.
Sir?
Yeah, please go ahead, ask.
So,
Dr.
can I
Gautam,
ask?
to ask, what is the chance of recurrence of this deformity after you have taken out the bump, and how do you prevent it?
Yeah, so good question. So there is cancellous surface bone. People always ask this question. Yes, true. Will my bump recur? But what we have seen in practice, that once you remove that big bump, it's a cortical bone and you have cancellous bone beneath. And once your tendon, you stick it back through and through to that bone, there is no space for that bone to grow. So no, it does not recur. That's what I have seen. Yeah.
Sir, does type 1 collagen help in healing of the repaired tendoachilles? Do you prescribe it post-operatively?
Type 1 collagen. Okay, so I don't prescribe it personally. I don't know there are any papers. I'll leave that question to the seniors.
Practice, do you use type 1 collagen for tendinopathies, for tendon healings, for tennis elbow, for insertional
So
tendon?
for conservative management, yes, initially, when they come in the initial phases, we do use them along with anti-inflammatories. But what level 1 evidence we have, I'm not sure of that.
Sir, we are from Hyderabad. One question, sir. Any chance of tendoachilles avulsion? Because there's tendoachilles will become weak after 3 months of rehabilitation. If the patient goes for any eccentric activities like playing squash or table tennis or long tennis, there is any chance of rupture of the tendoachilles avulsion after this repair?
Yes, so there is, and we get patients who have, after the repair, they have a rupture. And that's because, number one, the expectations are not set right from the beginning of the surgery. Number two, the repair. So you need a strong repair. You need 2 anchors. You need a knotless so that you get a broad surface of tendon to bone attachment, and patient selection where the metabolic levels of the patient are good, diabetes is under control. If you select all that, you will have less of that. If you don't, then that can happen. Yes.
I like to add on that.
Hmm.
There is one more point, and that is inadequate resection of the diseased tendon. So the tendon ruptures at the diseased tendon site, not at a good tendon site, and diseased tendon will not osteointegrate also. So you should be old enough to have a proper evaluation on your MRI, how much of the tendon is degenerate, and you should take out all that degenerate tendon as Dhrumin showed in his video. And that's very important. If your degeneration is more than 2.53 or 3.5 centimeters, please do not be afraid to do a tendon transfer, what we'll show in the next talk. And that's very important.
Sir, calling from Indore. Yeah.
Can
Dr.
I
Dhrumin,
just
for
add
the
on
very
to
good
this?
presentation. We have a question for you from Indore. There are 2 or 3 things. Dr. Alok from Indore. Rajiv Shah, good morning. And all Pradeep and everybody. I hope you can hear us.
Yes, yes. Go ahead.
Yeah. So one thing, Abhishek, were you talking about tendinopathy or Hagelund to you just now since you replied about that? That is one question to you. Second to Dhrumin, you keep them non-weight bearing for what length of time?
6 weeks.
Now, do you think there is any added advantage of allowing them to bear weight immediately post-op using a customized high heel while the limb is in equinus? Means the weight transfer will be equal, but the chances of fibroblasts getting converted into tenocytes are much more higher if the tendon is loaded immediately post-op. That's my
Yes, so
question.
absolutely. You can do that if your repair is strong enough and you are
Yep.
confident you've done enough number of cases. I think that's not a bad idea. After 2 to 3 weeks or 4 weeks, you can give them wedges in the ankle boot or a high shoe, as you said, and ask them to weight bear. Yes.
Sir, from Hyderabad, do you able, sir, in the post-op period, and how long you will keep? With the plaster or anything.
Sir, we lost you. Can you repeat your question?
Sir, post-op.
No, your connectivity seems to be a little bit of a problem. I can't hear you at all.
Sir, one question from Jodhpur.
Yes, please go on, Jodhpur.
Sir, what is the role of ZX osteotomy in this case, or any indication or contraindication of ZX osteotomy? Please suggest.
So for me, Zadek osteotomy is where the length of the calcaneum is long. There are ratios available. There is a paper on it, which we have to calculate. And we have to believe in the concept. So it is shortening the tendoachilles, shortening your lever arm, and offloading the bump where you do not touch the bump. So that is an alternative which is coming up now. We have to do more cases. I think Dr. Rajiv Sir has done quite a few, and he is a better person to tell us about that.
Dhrumin.
One question from Badwan.
Just a minute, let me answer the question. Yeah, ZX osteotomy is a dorsal closed wedge osteotomy. And the modification of ZX is where you also remove the Hagelund and you do the dorsal closed wedge osteotomy. This does not touch tendon at all. And that is the very important thing. The worrisome part of Dhrumin's presentation, which I felt, was lot of foreign material. I have seen Van Dyck Van using only absorbable sutures, not non-absorbable. And I have seen and experienced so many number of cases where there is no infection, but it is the degeneration into the tendon because of lot of suture material. So try and avoid or reduce your suture materials. Practically speaking, I have switched to the ZX osteotomy. And it is not that angle also. It is not that cavus which you are correcting into planus and doing the ZX osteotomy. But it is a belief and biomechanically now proved that the all degeneration into the tendon is because of the pressure by the Hagelund. And now I have 2 or 3 cases where I've got a post-op MRI and I've shown that the degeneration gets lost. So that is where nobody knows that how much time this open surgery patient would take to recover. It's variable. They may take 6 months, they may take 9 months, 8 months. And aseptic degeneration of the tendon, wherever you pass the suture, is a big, big issue. And that is where whole world is shifting onto ZX osteotomy. You can do it open also. If you're not a minimally invasive percutaneous surgery, you can do it open also. I started doing it open. And then I switched on to MIS once the MIS was available. The one important point which I wanted to, tell to all general orthopedic surgeons, how do you know that this is a bad tendon? How do you know that this is a good tendon? So not only MRI, on table you don't have MRI. An MRI is a magnified imaging of what you see. So on table, the tendon which looks dull, tendon which looks grayish, tendon which on palpation is thicker, tendon which on cutting the knife doesn't cut like you're cutting a butter. It feels very, very hard. Is bad tendon. Be on the side of removing more tendon than less tendon. And still, if you are in doubt, remove the tunicate. The one which is profusely, nicely bleeding is a good tendon. So that is what is important. Can I add one more point? When you do your skin incision, make sure that you don't separate sheath from the skin. All problems of the skin issues are because of 2 reasons. One, short incision. Go as deep as possible. Go as long as possible. And don't separate skin from the sheath. Because when you close the sheath, skin automatically falls back. And you also use a pull out suture. The sutures which you pass, which are absorbable suture, and one assistant would pull it, and then you do your repair. That makes your life easy.
Hello, one question.
Is there any patient whom you would refuse to do a Hagelund spur excision? Is there any absolute contraindication?
So patient who I'm see first time in the clinic who has not tried anything, just comes with a bump and pain for 1 week is a contraindication for me. He has to go through stretching exercises, medication, physiotherapy before he says, yeah, he's ready for surgery.
But is there any pathological contraindication? Oh, the tendon is too far badly involved, or the bump is too anterior, too posterior,
No,
something like that?
No, we have things available. We have next stock like FHL transfer available. So not particular with that.
Can I quickly? Yes, while somebody has a question to ask, can I ask Abhishek to set up his
Sometimes it is seen that after operation, there is suture prominence through the skin. And how we can prevent this troublesome complication of the patient? Patient comes to
that's a very good question, sir.
Yeah, very good question. So as Rajiv sir said, minimum number of sutures, try and use. Make sure you bury the knot. So when you tighten the stitch, make sure you tighten it in a fashion that you bury it. And then again, a knotless will try and bury it more. So keep as much soft tissue over your knots as much as possible. Then you'll not have that problem.
Lovely. Prasad, you had a question?
Dhrumil?
Yeah.
Hello. Am I audible?
Actually covered in most of the questions. So my question was about this. Most of the Hagelunds usually have tendinopathy, and we remove whatever we see with the naked eye, which is usually the crab meat appearance. So at what time do we decide that we require an augmentation for this particular thing? How much after removal, whether we can still repair it or we require to augment it?
Yeah, so for me, I would say if you remove the tendoachilles insertion quite a lot, that there is a gap left in neutral resting position. There is a gap between the tendon and the bone, or in at least 20 to 30 degree of plantar flexion would be the maximum where you can do and close the gap. If beyond that you need to plantar flex, then I would be hesitant and I would likely take an FHL tendon if it goes more than 30 degree, because patient is eventually going to stretch out and you don't need to wrap it off. So you need an additional tendon there.
Thank you very much, Dhrumin. I think last question from Dr. Karkar.
Yeah.
We stop after this.
Yeah. That Hagelund deformity that is there is many a time genetic, I think. And you find that it is like a bull horn or like a crab meat. So why you have to go right down what you showed? You can just excise that, retract the tendon, excise that part which is the Hagelund. It's not tendoachilles tendinosis. So why you have to do that, what you showed?
No, so to get the plane of the Hagelund resection, Hagelund is the big top, but you have to remove a triangular bone of wedge. So for that, you have to go deep down so that your osteotome starts from that level and goes up. That is the only thing. If you just take it down from them, patient will still feel the bony bump. If you take it in this fashion, then the tendon closes it nicely and the tendinopathy doesn't recur.
Right. Thank you very much, Dhrumin, for a wonderful presentation. Abhishek is just going to add a little bit to this presentation.
I'll just take that question, sir. Sir's question. I think sir asked about when the tendon is good, why touch the tendon? Correct, sir, and only remove the bump.
Yeah, only the Hagelund part,
So
which is genetic actually.
Hagelund syndrome has three components. One is that Hagelund's bump, one is the tendoachilles insertional tendinosis, and the retrocalcaneal bursitis. So when all three come in, it becomes a Hagelund syndrome. What I think your question was only the Hagelund's bump when the tendon is good and there is no, if there is plus or minus bursitis. Correct, sir? So when the tendon is good, one should not touch the tendon and one should do only a calcaneoplasty. We can do an endoscopic calcaneoplasty or open calcaneoplasty as you're doing it. Or we can do an MIS calcaneoplasty nowadays. If the tendon is degenerate, then we need to do this. So this surgery was for a Hagelund syndrome, which has all the three components. One is the tendon, one is the retrocalcaneal bursitis and the bump. So all three are addressed in this. So you have to do a total job in this case. But maybe in only the bumpectomy or only a calcaneoplasty can be done. I'll be quick on this. We were discussing about not so affordable one. So this is what sir said, make sure that the skin and the paratenon is elevated in one flap itself and not to do too many layers. It's a midline split. And where, you take out, see, this is the degenerate tendon where what sir said, the yellow part and as part the white part, you take out all the degeneration, take out the bump, make sure that you take out the bursa also. So this is what it was. Then this is the transosseous sutures that we've done. It's a vertical line. Make sure that you always hydrate the flaps. Take bites, close the tendon. Make sure that it's coming down onto the thing. This is a transosseous bite. So I think this is how even in rotator cuffs, there are transosseous repairs which are described. But I completely agree with Dhrumin where, this is a weight bearing tendon, much more stronger, as good as the bone. So it's important that you give him stability and you have your own courage to kind of make sure. So this is how it can be done using transosseous sutures.
But is it as strong as what Dhrumin had showed?
So
Your suture just into the heel.
It is a compromise. It's not as strong as this, but then you barter it with longer immobilization. So in this case, again, where my tendon degeneration was not that bad, the angle at which I got it was gravity assisted, I was okay to do it. At times where you have to really get it like plantar flex and get it, it might not be where it will still stretch out, where you need those. But again, my whole point is you need biology. Only putting stronger anchors is not equal to, or on Sir's spine, or like olden days, there were only heart shields or SS wires and they could still correct a scoli. Now there are gadgets which don't do, but the key is preparation. Unless you have bone preparation, the union is not formed. Or in trauma surgery, you may have the best locking plates, best companies. It will still fail if you don't address biology. Here, the biology should be addressed. The tendon degeneration should be taken care of. The bump should be taken out. The bursa should be taken out. And then the way we fix it is only a mode to get the tendon back reattached. That's osteointegration of the tendon into that. So this is one of the techniques where we can do it using transosseous sutures the way they do it in rotator cuff or how it used to be done before.
Lovely, Abhishek. Thank you very much. Before we move on to the next case, any last minute questions before we move on? So I think, yes, we have a question from Dr. Saraf.
Hello. I'm Dr. Saraf from Bihar. In which position plaster should be done? In which position plaster should be done? It should be above knee or below knee, in neutral position or in cornice position. Which position plaster should be done?
Dhrumin?
So I would plaster a below knee in a plantar flex position, because when you do the repair, you are always a bit tight and your foot is in plantar flex around 20 to 30 degree, not more than that. But a below knee. Now the concept of above knee plaster has gone in tendoachilles. We never do that. Even in TA tears, we are giving walker boot and weight bearing. So below knee.
Lovely. So thank you very much for the question, Dr. Saraf. Just to recapitulate what Dhrumin has shown us, he has shown us a Hagelund spur excision in a patient. So as has been very clearly advised by Abhishek, that the Hagelund spur thing has three components. There is a bump, there is a bursa, and there is an insertional tendoachilles arthropathy. And you have to deal with all these three problems when you deal with a patient who has, for whom you are treating him for this problem. The initial treatment is always conservative, a good trial of conservative treatment, at least for 3 to 4 months, which includes, again, Abhishek, Abhishek, what is your conservative treatment regime? For some people want to know that. Okay, what is the conservative treatment regime? How long does it go on?
So I think while you're counseling the patient for conservative line of treatment, I think it's important that you counsel them for demand and expectation reality mismatch or match. So someone who's active and is not improving at 6 weeks, 3 months, we would offer them some intervention. And conservative treatment would be wearing high-heeled footwear where you will offload that pressure on the tendoachilles insertion. You would also start a lot of tendoachilles stretching, eccentric loading programs. You can add pharmaceuticals to it using various types of collagen which are there. But primarily good rehab where you increase the loading of the tendoachilles by eccentric loading programs and stretching, and heeled footwear while doing some intense activities.
And any role for steroids into the retrocalcaneal bursa?
So again, a big gray area. When the tendon is degenerate, you should not give steroids because steroid causes more tendon degeneration, causes ruptures, or it gives you a blanket of only no pain, but actually the degeneration is progressing inside. Carefully, when the tendon is good, paratenon is well covered, or the tendon is well covered by the paratenon, and if it's only a bursitis problem, anterior, a bit more than what we would give, you can try steroids, but that's only for the bursitis component. But you should always counsel them in diabetics, and there is a high chance of rupture. So I've never given steroids near tendoachilles. You can
May I
try
ask
other.
one last question, sir?
Yes, please go ahead.
Abhishek, you show us phenomenal transosseous suture. So now my question to all of you, because you, Abhishek, only mentioned that you will delay the weight bearing once you have put in a transosseous suture. Now my question is, a perpendicular repair which we achieve by putting the anchors in the bone and then wrapping the tendon around the bone. That is a perpendicular repair. You agree? Means the anchors are in the bone, the sutures are coming out of the bone, and 90-degree almost we are repairing the whole thing. So that's a perpendicular repairing. While an end to end axial repairing is means when you have put in a transosseous suture from capillary to chordal and then you repair it. So which repair will have more strength?
So, so it's a good biomechanical question. So if I would like to take evidence from the shoulder and bring it down to the heel, the best angle at which tendon bone pull out is called the dead man's angle. It's at 45 degrees. So how does the dead man angle come into picture is by Dr. John Warner from US, who's a shoulder surgeon, who showed, or rather his thing is like, if you see the cross in the symmetry, it is put at 45 degrees support. That 45 degree support holds the cross up in the symmetry, even in the most strongest of storms. So that 45 degrees where the pull of the tendon and the anchor placement is important. And that's why if you look at shoulder surgeries or even tendoachilles insertional surgeries, or what Dhrumin showed, the angle at which he was placing the anchor was 45 degrees. So ideal is 45 degrees. Try and be as close to it. That's the angle of, it's called the dead man's angle, and that is the strongest angle which is proven in biomechanics of bone tendon integration.
Thank you. I think this
Very much.
comprehensively covers the topic of Hagelund's spur excision. We move on to the next talk, and I'm going to request Dr. Pascal Denise, who is going to talk about similar thing, insertional tendinopathy, but with excision of part and then repair or reconstruction using an FHL tendon. Yeah.
So good morning, and it's great to be here on a Sunday, especially in front of such great faculty today. Dr. Rajiv Shah is here, Dr. Abhishek is here, Dhrumin is here, Samarth is here, Sab hai, and Sir is also here. So we're going to talk about straightforward regarding the case. So I think everyone has spoken about tendoachilles repair and putting in the suture material, etc. And then what happens if all goes well? It's great. But now what happens in this situation? So like I said, I was trained by Dr. Rajiv Shah, so I do debride the tendon, wait for it to bleed. But what happens is that as a younger surgeon, you want it to really bleed. So you end up debriding, but then you realize you've got to pull it down quite a lot. And then what happens is that you can fix it intra-op. But then what happens is the skin complications post-op. So then you've got to get a plastic surgeon involved, or if you put too much of suture material, there's a lot of problems. And obviously you don't change the way you do surgery. You say tendoachilles is the original, let me fix the tendoachilles back inside to the bone over there, because that is the biological best way. Something is torn, just fix it. You will only change your surgery like when I changed my surgery, is that because when I have a complication and that one patient keeps coming back to you and says that, look, what's, you've given me this and now I've got to go to a plastic surgeon and there's so much more expense involved. So you need to think forward, especially in today's day and age. Whenever you see a patient, you need to plan. So I always add TA repair plus minus FHL transfer, because FHL is my bailout surgery. It is never my primary surgery except for a few indications of patients. So I think this is something which you have to keep in mind. What are your indications? Because you need to take this consent beforehand. If you've got an MRI done beforehand, you know the quality of the tendon, you know how much is the retraction, you know how much of fatty infiltration is there. So you can plan beforehand for an FHL tendon transfer directly. But if like what Dr. Dhrumin said, or like what Dr. Rajiv Shah said, that when you're debriding on table and you find that, hey, this is going to be a big problem, I might have to do a VY plasty or I have to do an FHL. So obviously, if you do not learn, I mean, the idea about this is to understand FHL should be your secondary surgery, and there are few indications for directly FHL transfer. Okay, so what are my usual indications? So if a patient comes to you and it's a chronic tear, say about 6 weeks time, I know that I'm going to have to pull. So even as far as pulling in the tendon is concerned, my retraction on my skin margins is higher. So therefore, there is a higher chance of skin necrosis. The second thing is that tendon quality. If it's a Hagelund's bump, like what Dr. Dhrumin has spoken about, you know that, okay, fine, the insertion, you will see the Hagelund's bump, but you'll see huge amount of calcification. In this scenario over here, I have to remove the Hagelund's bump and I also have to remove the calcification. So what is remaining of that tendon over there is a mere skeleton of what it should be. So does it make sense in fixing that same debrided tendon back to the bone? Will the patient still have pain? Will they come back over there or will it re-tear? You need to think about cost constraints also. In some patients say that if I'm going to put a couple of anchors in over there, and our main villain in all of this is that suture material, because this is a very subcutaneous area. So suture material has caused problems for tendoachilles patients. So plan in advance and understand that if I'm doing a Hagelund's, I have to keep this as a backup. Second thing is, I think sir has spoken about steroids. Is there any role for steroids? We all say there is no role for steroids. But what happens is that ultimately a lot of patients get this injection. So if you speak to MSK radiologists, they say if you inject in the bursa shrinks, etc., and you can give it in that area. But the point is that a lot of times, if this patient has got chronic pain and you inject it into the steroid, like what Dr. Abhishek mentioned over here, it will just rip off. So what happens is that that same quality is torn because it's of poor tendon, right? So you need to debride that again and then reinsert it. It might not come, so plan for an FHL transfer again. Skin issues. If somebody is a high diabetic or is a high smoker, you are going to have skin problems. So you have to get in and get out as soon as possible. Otherwise, you're going to have a skin healing issue problem. So you plan basically for failure. So this is how I would plan my FHL tendon transfer, is that, I am going to plan this in case I cannot do my TA repair. Last is also the demand of the patient. If it is, say, a very elderly male, female, and when I say elderly, I mean 75 plus or so like that, who doesn't have a higher demand, it doesn't make sense to go on, repair the tendon, keep the patient non-weight bearing, because it's difficult in the post-op period. So I do an FHL transfer and get my weight bearing going much faster. Okay. So this is a typical case scenario, what we would see, okay, in an insertional tech. A 60 to 70-year-old male or female like that, they would have, this patient had pain since the last 1 year. He's taken one steroid injection, is what he says. He's taken another injection. He doesn't know whether it's PRP or steroid. He had severe pain and then he's developed a much worse limp 2 weeks post the injection. Okay, so if you can see his MRI, you can clearly see that tendoachilles is quite well proximally migrated and it's nice and clumped up like that. So what you need to understand in this scenario is that look at the distance. You can see distally there is a small flap of tissue, but it's very poor tissue. So does it make sense to go in and repair these two things? And also when you look at the proximal tissue, there's a lot of edema, there is fatty necrosis into it. So should we be repairing this? Okay, and this patient has come 6 months post the rupture, just walking in and says, look, I have a defect and my main complaint is limp and I'm not able to walk quick enough. There's no complaint of pain in this scenario. So what, then I say, okay, look, I'm going to do it, but most likely I'm going to do an FHL transfer. And in my mind, I know 80% to 90% I'm doing an FHL transfer for this particular patient. So first thing is that you need to check for the FHL integrity before you can put this patient on table. It doesn't mean like, because there is a rare case of the FHL could be ruptured. So you need to know how to check the FHL. It's very simple. Ask the patient. He doesn't need to flex his toe, the great toe. He has to flex the IP joint of his great toe to understand whether the FHL is working. You can palpate it also at the same time and you ask the patient to flex it. Obviously, if you're doing a tendon transfer, it should be minimum 4/5 power. Okay, because it is going to drop one level when you transfer it. So I will be putting the patient in prone position, and I'll tell you why. Like Dhrumin has said that you can do it in floppy lateral, you can. And then at the same time, he said because the anesthetists don't like prone position. In my defense, the anesthetist doesn't handle the patient post-op, so I will require what is easiest for me to get the best view. So the anesthetist has to cope with what I am asking for. Because how I do prone position is a little bit different, and I'll show you how to do that. Ruben has spoken about a central incision, midline incision. I don't do that. I do a paramedian incision because I'm always planning for failure, right? And also, if I'm doing a paramedian incision, my approach to the FHL is much more easier because it's on the medial aspect like that. And in case the suture material causes skin necrosis, if my skin breaks down, it's breaking down on the medial side and not on the central side, exposing my tendon. The angle of incision. So I don't put a direct 90-degree angle. I put the blade at around 45 degrees. So I have two equal flaps on either side. Because in the tendoachilles, if you go directly down at 90 degrees or you go vertical to that incision, you'll have one flap which is slightly thicker than the other one. So go at 45 degrees. Okay. Now talking about, I think sir has asked regarding the Thompson's test. So this is the uninjured limb. This is the injured limb. When you're doing a Thompson's test, very simple. You need to press the gastroc, not the soleus. This is the non-injured limb. So when you see that Tushar is pressing the gastroc away, there's good continuity, right? So this is my position, my prone position, which I'm talking about. I always have a bolster, and there is a reason for everything what we're doing. And in every picture, you need to see why we are doing this. So I keep my patient in prone position. This is a left-sided tendoachilles rupture. So you can see that there's a side support on my left side over there. You can also see there's a bolster flexing the flexing the knee over there. So if I flex my knee, my gastroc is released. It helps me pulls it down a little bit closer to the TA like that. And if I give a side support on left, that is because I tilt my table by about 15 degrees to the left, or in this case, onto the operator side down. So that when I'm putting my incision, I'm going at 45 degrees to that. So these things is that before you do a surgery, you should get your positioning right and you should know where your C-arm is going to come so that there is no problem during surgery. Okay. So this is my incision. Like I said, it's different from what was explained before. It's a paramedian incision. I do put the incision paramedian, but when I come to the distal stump, it goes more central like that because in case I have to remove the Hagelund over there, I can remove the Hagelund much easier rather than pulling my skin and going in for necrosis, right? So now you do an open incision. So I do my FHL transfers open. So you can see over here, this is the patient over there who had a chronic Hagelund's. So usually what you see that there is the tear in that scenario. And I don't think you can hear it because I put the sound off. But when I'm tapping on that patient's proximal stump there, there's a huge calcification. So this is a very common scenario what we all see. So obviously in this scenario, we can't just remove the calcification and pull that empty shell of the tendon down over there because it makes no sense, right? So, and even if we do it, then we'll have to do a proximal gastroc release to get it right down all the way. So this is one scenario. This is the other scenario. This is the patient which I have spoken about where he has taken the steroid injection. So if you can look at it as proximal and as distal stump, it's basically shattered. So if you have a proximal and distal stump shattered over there, you know that this is not going to be a good tendon. We're going to use a lot of suture material and you could have complications in the end. Okay. So now we've decided on table, or rather before the surgery itself, that I am going to do a flexor hallucis longus transfer. So in this scenario, it's very simple because the tendon is right there. All you have to do is so you have your tendoachilles, then you go medially, make an incision over the fascia between the two muscles, and you get exposure over the tendon, over the muscle body rather. And I would always go from proximal to distal because when you notice that, I'm going to press this video now, what you can see is that the tendon and the muscle joining together, the musculotendinous junction basically. So you know that what you're harvesting is the tendon and not the posterior tibial nerve, right? Because there are a lot of scenarios where you can end up pulling out the nerve like that and then you'll end up in more trouble. So this is extremely vital that you see the musculotendinous junction. So we can see it in this video here. So can you see the musculotendinous junction? And at the same time, it's a prone, and you can see I'm moving the great toe with my hand. So you can see the musculotendinous junction, and you know that you are isolating the tendon. So trace from this portion and go more distally, right? Because if you go more distally, you can see that, see when I'm moving the toe up and down, you can see this is your tendon which you're isolating. And it's not like it doesn't happen to people. There have been situations when I'm looking and I'm saying this is the tendon for sure, but it ends up being the nerve. So obviously you need to be very careful, right? So see the musculotendinous junction. Just don't go in a hurry, like you said, 30-minute surgery, fatafat, and then end up stitching the nerve over there. And it can happen. So this is another patient where we can see the musculotendinous junction very well. So you've isolated your tendon now, right? So let's move to the next slide. And in this next slide, how do you do it? How do you isolate that tendon, right? So when you're isolating the tendon, now you said confirm this is the FHL tendon. You can do a loop stitch around it. You can flex the great toe as much as possible. Plantar flex the ankle so you get maximum length like that. Give it a good pull with the mixture and then cut it off, right? It's kind of simple like that. And it's out like that. And this tendon is in the same vicinity and the excursion is almost the same. So that helps us in the final benefit. So now either you can stitch this tendon directly into the bone, right? Because then it forms basically like a biological splint, and then repair the original tendon with simple vical sutures over it, just so that, it acts as like biological strut like that. Or if you want a better calf strength or get better push-off strength, what we do is something known as a pulvar shaft, where we take the FHL and then go through the distal sum of the tendoachilles and then fix it into it, right? So you can obviously do a simple whip stitch if you're going to be using an interference screw, or you can even do a pull through like what I think Dr. Abhishek has also described if the patient doesn't have too much money. Sorry. So either you can, and sorry, before I mention this is that if the patient has got a Hagelund's, it's always better to excise that Hagelund's over there so you get a raw surface. Because if you get a raw surface over there for the tendon to go into the bone over there, your healing rate is much better. So at this point, I would use a saw and remove the Hagelund's, or you can use an osteotome also and remove the Hagelund's. So if you look at it, I'm just tapping on that area, and this is my FHL in the same vicinity. So either you can directly put your FHL into that, or you can do what I do in this scenario. Sorry, this video is upside down, where you make a hole through the distal stump of the tendoachilles and then just pass the tendon through it with a simple pulvar shaft mechanism like that. So in that scenario, you can get a nice, good push-up strength. So in this last video, what you can see is I've taken it through the proximal stump of the tendoachilles, and I'm going to just fix this FHL directly into the bone over here. Simple and straightforward. I'll show you at the end the difference between, we'll do a Thompson test on both these, the difference between the two fixations, and then you can decide which one is better for you. Okay, so how do you place it? I use an interference screw. You can use a biological peak screw like that. Biotech has got it, Arthrex has got it. Either you can use a 5, 6, 7 by 23 one. The direction, I think he also spoke about. So biomechanically, if you go at around 45 degrees, so the direction of your guide wire should be, can you see to where the plantar fascia to that medial process is over there, is in that direction is what you need to go at. Right? So then you ream, you don't have to ream all the way through and through. Otherwise, you'll end up rupturing the patient's plantar fascia. That's not what we want. And then fairly simple is you can use your tendoachilles screw over here in this scenario. I think it's the next image. So how do you fix it? So again, you're doing a pull through of the FHL. You need to have some amount of plantar flexion going on because we don't want to lax FHL. And then you put the biotendoachilles screw. So you notice when I'm initially putting the screw in, my assistant is not holding it. So remember, you've gone at 45 degrees in, so your pull has to be at 45 degrees in the same direction of the tunnel. And you have to give a good amount of plantar flexion so that our FHL, which is going in, is also tight and not lax. Because at the end of the day, you want a good FHL, which is nice and tight, that will give you a better push off, right? So, and in this next video, what we can see is that okay, so you can see that's a good muscle belly and the FHL tendon is going into the calcaneum. So like I said, either you can do an FHL direct transfer to the calcaneum, or you can do a pulvotraf through the distal stump of the tendoachilles. So when we do it, just to be fair, these are two different patients, but you can see that in this scenario, when I'm doing it, I am putting some pressure, and you can see, okay, fine, there is continuity over there. But when we look at this next video, so this is a patient who's got an FHL direct transfer to the calcaneum. So you do have continuity, but you know that the tension in that muscle isn't that great. So when we go to the next video, so this is, I'm not even giving resistance to the tendoachilles, but this is your FHL, which has gone through the tendoachilles, and I'm doing the Thompson test again by just pressing the gas stroke. And now when you look at the Thompson test, you can look at that power over there. So I think it's always better to incorporate the original the original tendoachilles to get a better cast strength. And you might say that this guy is talking about the previous surgeon and saying he's put suture material there, but even he's got suture material over the whip stitch over there. So original, whatever stump you have of the tendoachilles, you use Vicryl to cover that so that your foreign or your foreign suture material is not coming intact with the skin. Last side is my post-op protocol. Why do I decide to do FHL transfer in a more elderly patient is because I want to mobilize the patient as soon as possible. There are some people like Dr. Nasser, I think, who is a pioneer for the FHL transfer in Egypt. And he says that he's using it as an internal brace, biological brace. So he mobilizes patients from day one they're walking. Of course, I'm not as aggressive. I still keep the patients non-weight bearing for the first 2 weeks, but hip and knee strengthening, continuous weight bearing with wedges over the next 4 weeks, and then gradually removing the wedges. Okay. So the thing is that it's acting like a good biological start if you repair the original TA over that with simple sutures just to act as a protection against your skin. And your mobilization is much faster. You don't have to worry about this tendon re-tearing, etc. And your surgical time is also lesser. So skin complications in general are a little bit lesser in this scenario. So I think it's a great surgery. And like I said, it should not be, a lot of times people are doing tendoachilles repairs plus FHL transfers. If you're doing a primary TA repair, I think that's what you should go on, because this should be your backup surgery if there is a complication and failure, right? Or in those patients where you think that I need to get in and out, or the tendoachilles is a poor quality beforehand. So take home message is that everybody should know how to do the FHL transfer. It's pretty simple and straightforward, but use it only when you know that you are going to most likely have complications. Otherwise, an original tendoachilles is much better than any FHL, no matter what they publish in the West or whatever it is like that, but I would still do an original TA repair. The only one complication is what is that you can still flex your great toe, but you can only flex it at the MTPA joint. You cannot do flexion at the IPJ joint, right? So that is important to tell your patients beforehand, because very few patients complain about it. But I have had a patient which says that I cannot flex my IPJ joint post the surgery like that. And that's also another doctor, but it's important that you explain these things to your patient beforehand. Thank you.
Thank you, Pascal. That was fantastic. I open the immediately. I think a lot of the discussion on the spur, the tendinopathy, etc., has already happened. And therefore, that part of it, we will close down. We will not take questions on that. But we will take questions on the specific tendon transfer that he does. So, any questions on that? Yeah,
Can you
please go on.
elaborate? Yeah.
Hello.
Hi. Your take on the long versus short harvest of the FHL, Dr. Kuldeep Gadkari.
Yes, sir. So the short FHL, basically your FHL is just adjacent to the tendoachilles. It's a single incision. We are using this tendon transfer as an in-phase tendon transfer, and the excursion is the same when we put it into the tendoachilles. So in this scenario, with a single incision, you don't need to harvest the tendon from the knot of Henry side. That's a long tendon transfer. In those situations, previously, when you would like to go through the calcaneum and then stitch the FHL amongst itself, that is when we would do a long FHL transfer. But biomechanically, right, ultimately, we want to mimic what the TA was. So you will get a much better push-off strength if you do a short FHL transfer directly. And it's a single incision. You don't have to incise it from there. And the tendon is right there. So I would not do a long FHL transfer. As far as I'm sorry, I forgot to mention, but obviously you can do this endoscopically also. So I think Dr. Abhishek Kini does a lot of the endoscopy FHL transfer works, and probably he can speak about the later.
Right. Any other questions over here before I open it up online? Anybody, any questions from across India?
Sir,
On the FHL transfer, very elegantly shown by Dr. Pascal.
Can I ask?
Sugata Reddy has asked one question, sir. Can you try plasty before attempting FHL? In which conditions you can do a lengthening of the tendoachilles by vulvoplasty instead of FHL transfer? Anything, sir?
Can you do a tendoachilles lengthening?
Yeah. So I think in 2018, so when I learned with Dr. Rajiv Shah, we used to do a lot of VY-plasties like that. But
for this indication,
for chronic tendoachilles tears, etc. But like I said, when you have a bad experience and then you realize, okay, if this patient is on table for a longer period of time, I've had a 135 kg lady who couldn't fit into the MRI machine, and then we just did the repair. So what happens is that you will be able to pull it down with a VY plasty also, but your skin necrosis chance is much higher. Right. So in this scenario, if I'm thinking I'm going to have a complication with this patient beforehand, an FHL transfer will give you as good as results. But like I said, if you're managing a gap, say maybe of about 5 centimeters, something, 100% do a VY plasty like that, because original TA definitely better than the FHL.
So we got the second question from Hyderabad, sir.
From North.
Enough for fixation of the FHL. You're putting on the FHL screw. Is
sir,
there any
I don't know, for some reason from Hyderabad, that voice is not coming very clearly.
Sir,
Hello.
screw is enough,
Oh,
sir?
we can't hear you, Hyderabad. Can I move on to Indore? Indore?
Yeah. May I ask a question? With the advent of interferential screws, will anybody like to do a long segment FHL transfer? That is my first question. Second, if we are doing a short segment FHL transfer, how much loss of the IP flexion can be there, or will it be there?
No, like I mentioned, I'll answer your second question first because I've already answered that. You will have no IP joint flexion at your toe because the FHL is attached to the distal phalanx, but you will have flexion at the MTPJ joint. So I don't think it's too debilitating, but patients will ask you why I'm not able to bend my toe. And I think you can decide to do a long FHL transfer. I think in this scenario, whether it's going to be biomechanically better. That's why I prefer short FHL transfer. You can use any tendon, in fact. So even Dr. Samarth Thakkar uses he uses hamstrings, right? But then some people might say that why you are touching the knee when you can just touch the foot itself like that. So 100% you can do a long FHL transfer through. You can do a tunnel through the calcaneum and then stitch the FHL upon itself. 100%.
Sir, I hope it answers your question. Is Hyderabad back with a better microphone?
Yes, sir. Yes, sir. Sir, only FHL screw is enough for fixation of FHL transfer, sir, or respect to the calcaneum?
Sir, we missed half your question.
Yes,
I'll move on to Jodh. We missed your question.
Hello.
We can't hear you.
Sir.
Jodhpur,
Jodhpur.
please ask your question.
What is the exact location of insertion of FHL? This is exactly on the anatomic side, or this is more anterior to anatomical side?
What is the exact location of
The insertion?
the FHL?
So it's not when you're fixing it, right? So,
yes.
So I would remove the Hagelunds and then put it more proximately at an angle of about 45 degrees into the calcaneum like that. So that's more dorsally rather than into the calcaneum insertion.
Should it be at the same anatomic location of the TA, or would it be a separate?
No, it will be more proximal, sir.
Dr. Rajiv Shah wants to make a comment.
So, Alok bhai, answering to your question, I almost moved to double incision FHL, because it has been now proven by the experiments by Professor Panchbhavi that it is a sound repair. So all those patients who are more demanding, I pass the tendon through the calcaneus. It gives really a strong strength. That's one important, but with the caveat that this exposure, when you take the double incision FHL at the master notometry, there is a medial plantar nerve which is going just by the side of the tendon, and you have to retract it. And patient can have long-standing paresthesia, which eventually goes, but you must inform your patient they're going to go ahead with this thing.
Does the zedeblic osteotomy reduce the need for any VY-plasty or anything?
Has gone as a duplication.
I wanted to do a comment on VY-plasty and
Hello. Hello, sir.
Hello.
VY-plasty or central turn down. If you talk about foot and ankle surgeons world over, have stopped doing it. Though it gives initially good strength, it gives lot of degeneration into the tendon. So practically speaking, any defect which is of 1.5 centimeter, you pass the pull-out sutures, ask your assistant by clock to pull the tendon for 5 good minutes, and you will get the length of 1.5 centimeter. Beyond 1.5 centimeter or 2, 3, 4 centimeters, nothing except FHL.
Thank you. A question was from Sangli. Please go on, Sangli.
Yes, sir. I wanted to ask, sir, the pulvar trap technique is looks better because it will give the tendon excursion in the line of that gastrosoleus. And another, I wanted to please elaborate on the wedge weight bearing, because we are not aware of that. Weight bearing.
Again, like I said, so when you go and you see different surgeons' techniques, I think that's where you keep changing your technique. So I mentioned it, Dr. Girish has spoken about the FHL transfer pulvar trap technique. So I find that it's a much better thing than much better surgical result than rather than just doing an FHL transfer directly. So I've had better experiences with that. And I think second thing is weight bearing. I think once you do your suture removal, you can start the weight bearing from 2 weeks. So that's what it's faster mobilization, because we are only waiting for osteo-integration, like he said, for the tendon into the bone. As I think the Hyderabad question was something to do with the modes of fixation. So tenodesis screw is, I would think, the best mode, because I've seen it previously. Again, if you use an anchor, there's a good chance that the anchor could pull out and your entire hard work is gone out. So I think using a tenodesis screw is the best option in this scenario, and it's not too expensive also. It's far cheaper than an anchor.
Lovely. Thank you, Pascal. That was wonderful. We have one more question from the audience over here in Bombay.
One question from Meerut, sir.
Sir, I think we have discussed a lot about pulvar trap, but I had some doubts about when on table do you think that you need to do a pulvar trap? Second thing, when you do a pulvar trap, where do you exactly take the loop into the tendon? Is it in the complete tendinous junction, or you go slightly proximal and leave some 1 to 2 centimeters of tendon and then do a pulvar trap?
No, so on table, if I have a proximal good stump, then I always, because see, the excursion of the FHL and tendoachilles is almost the same. It's same like that. So by doing the through the basically, if you do the pulvar trap, obviously you can't go through the unhealthy portion of the distal portion of the proximal stump. You'll take it a little bit more proximal like that. Just go through it and then go. I just go through a single. I don't do multiple.
For all cases, whenever you're doing a FHL transfer, you always do a pulvar trap.
I've started doing it now. Because definitely the push-off strength is much better after that. But your tendon has to heal into the bone.
Yeah.
So that
I see Sangli still had his hand up. Sangli, do you still have a question?
Sir.
Hello, sir. Meerut.
Hello?
Yes, sir.
Yeah, Meerut, go on.
Meerut, sir.
Yeah, please go on, Meerut. Sangli will come back to you.
I want to ask that you are retaining the proximal and the distal part of the tendoachilles and you are augmenting it with the FHL. Am I correct, sir?
In most cases, if I can, yes.
So when you're
Because
doing,
otherwise, if you just do an FHL, there's also a nice defect in that area, and the patient complains that he or she does not have that, that normal. It looks weird because you have your calf and then you have a thin, basically stump going from the proximal to the distal end. And also, like I said, I would try to maintain the original tendons just to cover my suture material so that I don't end up with any skin necrosis.
retaining both the FHL with the tendoachilles part, which is remnant. Now you are immobilizing above knee or below knee, sir?
Below knee, I put a boot and I'm non-weight bearing for the first 2 weeks and then I'm weight bearing after that.
No, but if
One
you
last question
Achilles, then
from
the
my side.
distal femur. So I mean, movement at the knee might interfere with the healing of the FHL.
You can do a one. No, 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 no. So the FHL is origin is on the tibia like that. It's not like your gastroc, which is originating from your what you say, your distal femur. So there is no question of doing it. So my FHL is my main tendon. I'm using the TA just to cover my thing. To basically, it looks cosmetically better. One, and two is that it prevents any suture material like that. And also in sometimes if I'm trying to offload that, if I do a TA repair over my FHL transfer, I do a 1 centimeter proximal calf release also in that scenario, so it reduces the amount of stress on my fixation. So if I'm cutting my gastroc through the muscle over there, again, it doesn't make sense immobilizing it above the knee.
So we'll take this final question, if any, from Sangli. Otherwise, we'll move on to the next case. I think it's answered. Thank you very much. We move on to the next case, and we have got Dr. Rajiv Shah, and he is going to show us an excellent demonstration of subtalar arthrodesis, a fairly common procedure among general orthopedic surgeons, very important for all of us to know about it.
Good morning. And again, thank you very much, Bombay Orthopedic Society, to invite me here. So subtalar fusions, the types could be conventional subtalar fusion, arthroscopic subtalar fusion, distraction subtalar fusion when you have a malunited calcaneus fracture and patient complains of anterior ankle pain. And when you take a weight bearing X-ray, you see that the talar declination angle is reduced. That's where you do distraction subtalar fusion. And quite a time, we have a subtalar fusion with a posterior impingement. So the case which I am going to show is a female of 68 who has got a seronegative arthritis. And you can very well see the arthritis of subtalar joint. Obviously, you also need this kind of an Excel or the Salzman view because sometimes you have excessive valgus, sometimes you have varus. You need to correct it when you're doing a subtalar fusion. And this is one of the very important thing. When you do this, you have to have a weight bearing views. You want to see normal talar declination angle. What is the talar declination angle? It's an angle which is formed between the sagittal axis of tibia and that of the talus. This angle normally is up to 110, 120. In a malunited calcaneus, this angle reduces to 90 and patient have anterior ankle pain. This is the case where you have to have a kind of distraction subtalar fusion, which we are not going to discuss. And again, as I said, Salzman view, no varus or no valgus is what is important. Now coming to the position, I like to position my patient into lateral position and I like to put in a bump which makes knee to ankle axis completely straight. And this is how I start marking. I mark the fourth metatarsal base. I mark fibula. That's the head end. And then an incision, which is a sinus tarsi incision, goes from tip of the fibula to about 2 centimeters. So this is how your incision comes into play. I almost always use a bump, which is my second assistant. When I want to do the dissection, I push bump up so that it makes my life easy. My assistant can do sort of inversion and my exposure is easy. And when I want to put the wire, I want to do natural 0 to 5 degree of valgus at the subtalar joint, and therein I pull my bump out. So this is how it could be helpful as one of the assistant. And then your incision starts, as I said, it's a sinus tarsi incision. Mind you, this incision varies. If you're doing a MIS calcaneus, you need to go little lower because you want to go underneath the peroneum to slide your plate. When you want to do a subtalar fusion, your exposure would be little anterior. And make sure that your incision is centered in such a manner that you don't hit your nerve. And so the dorsal exposure, you have to take care of anterior branch of sural nerve, and plantar exposure, you have to take care of tendons of peroneum. Mind you, this sort of arthritic patient, they have a lot of synovitis here. When you do this surgery, remove the synovium, do synovectomy. You could send it for the biopsy if required. If not, also you remove it, because otherwise patient comes back saying that, sir, sab kuch acha ho gaya, but the swelling is there. That is all. So that is what patient value a lot. This is a very, very important thing which I learned from Professor B. Hinterman, that you put in a bone spike to protect calcaneofibular ligament. Calcaneofibular ligament, if you cut it, you could have problems at the ankle. So push in a bone spike, and bone spike reflects the calcaneofibular ligament. Once you do this, then you have to identify the locations for the passage of your wires into talus and then into the calcaneus. You're going to put a distraction wire, Hinterman distractor, and this is how you do the Hinterman distraction. You put in two wires, one into talus, one into calcaneus, and then with this wire you start distracting. We typically band the wires with an Hinterman distractor, so the distractor doesn't come up and your distraction is focused to the joint you want to work onto. So that's how I bend the wire, turn it, and this is the Hinterman distractor in place with one wire into talus. The inferior wire is into the calcaneus. And then you start distraction. As you distract, you get good amount of space. Sometimes you find that the distraction is very difficult. In that kind of a case, those kind of cases, you had to cut the interosseous ligament of subtalar joint, or sometimes you need to go little medially so that you can really distract it. This distractor, Hinterman distractor, should strategically be used. If you want to go and see more of calcaneus, you pull it down. If you want to see more of talus, you push it up. Thereby, the movement, push and pull movements of the Hinterman distractor gives you an access to the joint. The next step is preparation of the joint with a straight and angled curate. You should prepare it so nicely that you see bleeding bone. And once you are done with it, you give a lavage. Don't give lavage after you drill this bone, because the drilling material is osteogenic. So you give lavage before you do the joint preparation with drilling of articular surface. Articular surfaces are drilled with 2 mm K wire or a drill bit. This drilling has to be quick. That is what literature has said. And you make sure that you're not heating the bone a lot. And keep this material in, because it's an osteogenic material. Drilling is followed by osteotome perforations of articular surfaces. You could take a straight and the curved osteotome, do multiple perforations. This makes your fusion site very nice. Sometimes you may have to use optional bone grafting, which you can take from calcaneus, which you can take from the proximal medial tibia if patient is not having a knee pain, or you could do it from proximal lateral tibia if patient is an aged patient beyond the age of 45 to 50. It is at this juncture that you need to do your image check. When you do the lateral image, assistant pulls the leg into dorsiflexion, and this is how you see your APN lateral image. And then you start marking for your screw placement. So you want to put in screws which are going from the non-weight bearing of the heel, calcaneus, to the talus. And you are wanting to span the joint itself. So that's how you push in your K-wire, mark for the screw placement, and this is how you are going to pass one wire first. And this wire, if you see, is into the into this posterior subtalar joint which you want to fix, and you're going from the non-weight bearing area of the calcaneus. I've seen people putting these screws from the weight bearing area and then patient is not able to walk. Typically, I like to use K wires or a guide wire for 6.5 mm screws, and there are two parallel wires. Make sure that you are going into various quadrants of the talus. Most important, I have pushed screws into the anterolateral gutter of the ankle. Don't do the blunders which I have done. Always, always, always check AP ankle to make sure that your wires and your screws are not going into the gutter of the ankle. Okay, you measure the screw length and replace these wires with the screws. But mind you, lateral screw would be first because you want to give a natural 0 to 5 degree of valgus. I typically use a screw which has got a variable pitch. So biomechanically, they are radial preloaded screws, which has got a smaller diameter distally and a larger diameter proximally. So it compresses tremendously. No head of the screw remains outside the bone. So this area is very known and prone for the impingement. So that is what you do. This is how the final images looks, and this is how the post-closure thing looks. So post-operatively, I give a below-knee posterior slab, keep them non-weight bearing till I see good fusion. On X-rays are taken at the interval of 4 to 6 weeks. And I do like to follow such cases with Broaden's view, which gives me an idea of the fusion as you take Broaden view from 10, 20, 30, and 40. That's all. Thank you very much.
So after that very elegant display of a subtalar arthrodesis, questions are open to the house. Anybody? Yeah, please, madam, go on.
Before that, when you are doing this for a malunited calcaneus or a talus, a post-traumatic fusion requires a sound kind of a construct. So you must use one anterior screw which goes and fixes the middle or the anterior facet. So you're preparing all three subtalar joint. You know we have an anterior, middle, and posterior subtalar joint. So you need a sound construct for a post-traumatic situation where you need to use three screws. Yeah.
Yeah. Any questions?
From the
Subtalar arthrodesis, not very common, but not an uncommon surgery either. You do see these patients with arthritis, obese patients, a lot of inflammation, a lot of pain. They come to you, they're hobbling around. You've tried everything. You've tried anti-inflammatories. You've tried splinting, giving them splintage, and you've given local hydrocords, not worked. That's the time you start thinking. Pascal, what's your question?
So, like you had mentioned about this we always put our lateral screw in first. But what I've noticed that even intra-op sometimes I get it post-op also, but as the patient walks, so sometimes if we don't get is there any way we can prevent the lateral cutout of that screw going into the lateral gutter other than the AP X-ray which you showed us? Because I have had cases like that, like you said, I do fix it in between, but maybe if the fusion is not good enough, then sometimes it does cut out. Is there something that we can make sure that our lateral screw doesn't cut out? Because if it cuts out, then the patient has pain on lateral impingement.
So follow a very simple principle. For a cases of valgus, when you're doing a subtalar fusion, try to push your screws from lateral to medial, because that is how the calcaneus has been over years. If you're doing cases with varus and subtalar arthritis, try to push and screw from medial to little lateral. It is not always that you put in a lateral screw first. If the case is some kind of varus, you're doing it for the KO varus case, is that you have to first push in the medial screw first. So that's how you do it. But whenever you put in a screw, you must make sure that you're putting the right screw first, the right kind of a screw first. And that is what would prevent. And always, always see the AP ankle. You have seen that we have post screw into the ankle gutter.
Yes, Shyam, please go ahead.
So what is your take? Should the screws be parallel or it should be divergent?
My take is to put in a parallel screws, which would get hold of good quadrants, and I like to tighten them, in a parallel kind of thing. So compression, yeah.
You are trying to lag the talus onto the calcaneum.
Absolutely.
Would it be different in case of malunited calcaneum or?
Absolutely. Malunited calcaneus, I am going to tighten simultaneously the anterior screw, which is called as Roger Mann screw, and a posterior screw. Because my anterior screw is going to compress the talus over the calcaneus. And I want to get a plantar flexion of the talus, because in a malunited case, what happens is that talus goes into dorsiflexion. So I want to compress the talus, and that's how I'll first put in a anterior screw and posterior screw. When you're doing a kind of distraction subtalar fusion, I like to push in a screw which is not compressing. Or I may put in one screw which is compressing, other screw is a static screw. I don't want to crush my graft.
Dr. Saraf, please go on.
How do you assess deformity and bone quality before
Can't
planning?
hear you. You are muted.
Hello.
Yeah,
Hello.
we can hear you now.
How do you assess the deformity and bone quality before planning the fusion? How to assess the deformity and quality of the bone before the fusion?
Great question. Now you must do clinical evaluation of this patient. And typically clinical evaluation is also on the standing front, standing side, standing back. And one of the X-ray you take is Salzman view, which is a standing weight-bearing view, which shows the axis of tibia to talus to calcaneus. This tells us whether there is a deformity on a varus or valgus. The second thing, on a lateral view, lateral weight-bearing view, you know that what is the declination of talus vis-a-vis tibia. You could sometimes have a talus which is very, grossly dorsiflex. So this is how you divide, you decide that these are the deformities I have. Sometimes in a flat foot or in a cavus foot, you have a very bad, or even a malunited calcaneus, you have a very bad heel varus or heel valgus. Therein you need to do subtalar fusion, but it would be preceded by a calcaneal osteotomy. You might have to do a medial displacement calcaneal osteotomy, or you might have to do lateral cross wedge or a Dwyer's calcaneal osteotomy. So that in such cases, you prepare the subtalar joint first, then go do your osteotomy, fix it temporarily, and then pass your screws, which passes from the osteotomy site to the fusion site. The quality of bone, yes, you would be able to appreciate from the X-ray. You would be able to get it from the history of the patient. If patient is a kind of a patient who is on a steroid because of an asthma, you are obviously getting a quality which is going to be bad. In my case also, I did not show it, but I did the bone grafting because he was a rheumatoid patient on, she was on a steroid. She was like on certain medications which were reducing her resistance. So therein you need to add bone grafting also.
It is cancerous chips,
It's
not
a
graft at all.
cancellous, yeah. It's a cancellous bone grafting. I typically take it from proximal tibia.
What if there is a fracture calcaneum where the calcaneum has flattened out completely? Is there any difference in the surgical procedure?
Absolutely. As I said, such cases do have settled down talus over the calcaneus, and you have to increase the length of the whole construct. So shortening is corrected and the talar dorsiflexion is brought into the plantar flexion. In such cases, you need to add tendoachilles or a gastrocnemius lengthening, and then you need to put in a graft between tibia and talus. It's a structural graft from the iliac crest, which is strategically shaped, strategically put in such a manner that you not only correct the shortening height, but you also correct the varus and valgus. In such cases, it is very important that you don't take a sinus tarsi approach. You don't take the extensile lateral approach because you will not be able to close because you increasing the height. You take a posterior approach. It's a posterior arm of the extensile lateral approach. You take it and then you're going little indirectly, removing the exostosis and doing the subtalar fusion from posterior aspect.
That's very, very important. I think, any questions? Sangli, you have a mic in your hand. You have a question to ask?
Sir, am
Yes.
I audible, sir?
I have already
Yes.
sent the images. Hello, sir.
Yeah, what images?
Yeah, I have
Where
sent
have you
the
sent?
images. It is a malunited calcaneum. It is 6 months old, and it is totally collapsed calcaneum with a subtalar arthritis. 30-year-old male patient. 6
Where
months
have you
old.
sent these images, sir? We haven't got them.
Wait a minute, sir. Just I wanted some tip because calcaneum is grossly shortened over there. I will hold the images in front of my camera.
Right. Okay, we can see that. Can you show some other image?
You have a weight bearing lateral view.
Can you magnify that? Zoom it in. Yeah, that is much better. That is much better. Yeah.
That's a better. Okay.
Yeah. That's a very nasty injury there.
Yeah, yet we are waiting for the CT. Yesterday only patient came, and this is a very.
So, can I go ahead with my plan? If you could put in the
Yeah.
lateral view, you could put in the lateral view,
Lateral view.
not the axial one.
Show the lateral one again.
Gautam.
These are very nasty calcaneus malunion. Here you would start with open tendoachilles release, one, with the distal release of tendoachilles going medially because there is a medial angulation. And you would need to do a plantar flexion close wedge osteotomy of the calcaneus here. So this osteotomy would be some this. And with that osteotomy,
Here, you mean to say over here?
yes. So it would be a plantar close wedge osteotomy, and with the tendoachilles completely lengthened, you close it plantarwards. And that is going to bring calcaneus into right position, and then you do the subtalar fusion like you do as routine.
Would you
But
do
these
it at
are
the same
very, very challenging cases.
Would you do it the subtalar fusion at the same sitting as the osteotomy? Or
Absolutely.
Would it, yeah.
Yes. Okay. Yes. Same sitting.
Yeah, Jodhpur, you had a question, Jodhpur.
The stud graft to be added, sir.
Stud graft you will have to put. So don't take extensile lateral approach. Otherwise you will invite plastic surgeon. Take a straight posterior approach. It's little. So you're going to put in a tendoachilles, open tendoachilles lengthening. So take that same approach down and take it little anterior to the tendoachilles. It will be a long incision. Start with tendoachilles lengthening and then do. I have a mark. Okay. And then do a plantar flexion, plantar close wedge osteotomy from here. So this then would be brought down and then you do the subtalar fusion. Put in a graft, put in an anterior screw. Anterior screw, what I mean is going from here to here.
Right. Thank you very much.
One question.
Yes, please go on.
If a patient suffer from both tibiotalar and subtalar arthritis, which should be addressed first, both simultaneously, or any idea about it?
So ideally simultaneously, because you want to pass your screws, which would go crossing both the joints, tibia as well as calcaneus, as well as talus. Or you want to pass your nail, that also goes through all three bones. So you should be addressing it simultaneously.
Sir, can I ask a question?
Yes, of course, please.
Sir, if we are dealing with a post-traumatic situation and you said we have to use the anterior talar fixation as well as the posterior facet fixation. So the screws will be from the non-weight bearing zone and there will be 3 screws going parallel to each other?
So the first 2 screws, as I showed in my presentation, would be like that. And there would be a screw which would go anteriorly and lateral to medial anteriorly, almost pushing the anterior and middle facet of talus into plantar flexion. So an anterior screw, which would be almost parallel, it would be parallel to the posterior screws, but three screws like that. That could be from the weight bearing area where you're going to put in a headless screw. It doesn't matter whether it is through the weight bearing or through not through the weight bearing.
Right.
And even if you put a screw with a head, this screw is not into the weight bearing area. It is little anterior to the calcaneal tuberosity. So it will not matter.
Thank you, Rajiv Bhai. That was a fantastic presentation. Before we move on to the next presentation, we've got a small quiz for you, couple of questions. Moderators at all the centers, please be ready to reward our delegates appropriately. We've got Dr. Samarth Thakkar, who's put up some questions of interest for us. Samarth,
Good morning to all the delegates. We'll ask two questions in line with the three previous talks. The first one is, all the delegates can try answering, what is the standing X-ray view called? Is it a standing ankle AP? Is it an axial view? Is it a Salzman view? Or is it an AMI view?
Anybody in the audience over here in Bombay?
General orthopods, please.
Yeah, please go on. Okay, we've got an answer in Bombay. What about elsewhere? Anybody else has got an answer there?
Salzman view, sir.
Salzman view.
Yeah, so in Hyderabad it says Salzman view. Anybody has any other answer?
The Ludhiana Salzman view.
So, yes. What is the second name of Salzman? Anybody? An additional part.
Yeah, so the delegate in Mumbai rightly answered. The other name for this is a hind foot alignment view. So to understand better, these are all standing X-rays taken with the projection from behind the patient. The film is kept either on the floor or in front of the foot, perpendicular to the projection. Now, based on the degree of projection, we have different kinds of hind foot alignment. If we have around a 30 or 20 degrees of angulation, that is a described angulation for a Salzman view, wherein we see the calcaneal alignment vis-a-vis the tibial alignment. The same projection at 45 degrees gives us the standing axial view. The views that were shown by Dr. Rajiv sir in the previous cases were standing axial views, wherein we not only see the alignment, but also the subtalar joint surface, giving us more inference from the X-ray. So that's the hind foot alignment views for all our delegates. Another question. So since we had a good discussion on TA, this is a question pertaining to that. So lengthening procedure of the tendoachilles, there are various ones mentioned. The one in the image here, which of those is it? Bowman's procedure, Hoch's procedure, Baruch's procedure, Strayer's procedure. Pardon me for all the eponymous options.
Yes.
From Mumbai delegates, any answers?
Hello.
Yes, yes, please go on. Who's answering?
Strayer's procedure.
Who said that? Sangli?
Strayer's procedure.
Okay, we got answer of Strayer's procedure from Sangli. Anyone else?
Anybody else differs from that? Anybody has another answer?
Stairs procedure.
Yeah, Dr. Saraf.
Stairs.
All right.
Correct.
Dr. Saraf please deserves a chocolate there, and so does the person in Sangli. Unfortunately, in Bombay didn't answer, so I'm going to eat this chocolate here all by myself.
So yeah, we got right answers from our delegates. Just to add a little note on that, lengthening procedure for the gastrosoleus complex can be done at all levels, starting from the femur at the origin, where we do the Baruch's procedure, where we release the aponeurosis of its origin, often the medial. Then we go into the mid substance in the proximal half of the leg, where we release the anterior aponeurosis of gastrocnemius isolated, which is called as Bowman's procedure. Then as we come down, when the gastric aponeurosis is formed and the muscle has terminated, we release the isolated aponeurosis of gastroc, which is called as Strayer's procedure, as in the question here. As we go distally, there is a simultaneous release of both gastroc at the same time soleus, and those are Vulpius, Baker, and all those tongue in groove kind of releases. These are stronger releases, but they're more debilitating when it comes to the push-off function. And as we go distal most in the tendon of tendoachilles, we have the Z lengthening and the hooks release. Thank you.
Lovely. Thank you, Samarth. We now move on to the next case, and I would like to invite Dr. Dhrumin Sangoi, and he's going to show us a fairly common problem, an open hallux valgus correction. It's not uncommon in our practices that we see hallux valgus in patients, and though not many agree for a surgery, but when they do, Dhrumin is going to show us how we can go ahead.
Yeah, so as rightly said, not many patients in India will go for this procedure. As compared to the Western world where they wear closed shoes, we are a community who wear open chappals, sandals, slippers, and many patients tolerate this deformity very well. So this was a patient, hallux valgus. She wanted to wear closed shoes and office going person. So why do people get pain because of this bunion? So many people have bunion, they don't have pain. So there are a couple of common reasons. Number one, the bursa. Bursa over the bunion deformity gives the pain. Number two is the plantar nerve, the branch of it which crosses over the medial side of the big toe, that gets irritated and causes pain. And number three, due to the malalignment, people can have some cartilage changes in the MTP joint, and that can cause pain. So these are the three major causes why people get pain in their bunions. And when they do get, and they are not very happy, they come to us for surgery. So this is a right side hallux valgus which the patient had. Always get a lateral view to see if there is any osteophytes. You need to see the sesamoid position if there is any arthritis there, and always standing x-rays, because a supine x-ray, lying down x-ray will not show the degree of deformity which a standing x-ray will show. Always see the hallux valgus angle. More than 20 degree is an indication, because even we as mild normal population has a bit of valgus in their big toes. And the another important parameter is the angle between your first metatarsal and the second metatarsal. And these people, their angle is more than 9 degree between the first and the second metatarsal, and our aim should be to get it closer to 9 or a bit lesser than that. So going on to the surgery. So many surgeries have been proposed for hallux valgus correction. What I commonly do is a scarf and an Aiken osteotomy. That's your incision which goes for the scarf. There's one more procedure added here, which is a adductor hallucis release. So adductor hallucis tendon inserts into the base of the proximal phalanx, and the strong pull of that pulls the toe in valgus. So you need to identify the adductor tendon. Sometimes the flexor hallucis longus is very close. If you try and pull that, the toe will bend down. So make an incision, go as near the base of the proximal phalanx as you can. Try and identify the tendon, and then with a 15 number blade, you can release that tendon. So you can do it with a scissor or with a 15 number blade. It's just an upward sweeping action. Try and be close to the bone. Your digital nerves and vessels are there right across. So make sure you have a retractor and retract those structures and not injure them. Then you start with your medial incision. So as shown in the picture, that was the medial incision. First, you will see, make sure of the plantar medial digital nerve, which goes a little bit dorsally there. Make sure you retract that. Then you'll see the capsule. You have to inside the capsule. Okay, so I'm next step here. Once you have opened up the capsule, you see the bone and you see the bunion deformity. Try and use a small oscillating saw blades rather than your big TKR saw blades. First step is to remove the bunion. So try and get the bunionectomy done first, which will be close to your articular cartilage. You shouldn't violate the articular cartilage when you remove the bunion, because if you go too far medially, you can get a complication of hallux varus. Your toe will turn inside. So try and get the bunion out first.
So just doing a bunionectomy and a medial soft tissue plication, very high chances of recurrence. Hence we have to add the bony osteotomy. So we have two chevron and scarf osteotomies here. Okay, that's the same video. So this is the next video. Next step is I put a K-wire in the center of the metatarsal head. So that's the cartilage where the green dot is. And there around center goes your K-wire. So that's just a guide to your Z cut. So scarf is a Z cut. I will show you in the next video. Okay. So now your goes the vertical cut. So it is a Z. So this is the first vertical cut which will go in the first metatarsal. It goes through and through all across on the other side. Make sure you do not go inferiorly, otherwise it will become a complete transverse cut and your head will be off. Metatarsal head will be off and also your head. So yeah. So once you do the first cut, which was, you did the first cut, which was this. Next, you can mark with a cautery. Okay, so I've interchanged the videos. I think this was the first video before doing the cut. After doing the bunionectomy, you do this step, which is a cautery marking of this Z. And I've already shown you the first cut in the previous video. So that's the cut along the long axis of the metatarsal. And this is your saw cut, which goes along the long axis of the metatarsal after your first cut is done. So this K-wire just serves as a marker where you are doing the vertical cut and where you are doing the horizontal cut. Again, this is bicortical. So you have to feel both the cortex. You have to feel the near cortex and you have to feel the far cortex. Don't try and go too much inside so that you reach the second metatarsal. So that's why feel is very important, and small precision saw blades like this are important. Another tip is, if you don't have this saw, you have to drill multiple K-wires with a small drill bit, and with a very fine osteotome with a controlled manner, you can do this. But it should be a fine osteotome. You don't want too much bone loss. Yeah, so I always complete it with this osteotome like this. So here in this video, you can see the horizontal cut, and then again at the proximal end, it extends down the vertical cut. So that's how your Z is completed. You can see the osteotomy a bit mobile now. Always you will struggle to shift it initially. What you have to do is take a periosteal elevator, try and lift the periosteum on the far cortex on the opposite side. Only then you will try and get a good shift. So that was about it, about the osteotomy. I don't have a video of Akin osteotomy, but you can see now there is a cortex there. So that's the shift which has happened. There are two screws which we have fixed. You can use a headless small 2.5 or a 3 mm screw. Now this Akin osteotomy gets your toe a bit more inside. So that osteotomy goes like this, from there to there, and a V shape. So it's a medial base wedge and it's a closing osteotomy on medially. And then perpendicular to the osteotomy, you put your screw. So if your osteotomy is in this way, you put a screw like this. Some people like to do an osteotomy where my screw is going, and then their screw will come from this direction if they do the osteotomy like that. So that's how it goes. Afterwards, your toe should always be in varus after your closure. So you have to tighten up the medial soft tissue so much that your toe becomes in varus, because eventually that will go in valgus, provided you have not done the bunionectomy too much and you have not gone with your bunionectomy towards the articular cartilage, you should not get a hallux varus complication. Bandaging, post-op bandaging is important. It should always be with your toe in varus for around 4 to 6 weeks. And that's your scars which have healed because they eventually stretch out. Even it was in varus, you can see that now it's become straight. And always warn them of slight valgus going of the big toe at 3 months mark. So they are happy. They are happy because their bump goes away, their toe is aligned, and their plantar flexion and dorsiflexion of the MTP joint they get, which they couldn't get before as their MTP was almost dislocated. So some similar cases, again a severe hallux valgus, intermetatarsal angle is widened, hallux valgus angle is widened. Here the first metatarsal is very short. You can see the second metatarsal is long. So always check if the patient has a callosity under the second metatarsal head. If the patient has that, you need to shorten the second metatarsal also. In this case, she did not have any callosity. We tried to lengthen the first metatarsal a bit. You can see how where this was and where the second metatarsal is, and with the cut you can adjust, either lengthen or shorten the first metatarsal depending on the way you angulate it. Sometimes you need 3 screws, so always be ready. Akin is always helpful. That gives them a good cosmetic deformity. So that's our toe position after the correction, and that's the fixation. So what can patients expect? So this is another patient who had a correction. So they are happy with their first toe. They should get a good plantar flexion, dorsiflexion, not to the best amount as the other leg, but still they get a good amount. And walking with a straight toe and on tiptoes is what they enjoy. So whenever we stand, we always stand on a tripod, the first metatarsal, the fifth metatarsal head, and the calcaneum. So once that is restored, that's the most satisfying part for them. Do I always do scarf and Akin? Not always. So sometimes we get hallux valgus with severe flat foot deformity. Now the patient tells, I don't have problem with the flat foot, but just correct my toe. So sometimes we have to do, which is called as lapidus fusion, where we rotate the first metatarsal, we fix the first TMT joint, we add an Akin osteotomy, and that's how we get a straight toe. So there are other procedures. We have minimally invasive bunion corrections as well now. So always choose what your patient wants, always set their expectations right, and that's how this deformity is corrected. Thanks.
Hello. Yeah, so that was nice. A hallux valgus correction, not a commonly done surgery in India, as Dhrumin said, but now with patients living longer, etc., I think we are finding more and more patients who are coming with more and more significant valgus deformities, and sometimes they do demand correction, especially elderly ladies. Any questions?
Sir, from Hyderabad.
Yes.
Scott was not me.
Sir, the same problem persists. I can't hear you.
Sir,
can you, I'll just send you, please record my mobile number, 98.
Yes, sir.
9820
Yeah.
50
50
43
43.
51. Just send me your message by WhatsApp.
Yes, sir. Okay.
Okay, we'll have a look at that. Meanwhile, we'll open a question. Yes, Dr. Rajiv Shah.
So, Dhrumin, I saw you doing the bunionectomy, going from distal to proximal. I do it from proximal to distal. You have a joint in front of you. You need to go about a millimeter away from your ridge. So that gives you an idea where you're going. And I like to go from distal to proximal, doing the bunionectomy, which makes my life easy because I'm not going to overcut it. Any comments onto that?
No, that's a good point. Yeah. So I think in this case, I had not opened up the joint. That's why I went from, yeah, you have to eventually open up the joint to go to proximal.
Yeah.
and you have to make sure that you don't violate the cartilage. You have to leave a ridge, as sir said. So that's a great point. We can always go from distal to proximal and do that bunionectomy. Yes.
Hello. So one question from Indore.
Hello.
Hello.
Yes, Indore, please go on.
Yes. Dr. Dhrumin, Dr. Vishal here. So some of your X-ray there is some still seismoid is not reduced. So how to some seismoid is looking little lateral side, pronated.
Sorry, what was the question again?
Seismoid. Seismoid is Hello. Are you audible?
Yeah, so scarf is a translational osteotomy. There is a little element of rotation which we can apply to it. Now the sesamoid, the majority of the correction comes with your medial soft tissue plication. As you tighten up the medial soft tissue, your sesamoids come along with that. If you feel that your sesamoids are too much out and causing a problem, then we have rotational minimally invasive osteotomies which we do transverse. However, in these cases, if you have a good translation of the first metatarsal with scarf as well, there are less likely chances of a recurrence if your bony deformity is good. The sesamoid will be slightly subluxated, but not to the extent that they should cause a recurrence.
So we have a question from Hyderabad. It was also about the scarf osteotomy. Should it be short or long, and indications for the length of the scarf?
Yeah, so many people do a short scarf, that is reasonable. So I would say with the degree of deformity, if you have like a mild 20 to 30 degree of hallux valgus, you can go for a short scarf or a chevron, because once you try and translate, you should get a good surface area to put the screws in. If there is a severe deformity, then you need to go for a long scarf so that you can translate more and still you get a good bony contact of the superior and the inferior metatarsal to put your screws. So I would say depending on the degree of deformity, if more deformity, go for a long scarf.
Yeah, any further questions?
Yeah, sir.
Yes, please go on.
I wanted to ask, yeah. So medial opening wedge osteotomy at the base of the first metatarsal and lateral closing wedge, medial closing wedge osteotomy for the distal phalanx, proximal phalanx. Do it workable because scarf looks to be much more technically demanding.
So closing wedge for the phalanx is good enough. You have to do that. But opening wedge at the base of the first metatarsal, then there is a gap left once you open it.
So we can use that wedge removed from the phalanx to fill in the opening wedge and just put one small recon plate over there.
Yeah, acceptable option. You can do that. That is fine.
Because
so hallux valgus has many surgeries. That is one option can be done. Yes.
Thank you.
Dhrumin, there is a question from Dr. Ravindranath that what about the shortening of the great toe after the Akin procedure? And do you warn the patient about this?
I'm not worried much with the Akin shortening, but the scarf itself can shorten your bone because you are removing some bone with the saw blade and you are translating. But always warn the patient, yeah, your toe might be a bit short, and always see the second toe. That should not be long because that causes a problem. Big toe shortening, patients will accept it.
Right.
From Hyderabad, intraoperatively, if we notice hyperlaxity of TMT joint, do you convert to Lepidus?
Yes, so I think that decision I make it more in the clinic itself by testing the TMT hypermobility. Also in the lateral foot X-ray, if you do a standing lateral foot X-ray, if you see a plantar opening at the first TMT joint, that is another indication that is hyperlax. In that cases, you plan your Lapidus before, but even intra-op, if you see that you have not made the cut and you feel that it is hyperlax, always a good option to turn it into Lapidus.
Sir, we got one more delegate. He is asking that if we open the MTP joint, if we notice there is an arthritis on the head of the first metatarsal, do you convert it to arthrodesis instead of scarf?
Again, pre-op that is to be determined with X-ray and MRI. Patient counseling has to be done. Intra-op, if I have not told the patient, I will never convert it into a fusion. The patient can sue me. So always another thing which you can, if you feel that there is arthritis, shorten your first metatarsal a bit. If you shorten it, then you will decompress the first MTP joint. If you see some cartilage erosions, do a few micro fracture there. Those are the tricks which you can do to avoid getting the first MTP arthritic and painful.
Thank you very much. We're going to stop this session over here and we move to the next talk, because the next talk has been now divided into two parts. In the first half, Dr. Shyam Thakkar is going to show us a lateral ligament reconstruction, and then Dr. Pradeep Moonot is going to show us multi-ligament reconstruction. Shyam, I would request you to stick to the video, not give us a lecture, please.
Sure. Good morning, all. I'm sorry I was not ready for the video presentation. I'll just quickly transfer. First of all, when do we need this surgery? So it is not just an MRI report which suggesting there is a partial high grade, low grade, ATFL 1, 2, 3. It is all the clinical examination which decides whether we want surgery or not. Many times we can get such pictures, so be careful. Obviously, this goes into a multi-ligament category. So just to be brief, ATFL, CFL and the PTFL, these are the ankle ligaments which stabilize the joint. So we'll directly quickly jump onto the case. So this is the most important test which is diagnostic for an ATFL reconstruction or a Brostrom procedure, which is a drawer test. You hold the distal tibia with your one hand and you try to shift or hold the heel with the other hand and do a forward backward motion, and you will find a laxity. So, okay, always compare with the opposite side. Do not just conclude with one side regarding surgery. So it is important. Other few tests are talar tilt test, dimple sign, and all. So yeah. So 56-year-old male twisted her ankle. It was on uneven surface. It was managed conservatively, but there was no relief. Obviously tried everything, did an MRI, and this was the MRI picture. Okay, so this is the section where we look for the ATFL, which is the axial section. When you start seeing the talar neck, do we have? Yeah. So when we start seeing the talar neck and the fibula, here comes the ATFL band, which should be dark black. This is all grayish and whitish. Okay. Another section. Yeah. So this is the important point. When you don't see a talar neck, this is the AITFL, which is a syndesmotic ligament. Don't trust the MRI report. Try to read the MRI. So in this case, in the coronal section, you can see there is a fragment. Okay. Anybody can know what is this? So this is a CFL avulsion. So ATFL, CFL avulsion, which is important because these cases don't get better with conservative treatment. So we check intra first. This is the draw test which we checked. We compare it to the opposite side and it is drastically positive. So this was a fluoroscopy test where we see there is instability and there is opening of the lateral gutter. And an anterior draw test. So you can see the gap is opening and the talar is shifting. Okay. So we take the incision lateral approach, just like extended sinus tarsi, where we start from the tip of fibula and so we start from here in line with the fourth metatarsal, a small incision 2, 3, 4 centimeter, and do not dissect up to the, just go to the bone. Do not dissect deeper than the bone, because ATFL normally you won't find a tear complete. There will be a stretched ATFL. So ATFL, CFL capsule complex. It's a complete complex. You cannot identify ATFL and a CFL separate ligament. Okay. So in this case, we found we elevated the periosteal flap and So this was the ATFL CFL complex, and you find that avulsed ligament or avulsed fragment which was there, which was impinging. So in such cases, we remove the avulsed fragment. So this is the fragment. It is not necessary to repair or reattach this fragment back to the native bone. You can just excise this and repair. And with the suture anchor, we had repaired, and you see how the complex is nicely flushed to the distal fibula. So on top of this, you repair the periosteal flap. This is the osteoperiosteal flap of the fibula over the repaired ATFL ligament in a double breasting manner. So this is the ligament has been completely sutured to the lateral malleolus, and the fibular periosteal flap is attached over it. And you can see the introp stability after repairing the ligament. So this is one procedure, rostrum procedure, where you do it openly. However, nowadays I'm just doing it arthroscopically. This is restricted only for cases where there is associated peroneal tendon tear. So just a short video on arthroscopic procedure. So we check for the draw test. So these are the landmarks. This is the anterior tibial tendon. This is the superficial peroneal nerve branch. In the lateral position, this is the safe zone. We mark the lateral malleolus, we mark the peroneal tendons and the nerve. So our portals will be standard anteromedial and anterolateral. I'm sorry. So
that was very nice presentation. This thing.
So this is
thank you for filling in up. Dr. Thakkar filled up with his video at the very last moment. I requested him, and he said thank you. He's agreed immediately, and in 5 minutes he got this presentation ready, which was lovely. Thank you very much, Shyam, for this presentation. And can I ask audiences if there are any questions regarding lateral ligament repair? I think he had wonderfully shown us the anterior posterior drawer over there, which was very clear. Meanwhile, while Dr. Pradeep Moonot is going to put on his laptop and show us the multi-ligament instability, we'll take some questions for Shyam.
Hi. Where do you place the anchors? Hi, Sachin here. Where do you place the anchors for the
So when you expose the fibula, you find the base of AITFL, which is the syndesmotic ligament. At the base of the AITFL is the origin of the ATFL ligament. You can do one anchor, two anchor.
I could see two anchors in your.
There are studies which there is no difference. So when sometimes we use two anchors, sometimes we use one anchor. If you have to use two anchor, you have to mark the from the tip of the lateral malleolus to the base of AITFL ligament, divide it into 2 points, 2 millimeter apart. There will be two anchor. If you have to put a single anchor, it will be just at the base of AITFL attachment. Put one double loaded anchor and repair the ligament.
Sir, from Hyderabad, if we don't have a
all anchors, someone coming from the spine field, we don't know what are the types of anchors available in the market. What is available and what are the specifications you should look for?
So since lateral malleolus fibula is a very small bone, you don't need bigger anchors. So there are titanium, PEEK, all suture anchors. Titanium ideally which should be used is 2.8 millimeter, not more than that. All suture anchors are smaller size. It is 1.8 mm double loaded, but it forms a ball of almost 4 millimeter. So ideally you can use that also. And I'm more comfortable using PEEK titanium anchor. PEEK anchors currently are not available for foot and ankle. The current PEEK anchors which we are using are of shoulder. So we have to drill too much into the fibula, which is, the length is, we don't get that much of length. So PEEK anchor, I have not seen most of them using. Either we use a titanium 2.8 anchor or we use a all suture anchor, which is 1.3 or 1.8.
Lovely. Thank you. Any other questions here from the house?
From Hyderabad, sir.
Yes, sir. Tell us, Dr. Raghvendra. Go on. From Hyderabad, I said you were going to ask a question, I
Yes,
thought.
Hyderabad, yes, sir. One delegate is asking if there is enough tissue of ATFL repair. Do you use extensor digitorum fascia or muscle for augmentation of ATFL repair?
So this is a Gold's modification, where we use the inferior extensor retinaculum. So currently it is difficult to find a very good tissue of ATFL and we repair that ligament. It is always advisable to reinforce using an inferior extensor retinaculum. Sometimes with reinforcing, the inferior extensor retinaculum band cuts through, the suture cuts through that band. So if possible, try to reattach. If you cannot get it, it's okay even if you take a bite from it.
Right. Thank you, Dr. Ravindranath, for your question. Any other questions, sir?
I have one question from Indore.
Yeah, please go on.
Do you always use anchor sutures for all ligament repair? Any other method?
You always use an anchor
Anchor
for a
suture to repair
ligament
ligament?
repair, or do you do it without that also?
Yeah, now I'm always using anchor because it is making my life easier. Earlier, I used to use pass transosseous suture and tie it over the fibula, but it takes 10-15 minutes extra time. Obviously, you can do it in cost constraints where you don't have to use an anchor. You can use a transosseous suture and tie it over the fibula.
Why you excise the tip of lateral malleolus? That fragment there cannot be osteosynthesis there.
If the fragment is too small, secondly, you don't want to attach the fragment. You want to attach the ligament. So attaching the fragment, there could be a chance of non-union and the fragment may lie there as it is. There is no point in keeping that fragment because bony union will be difficult rather than a ligament which is attached to the bone because it will heal with fibrosis.
If the fragment is there, that means the anterior talofibular ligament and the calcaneofibular ligament are torn?
Yes, sir. If you see, the fragment is lying anterior to the tip of lateral malleolus. So it is from the ATFL, CFL complex.
And if the fracture is proximal to the tip of the lateral malleolus, then we don't have to do anything. That's what AO had said, that it is distal to the ankle, so you don't have to treat it. Is that true?
That fracture is different. It would be a transverse or an oblique fracture. It is more of a syndesmotic injury rather than an ATFL injury.
Okay, good.
Right. Any other questions before Dr. Pradeep goes on? Okay, Pradeep, I think you go on and then I'm sure more questions will come up from the house after your presentation.
Thank you very much, Dr. Zaveri, sir, and Ashish for inviting me for this live surgery symposium. I'm sorry, I'm just coming from Udaipur. So just quick case, 35-year-old female, residing and traveling, the Jain monks, they keep traveling. She's been having this pain and difficulty in walking in the left side for 2 years, has had multiple MRIs done, tried conservative treatment, had physiotherapy done, no relief. On examination, left ankle, mild heel valgus, tenderness present. And now this is the key thing, and I think Shyam already mentioned this. You have to examine these patients very carefully. You can't just say pain on the lateral part of the ankle. Which structures you have pain is very, very important. And I think that is the key to the assessment and getting the diagnosis and the management. So she was tender on the ATFL, CFL, deltoid, draw test was positive. And sorry, it's pretty, thank you. And that is the assessment done. She mild valgus, otherwise the rest of the things was okay. Walking was, they normally walk, Jain monks walks around 10 to 15 kilometers a day. And she would not be able to do vihar, you call it, every 2-3 kilometers she would have pain and then she would need to use a wheelchair. X-rays were inconclusive. Actually, what they call their brotherly, the worldly brother who resides in the South India came to me in Mumbai. MRI was reported as having some calcaneal cuboid, and they were ready for a calcaneal cuboid fusion. So finally, one day I went to Ahmedabad and I said, no, let me assess it and then decide what needs to be done. X-rays were normal, and let's look at the MRI. Now, this is the key thing. MRI, which again, Shyam has gone through it, ATFL gone, deltoid had changes. And the key thing was, let me just go through it. And she had an MRI done, she had a CT scan done. I thought there was a fluid in the syndesmosis. She was tender on the syndesmosis. ATFL was, okay, sorry. Let me just go back and just go through the MRI because I think that is the key thing. Yeah, let me pause that. So here, that's your syndesmosis, that's your AITFL area, which was incomplete, changes there. ATFL is gone there, and she had deltoid changes as well, and deltoid tenderness as well. So finally, the plan was to do an ankle arthroscopy, assess the ankle, decide if the syndesmosis is definitely unstable, do a syndesmosis, ATFL, stroke CFL, and deltoid required or not. Okay. Positioning, supine position with a pillow on the same side, buttocks on the sandbag on the buttocks. Now look at that pre-op assessment. Okay, you can see the lateral tilt, that's all it is. So scopy done, anterior slight bulge there. Maybe you can talk about anterior impingement, but look at the medial side and we'll show you scopy, how you can almost drive through on the medial side. You should not be able to do that. That's, you can easily see, you see that how much allotment or space is there on the medial side. That's not normal. Look at that. I could put my shaver on the medial side and she was still opening up there. That's not normal. So she was lax medially. Also, we look at the syndesmosis. So this is tibia, talus, that's your fibula. You can see there, that's the opening. I could push my fibula through the probe, and that syndesmosis was opening up. So again, confirm the diagnosis of syndesmosic instability, lateral side. So open up on the lateral side. I think Shyam has beautifully mentioned how to do it. I always identify the whole capsule and the ligament, open it up. That's your talus, that's your fibula. Okay, and that's your anterior part of the distal fibula. Now you can decide to have two anchors or one anchor, or depending on how good your soft tissue is. Again, depends on the cost constraint. You can do one or two. So here it is just between the tip and the anterior flange of the fibula. I put a double loaded anchor. That means you have 4 strands with needles. Go through that, and then you have nice 2 strands. You can take the whole soft tissue and pull it up. And then you do a double breasting type of thing. So you pull up the whole distal cuff effectively and pull it on that. And on top of that, you will do a double breasting with the periosteum and your extensor retinaculum. So that's your Gould modification. So you want to just hold in there. So you want to pass all your sutures and then tie sequentially. So now there I'm elevating the periosteum from the distal fibula because that will also help me reinforce my lateral tissues. Now, the other just word of thing, if the tissues are very lax or very stretched out, I always keep a internal brace or a fiber tape handy so I can reinforce that. So it's always there to if I need it. I don't use it always, but if this tissue is bad. Now, also I'm exposing the distal part of the fibula. I'm putting a wire for syndesmotic stabilization. So this is a flexible tightrope fixation. Put in a wire. Now, most of the system, even the Indian systems, you have the whole kit inside. You have a wire, you have a drill around it. So that's a 4 mm drill going through it. And then this is a whole syndesmotic tightrope knotless done. You can pass through it. put the wire, you flip it automatically. There is a button there, you flip it, and then you can just tighten it up. So took the sutures of the ATFL, CFL, but did the syndesmosis tightening first. There it is. You just tighten up, foot in neutral position. You don't need to dorsiflex. I think that concept is gone now. So there, that's done. And now we're going to repair the lateral side. So that's your syndesmosis done. And now we are tightening up the lateral ATFL, CFL. You see here, that's the other important thing. You always leave your heel off. So keep a sandbag on the ankle, but the heel off. You want to push the calcaneum back, okay, and then tighten up your ATFL, and then, sorry, CFL, and then ATFL in a neutral position. So in a CFL in maximum eversion, and the neutral is ATFL. So that's you, and always start from posterior to anterior. And now we are taking the rest of the tissues distally and the periosteum flap on this side and tighten up everything. So that's your Gould modification. So this all protects everything on the lateral side. And that really gives a very strong repair. And you don't need many times now, if you have a good soft tissue, you don't need a synthetic reinforcement or augmentation. Now we move to the medial side. Again, tip of the medial malleolus, incision centered on the medial malleolus. I don't know why there is a lot of glare there. Here you don't see a glare on the screen. So expose the medial deltoid and then take off the deltoid of the medial malleolus. So that's where the plane where I want to enter into the deltoid. Lift it off. That was lax. You want to make sure you identify, if you want to go posterior, identify the tip post. That's your extent of your tip post, extent of your deltoid elevation, I would say. And then identify the tip of the medial malleolus, drill it, pass a wire. And this is a 5.5 mm, again, double loaded with needles, anchor, pass it. And then again, double bridge the whole medial malleolus and lift it up and tighten on the medial side. Okay, I'm just going to go a little bit faster. That's been done. So just tighten up, and that's finally the repair. And then we compare your pre-op, you see the lateral side, and also see the rotation, how the rotation of the talus is reduced. And after that, again, an ankle arthroscopy was done, and you can see now there is no drive-through sign. I can't put my probe, is just about going in. I can't put anything. I can't put my shaver inside. Okay, you see how stable it has become. Okay, even there, you can see, I can see the whole thing, but it's all really nicely tightened up everything. Okay, and then a nice movement. Okay, that's fine. Thank you so much. Questions?
Let's open it up to the house. Any questions? Now, instead of just a lateral ligament repair, you saw both medial and lateral.
May I ask one question from
Yes,
Indore?
please go to Jodhpur.
Indication of reconstruction of ATFL over the repair.
Construction over repair of the ATL. When do you do it?
So it's always repair stroke reconstruction. You never do an acute repair. We never do it except in very few selective patients. Most of our patients will come with after 3 months to 6 months failed conservative treatment. You would always elevate it, repair the ATFL CFL, and then the gout modification, which is the extensor retinaculum, tightening it. You always do that. And if as I said, if the tissues is bad, then you put a synthetic. Now synthetic, you have a lot of synthetic options, and the new one are the collagen options as well. So you can do that. I don't think so in the foot and ankle world we are doing anything of the tendon allografts or any transfers. We don't do that.
Okay. Pradeep
Sir,
bhai, from Indore.
From Hyderabad,
Yes, sir.
sir. Special
Hi, sir.
greetings. Special greetings to
Sir.
Pradeep, sir. He is a regular visitor to our Hyderabad.
Sir.
Dr. Pradeep, sir. A
Yes,
special
sir. I
greeting.
can see you. Hi.
Dr.
Hello, sir.
Ravindranath, what
Sir.
did you do to your mic? How did it start working suddenly?
Yes, sir. We have given a PRP injection, sir, to the mic. Sir, do you do any other additional, like a Christmas snook procedures if you can't repair the ATLF? Tissue is not good at all. So do you do any peroneus brevis transfers or anything, sir, for lateral ligamentous complex?
So I think that's a very good question. And as I said, if I feel that the patient is superbly lax, I always keep the internal brace stroke now collagen scaffolds on standby. And if I can't get the tissue nicely covered and I find it's flimsy, my needle is cutting through the tissue, I would use an internal brace. I do not use any tendon transfers, the Christmas snook or the peroneus longus, anything. I think now with the internal brace and synthetic collagen um, uh, tapes available, I don't think so we need to do that, because effectively if you use internal brace or the collagen, you add only 5-10 minutes, while with your whole Christmas snook, understand all the tendon transfers, the Christmas snook and everything, they are non-anatomic transfers. Okay, if you were to do a separate allograft and do a separate Y type reconstruction, that's your anatomic reconstruction. But I don't think so we do that, and I don't think so we need to do it.
Right.
Pradeep bhai.
Ludhiana, any questions from Ludhiana? Ludhiana, what about, are you all routinely using these kind of fancy things? Suture anchors, scaffolds, artificial biosynthetic ligaments, or you all are using traditional stuff for reconstruction of these ankle ligaments?
We have been using suture anchors and even internal bracings. I have also used earlier some allografts also. I've put one semity in a sports person. But yes, as Dr. Pradeep has said, now we don't need to use all those things. So yes, we have been doing.
And how is your experience with these artificial ligaments, etc.?
It was only one patient, and he was a sports person, football player, and he ruptured it, and he wanted to get it back. And I think he was a Canadian, so he's doing good. He's still in touch with me. He's doing good.
I think Ludhiana is full of Canadians and rich Canadians, so there is no problem with money. What about Alwar? In Alwar, do you have access to things like the suture anchors and the tight ropes and the ligaments that they've been talking about? Can we unmute Alwar?
आवाज क्या लगाओ, मतलब इधर से जो बात करना चाह रहा है उसको भी बात कर लेने दीजिए.
कौन बात करना चाहता है? इंदौर?
हाँ
बोलिए सर, सबको बोलना
नहीं
चाहिए.
नहीं Pradeep bhai, it was a wonderful case, nice dissection, nice reconstruction, and
Alok bhai, thank you.
yeah, the thing
Question from
the thing is, you did, I think, please correct me if I'm wrong, the history is of 2 year duration, right?
Sorry? Yes, she
The
had history
history
of 2
is
years.
2 year duration. Okay. Now,
Correct.
my first question, we did a close reduction of the syndesmosis.
Yes.
We did a close reduction of syndesmosis. One thing. Second thing. Now, since we did a fiber means this thing, but do you think reduction or fusion, which would have been better if at all the syndesmosis is at fault? Because after 2 years, putting in this fiber tape, this thing is tightrope. Will it work and will the patient work on that alone? Because ligaments are not possibly likely to heal if the syndesmosis was disturbed at all.
Alok bhai, excellent question. And I think as usual, we always come out with something different. And I think one thing is there, a fracture case with a syndesmotic ligament injury is probably different than these kind of chronic instability where you have a ATFL, CFL and a ankle instability, which is around 30% case. But no, I do not have the complete answer that should we have gone, opened up the syndesmosis, done a double fusion or sorry, a double ligament repair or an allograft repair or put a plate and a screw. I have no answers to that. Rajiv, I want to add any word.
See, my protocol is very simple. If a syndesmotic injury, whether it's a post-trauma, or is like isolated, beyond 9 months, I always go in for syndesmotic fusion. So by 2 years, if you see the literature, there are very, very, very few people doing repair. It requires a very strong reconstruction. You always need 2 screws and a plate plus a fusion. By 2 years is a long time.
पर राजेश सर एक चीज बताइए, is it the effect or was it the cause? I mean to say, lateral instability resulting in kind of syndesmotic laxity, or it was the cause? Means the point means cause and effect relationship can be tried to establish retrospectively. I'm not saying that we have to reach on a certain conclusion, but something.
So I don't know what is because she started with probably a deltoid and an ATFL and she just walked around and then she got a syndesmotic some pain. We don't know. So either is it or 30% of the time, and that's just from the literature where ATFL is associated with AITFL injury. And then they continue with it and then have a deltoid as well. We don't know. But the point, one thing is very clear, to identify these patients where you will only think about lateral ligament instability and only go for a lateral ligament and the patient still complains of pain. 30 to 40% of times, these are multi-directional instability. So assess your patients carefully. This MRI which I showed was reported normal almost, just a little bit of synovitis. But with the clinical assessment and then going through the MRI again, we could pick up all the stuff and get a repair done or at least treat the whole thing. Now, contention is, do you do a syndesmotic fusion or do a 2 tightropes or can do a collagen? Again, you have syndesmosis, also you can do synthetic or collagen stuff. That's a separate debate. But identify the cause and treat them appropriately.
But I
Thank you
compliment
very
you
much,
on
Pradeep.
using the scopy to the best of its advantage. Here, the scopy did a phenomenal job. Thank you, Pradeep,
Yes.
for enlightening us.
And I think that's why every ankle instability case, I always scope them. It adds 5 to 10 minutes max, but it gives you really great value. And also sometimes you can pick up a lot of other things. Thank you.
Thank you.
Hello,
Pradeep.
A question from the Merit also. Can I
Yeah,
ask?
please go on, Mirat.
As you repair the deltoid ligament, is it the reefing of the ligament or is it the like a pressing of the ligament over
Double
the?
resting of the ligament.
So yes, so what I did was I lifted it up the whole thing and then put in an anchor and went more distal, reefing it up. And the proximal part, again, I put it on the periosteum. So I almost tightened up the whole thing.
So
2
it is
layers.
a combination of both
Yeah,
this.
for acute injuries of the anterior talofibular, calcaneofibular, you said you never operate. So what is your protocol for these acute sprains? where both the things are ruptured?
So again, they depends on how they present. If they're saying that they really had a sprain and they just could not walk and swelling immediately like a golf ball, then that's a serious injury, right? I would put them in a slab or a walker boot for 2 to 3 weeks. Let everything settle down. The swelling goes back. The bruise may be there, but it will settle down, and then do a whole rehab process. Rehab process is for 3 months. Rehab in terms of exercises. No ultrasound, no infrared, all that is all fine. You can do it. Is the exercise. And the exercise also has to be sequentially increasing in nature. From range of movement to proprioceptive to wobble boards to real strength training. Then we assess them at around 4 to 6 months mark. Are they in pain? Are they pain and instability or painless instability? Okay. Or they've got better. So they've got better, they will never come to you. So pain and instability. If they have only pain, then we talk at around 4 to 6 months mark. Do they want a continue with the rehab or give them a shot of injection? Now again, that's a debatable thing. You can do a steroid or PRP. We have a lot of large work done by my fellows. PRP works. If you have pain and instability, then you have to assess again if you want to go with steroid and then see. Pure instability, if they're really unstable, then you opt them for surgery. That's how I would do it. If they're very mild, don't need to put them a slab, give them a stirrup brace and start with physiotherapy almost in 2 weeks time. The key thing, so I don't know. I have seen more CRPS post ankle sprain than my post-op patients. I think post-op patient, they're mentally already ready that they need surgery, so they are up for it. Ankle sprain, if you immobilize them a very long time, 6 weeks, you're bound for CRPS, almost guaranteed. So don't do that. Don't immobilize them for more than 2 weeks. I think that's the key thing.
Thank you. Thank you very much. We'll move on to the next case. Again, that's going to be Pradeep, and he's going to talk about ankle arthrodesis.
Sir, one more question. This was 2 years old injury. Patient was walking. Still, why there is no arthritis?
You have to ask God that, no?
Means what? Okay, so that's a different question, and it's an interesting question because in IFSCON we had a nice ankle session. The ankle, so though the literature suggests that a 1 millimeter shift or a step in your ankle joint, 42% increased stress on the cartilage, right? But the cartilage of the ankle is better and different than the knee and the hip. That's one part. Second, she had instability, mild micro instability. You could see that, or micro, or you could actually visualize on the arthroscopy, but not on the C-arm. So yes, if she would have continued for 5-10 years, she would have had arthritis. But at 2 year time, I think it's very early for arthritis. Coming back to the question, we get a lot of patients who have had instability for 15-20 years coming with arthritis. Either they are in varus, they are in valgus, and they are anteriorly subluxed. Okay, that's a very common thing. So one of the question is, when you have chronic ankle instability and patient said, it's okay, I'll rest it for 2 weeks, 3 weeks, and I'll go back to my work. Don't do that. These patients needs to be stabilized for avoiding long-term arthritis. Okay. More questions? So ankle fusion. 51-year-old male presenting with right ankle pain, 1.5 years, tried conservative treatment. So look at this. This is a typical case, okay, where you have this chronic instability present with multiple osteophytes present in the front and the back, okay, which the body or the nature is trying to stabilize this ankle. Okay, that's very, very important to read that. Now, such patients, if you tell them that you will do an ankle arthroscopy and remove all these osteophytes, you will make them worse. You will not make them better. Okay. So here you see the other thing is, I don't know, I'm sure the previous speakers have done, always get weight bearing x-rays. That's very, very important. And this is another view. This is a Saltzman view, standing Saltzman view, which tells you, so it's an axial view, but a standing, which tells you how much is your hind foot, varus or valgus. So this is the clinical assessment. Now, this patient would have definitely had some previous ankle sprain. It's just gone about, and you can see how the ankle is now tilted in varus. So these are the cases where, as I was saying, people say, no, just leave it. Yeah, you leave it and then you end up like this. Now, if they would have come very early with only mild arthritis, you can still reconstruct the joint. But now it's too late. You can have a separate debate. Do you want to fuse it or do you want to do ankle replacement? Okay, that's a separate debate. But for the sake of basic stuff, let's talk about ankle fusion. So always get weight bearing front views. Look from the back as well. And the gait. Very, very important. See how he's seeing. You see the heel from the front. So that means it's varus. It's a peekaboo sign. I think Shyam mentioned about that. So you can do it various ways. How would you do it? An ankle fusion. There are various ways you can do it. I think whatever you do one thing properly. You can do an arthroscopic ankle fusion. If you don't have much deformity, you can do it through a front approach, an anterior approach. You can do through a lateral approach. That is a transfibular approach. There is no right or wrong answer. You can choose whatever you want to do it. But as I said, the basic principles of an ankle fusion should be adhered to. Okay. So that means what? Sorry, I don't have that in here. So what is the basic principles? One is you have to get your opposition right. Joint surface is prepared properly, and the alignment. The alignment has to be neutral. That means 90 degrees. So here you should, okay, neutral to slight 5 to 10 degrees of valgus and around 5 to 10 degrees of external rotation. That is very, very key. If you don't do that, thou shalt put not the ankle in varus. Okay, because if you put your ankle in varus, that means you're bound, your patient, it may fuse. The patient will really, really curse you, if not like you. Okay, so here we chose, see, that's your pre-op assessment shoot. You see how much varus you have and how much that is. Now, again, you can assess, is it a fixed varus or a flexible varus? Now, why is it important? It is important to understand that if it is only a flexible varus, that may be a little bit of bone loss, you may be able to correct it without too much of a soft tissue. While if it is fixed, that means either there is bone plus your ligaments, you need to do something about it. Plus minus any release on the medial or the lateral side. Okay. So here we chose to do an anterior approach. So anterior approach is a slightly medial to the midline. Expose the, see the anterior tibialis anterior sheet. Now you can choose to go medial to it or lateral to it, but try to keep the sheet of the tibialis anterior intact. Once you shift the tibialis anterior sheet, you just go through the bed of the tibialis anterior sheet. There is nothing. Few bleeders which supplies the ankle joint. Cauterize it. There's a lot of synovitis or synovial tissue in there. Just remove it, and there is your ankle joint. So here it's between tibialis anterior and EHL. You just retract it. So your neurovascular is lateral side, and that's it, done. There is your ankle joint. And you can see a lot of osteophytes present. And also you want to retract it medially and laterally because you want to make sure you see the whole joint. Through the front, you can prepare almost 80 to 90% of your joint. Okay. And now we are trying to remove all the osteophytes. Now the reason we are removing the osteophytes, so you can get your opposition properly and the placement of your ankle properly. So these are all the bone pieces which are coming out. You see how the ankle is so tight. My thin osteotome is not going inside. Key thing also is any ankle fusion, you should have a sharp instruments which you should be only using it. Keep it on the side, not the hip and the knee surgeons. The key in any fusion is preparation of the joint. Trust me. Otherwise, it's a recipe for failure for the fusion. Now you can start seeing the joint. You're about to just open it up. but you're still only on the anterior part. Now, this is the key thing. Any fusion case, I think I'm sure previous speakers would have done it. This instrument has to be there, the Hintermann distractor. Okay, not the laminar spreader. Yes, you can have a laminar spreader as a second part. This tool is very, very important. Okay, and these have multiple holes, your 2.5 mm wires, and then you can have the thinner wires of 1.5 and 2. Without that, ankle fusion, subtalar fusion, midfoot, can't do it. So please, please have that instrument. So as soon as you open it up, the joint starts opening up slowly, slowly. Again, all the osteophytes are still coming out. You okay with time, sir? Okay. There, now you can see nicely, you see the surface. Little bit of cartilage was there. Again, I normally don't use a saw, but here just to make sure to get that gap and that deformity correction a little bit, we use it. Sharp osteotomes, shingling, drilling. These are the three things which you should be doing for achieving success of the fusion of the joint. It's still in varus, so there we are going to correct it and also have the release. So here you can take your knife and you can start releasing a little bit of deltoid. You release it till you get the correction of the varus. That's very, very important. Once you do that, then you can hold it with multiple K wires to the position which you want it. Now, this is the key thing. AP. Underneath the, sorry, get your talus underneath the tibia. Okay. And try to get the talus posterior. If normally what happens is we're keeping the leg on the bed, that automatically pushes the talus anteriorly. So you have to get that heel free, push it back, get a dorsiflexion, hold it neutral, and somebody else fires the K wires. So once that's done, and then here we are using a plate for fusion. You can, as I said, you can use whatever you want. You can use a plate, you can use multiple screws. Choice is yours. So here we are passing one screw at the proximal part. It's a cortical screw normally. So that plate sits it down. And then the distal part, get the dorsiflexion and you pass your locking screw there. And there I'm correcting the deformity, getting the dorsiflexion, holding it there. And then you put that locking screw or a cortical screw. Depends on what type of plate you have. Okay, so that's there. And then whatever graph we had from all the bones, we just put it in between. If you get a good surface preparation, you don't need too much of graft. Here we put some synthetic graft as well inside and then finish it with all the locking screws to be filled up. That's your nice placement there. Yes. And then finish with multiple screws as well. Okay, AP and lateral. That's your lateral. And then closure. Here, by the time you finish, yes, your sheet may get opened up, but you close the sheet properly so there is no bowstringing. And then close the retinaculum as well. If you're worried about any wound issues, you can always put a small drain there. That's your final shoots. Okay, thank you so much. Any questions?
Typically, I never go through the sheath of tibialis post anterior. Yeah. My mentors taught me that never ever open tibialis anterior sheath. It will pop up, will not be able to close. Majority of these soft tissue issues which occurs after uh, TAR, total ankle replacement or anterior approach, are because of tibialis anterior. So remain aware. It is through the sheath of EHL that we go. This is one thing. Second thing, to me, this was a case for a lateral transfibular approach. The huge osteophytes posteriorly, and you could not shift the talus down, and still it has remained into the varus. That's that apart, but you are not able to really generate a good tendoachilles shift by a lateral transfibular approach. You are able to go posterior to the tibia and talus, and you are able to release everything. You are able to release the capsule and on. You are able to push the whole talus back. So there are cases where you need to go transfibular. That's a better approach for certain cases. Obviously, entry approach is also a good approach, but mind you, entry approach has got lot of soft tissue problems. It has got good amount of soft tissue problems. So be aware about this.
Okay, thank you so much, sir.
Pradeep, this TCC nail, that TTC nail that you use for fusion, now there is no preparation made for the talus and the tibia as you have done over here. And then I think you have passed those compression screws also.
Correct.
So how does that fuse?
So TTC, if you are doing a percutaneous TTC for, say, arthritis, one is,
yes,
you should not be doing it. Here, you're doing an ankle fusion only. Here, only an ankle fusion. So a tibiotalar fusion and a hindfoot fusions are different.
So my question is, how does it fuse when the ankle is not
So it is
prepared
not
as you have
fused.
done?
So it is not, doesn't fuse it. The failure rate is very high. One is that is very high. But my point, one more point before that also. No, he's saying
I'm
if
saying for
people are doing
TTC
percutaneous.
nail, when there is no preparation done for the ankle joint between the talus and the tibia, how does that ankle fuse?
So that is done for the Charcot.
No, sir. Sir, what sir is saying is for arthritis only people are doing TTC.
I think you have to prepare. You have to prepare.
So that is what I'm saying, sir. So message is, so that is what I was coming to. If you have a pure ankle arthritis, please do not do TTC. That is the message which I was coming to it. Pure ankle arthritic patient, please do only tibio-talar fusion. Just because you have a nail, just because you can do a small incision and pass the nail in 20 minutes like a proximal PFN, that is not the answer. And of course, if you do not prepare the joint, it will not fuse. But also what you have done in the process, you have buggered two joints. Subtalar joint is very, very important. A patient with an ankle fusion, I can bet on you 90 out of 100 people will not be able to make out if that patient is walking in a normal shoe. They will not be. But a TTC patient, everybody can make out. So an ankle arthritis patient should not have a TTC done. Okay, that is the thing. It is an ankle fusion. That means a tibio-talar fusion. You can choose, as I said in the start, you can choose how you want to do it. You can do arthroscopic, you can do anterior, you can do lateral, you can do posterior, whichever way you want. But please, subtalar joint is there to not to be sacrificed. That is very, very important message, sir.
One more question. In my time, I have used calendruccio clamp. You see, there was some one pin going in the talus, one in the calcaneus, and two in the tibia, and then compression. So is that used now, or you prefer compression screws as you have shown?
So if I'm doing an arthroscopic, I would do an arthroscopy cleanup, or now I do MIS. So I don't even do arthroscopy. I do MIS, prepare the joint, and percutaneous 3 or 4 screws. And these are beautiful screws. 2 Arthrex is this, Bone Tech has it, now Nebula has it. They really give you differential compression. I do not like using, I've stopped using last 2 years, I've stopped using cannulated CC screws, partially threaded. Partially threaded screws just give you compression on table, done. That's it. You will not get more compression. Get a differential pitch compression screws. They really hold, they really give you compression. And one wire, one screw at a time. One wire, so when you're putting it, you put one wire, you put your screw. Then put another wire, put another screw. It's not like put all the wires and then start screwing. you will not get that compression.
From talus to tibia.
So whichever. So again, it depends on the deformity. So like here, if you had a varus deformity, my first screw will be the lateral side screw. If it is a valgus deformity, I will put my first screw on the medial side. So that corrects the deformity. That pushes the talus where I want it to.
So what I want to say is it's a conical screw, is it not? So therefore you will have to pass it from talus to tibia.
No, you can do the other way around also. You can do from tibia to talus also.
How tibia can compress talus?
No, so
the
but
tibia is not going to move.
No, but it does still pull it, na? It pulls it. The screw pulls it, sir.
There
Sir,
is
one question,
a
sir.
screw which is called as home run screw, which passes from the posterolateral aspect of tibia and goes up to the neck of the talus. So that is the screw. When you're using screw construct, you put it first. And that screw pulls the talus back over the tibia. That is the longest screw. That is home run screw.
Pradeep bhai, Dr. Negi from
Now
India.
I do 3 or 4, depends on what I want. So one screw, I also now put it from that fibula into the talus. So I get like a box construct, which is engineering principle. It's a very stable. In plates, I just put them in a slab for 2 weeks. I start mobilizing. Weight bearing at 6 weeks, but mobilize at 2 weeks time. With screws, I put them in a cast for around 4 weeks time.
So Dr. Saraf, please go ahead, ask the question.
Sir.
राम कुमार को भेजो, दीपक राम कुमार को भेजो.
Dr. Saraf, you have a question? No?
Yes, sir. What are different complications of arthrodesis, like non-union and malunion? How you tackle those complications?
I think that's a very good question. People think, now again, step before that is people talk about ankle fusion versus ankle replacement. Yes, ankle replacement, people talk about wound complications and survivorship. And ankle fusion is the gold standard, but there's still, I would say, yes, gold standard, but still have a complication rates. If you actually go through the literature and the latest systematic review, it's almost 8 to 10% non-union rate of ankle fusion. Now, probably a lot of people are doing TTC and that's why they're getting a non-union. We don't know. Yeah. So yes, if you do have a non-union, find the cause of the non-union, find the alignment if it has been done. Have we prepared it or not? And also the patient factors, like patient is a smoker, tobacco chewer, diabetic, circulation. So all that you have to optimize it and then treat it appropriately. But if your talus is not of good size and it's completely eroded, then you may need to do a lot of allograft, put in a iliac crest graft. I use BMP in all my revision cases, and you may need to then use a TTC for that. You have to sacrifice your subtalar.
Yes, Burdwan, please go ahead.
Sir, one question, sir.
Yeah, please go ahead.
Hello.
Please ask, Burdwan, please ask your question.
Hello.
Yes, we can hear you, sir. We can hear you.
Hello. I am from Bardhaman, West Bengal.
Yeah.
Sir, many thanks for this beautiful presentation. The thing is that in a severely arthritic ankle, how will you prepare the medial malleolar side or lateral malleolar side?
How will you prepare the
Medial and lateral side.
Yeah, so the key thing is you may not need to go into the medial and the lateral gutter as long as you prepare the surface. That means the tibia surface and the talar surface. You're still good to go. You still get good fusion rates. Okay. The only thing is if it is severe, as I said, if you're in severe valgus, severe varus, then you may need to open up the medial gutter to release the soft tissues. But otherwise, you do not, normally you do not need to prepare the gutters.
Okay.
Hello, this is from Indore.
Yes, Sangli, please go ahead.
Hello, Pradeep sir.
Audible?
Yes.
Yeah,
Hello.
Please go ahead. We can hear you. Please go ahead.
Sir, you said regarding passing a screw from fibula to the talus, but for a box-like construct. Okay. But
yes.
you are not preparing the articular surfaces on either sides of lateral side, especially not denuding the articular surface of fibula and lateral surface of the talus. But still you want to from fibula to, and in that case, do you osteotomize the fibula?
No, so again, there are, as I was saying, we were talking of multiple different types of cases. If I was doing an arthroscopic ankle fusion, where I can see almost 80% of the surface area, I can't see at the back. But then I would put my burr and go on the medial side and the lateral side, gutters. You can put your burr in there, or I have an MIS burrs now, minimally invasive surgery burr. I can put my burr in the lateral gutter and the medial gutter and prepare it. It just gives, it's like minimally invasive. So you just see it on Siam, clean it up, remove the whole flurry of the whole thing, and then put in a screw. So again, it depends. Not every case I would do the same thing. But if you were to do that screw, then yes, you do need to prepare the lateral side. Or if you were to do a trans fibula approach, in that case, you would take the inside part, so the inner part of the cartilage out, and then put the fibula back and then put the screw.
I think that's self-explanatory. Yes, Dr. Saraf, please go ahead.
How you compare the functional outcome between ankle arthrodesis and TTC? My question is, how you compare the functional outcome? Are you hearing me?
We can hear you very well. This question was already asked, sir, about 2 minutes ago. And Pradeep answered that question, but he will still answer it again. Pradeep, please go ahead.
So I understand it. You want to know the functional outcome between ankle fusion and ankle replacement. Is that correct?
No.
Between a TTC fusion and a regular ankle fusion.
Oh, TTC fusion and ankle fusion. There's no, the functional outcome with an ankle fusion is much, much better than a TTC fusion. Full stop. There is no question asked. Subtalar joint, if it is normal, please, please, please do not sacrifice it. Okay, just because you can do in a small incision, a TTC nail in 20 minutes, that's just not the answer. You need to prepare the joints and only fuse the joints which are damaged. Okay, the gait of an ankle fusion is near normal. I'm not saying normal, it's near normal. But a gait with a TTC is stiff. Okay, they will always limp. I
Hello,
hope that is clear.
I have a question from Merit. So,
please go ahead.
With the TTC nail in ankle, I mean to say, if the arthritis in the ankle joint is severe, there is a possibility of developing a subtalar arthritis in future. So, is it not wise to put a TTC nail after preparing both the joints?
So you find, suppose let's assume the fact that the patient had an ankle fracture, which was arthritic, has an ankle arthritis. Okay. I would just do an ankle fusion. Why would that patient have a subtalar arthritis? A normal person, a normal 80-year-old patient does not have a subtalar arthritis. You just don't have age-related osteoarthritis in subtalar joint. How many times you have seen? We don't see it. It's usually inflammatory or some other causes of it. Just because in future you may have a subtalar arthritis, that does not mean you should fuse a subtalar joint.
So for everybody, let me clear what all are the indications of doing TTC nailing in a case of ankle arthritis. If the patient is a case of Charcot or a diabetic neuropathy case, you always want to augment the fixation. Therein you need to use TTC nail. That's one. Second, when you have a deformity, where after correcting the deformity, you will end up with quite a loss of talus, or you don't have enough talus to hold your implant. You might have to spend to go to the subtalar joint. So these two. And the third, if it's in a case of avascular necrosis talus, where the whole talus has gone into avascular necrosis, you don't have a good bone for the union, you might have to go for the TTC fusion. These are the indications for nailing for ankle fusion. Otherwise, as Dr. Pradeep said, don't sacrifice subtalar. It's an important joint.
So one more indication I would add on to that, it's an inflammatory arthropathy patient with rheumatoid or anything, where both you know the fact beforehand, your ankle and the subtalar arthritis, then you would do it. Otherwise, as I said, the outcome from ankle fusion versus TT fusion is completely different.
Yes, Indore, please go ahead. So Indore, it's not that we are ignoring you in any way. It is just that if you put your hand up, we can see it, we will give you a chance. Everybody needs to get a chance.
Yes, sir. Thank you very much. This is Bhupesh from Indore. Pradeep sir, this is basically a question from Dr. Asim Negi sir. And already Rajiv sir has answered this question. But still, do you believe in your case, particularly the subtalar joint is a moderately arthritis and you may have to opt for pantalar fusion, or it's basically a CT scan finding you ignored the subtalar arthritis?
So I think again, in my case, the patient had very clear. So in a clinical assessment, there was no tenderness over the sinus tarsi, both lateral side or the medial side or the sustentaculum tali. He was only tender on the ankle joint area, so anteromedial and anterolateral joint line. And so I was quite happy that patient would do only with a ankle fusion. Now, after the ankle fusion, I still find that if the patient is in slight varus or valgus, I always have an option of doing a calc osteotomy and maybe correcting it. That's the one thing.
One very important thing in foot and ankle orthopedics, radiologically significant looking arthritis may not be clinically relevant. So go for clinical evaluation. Your radiology may show very bad arthritis. It may not be symptomatic clinically. So it's your clinical evaluation which makes sense.
With those words of wisdom from Dr. Rajiv Shah, if there are no more questions from the audience, we may move on.
Sir, one question from Burdwan, sir.
Question from Ludhiana. Yes, please go on.
As there is,
We'll first go to Burdwan, then we'll come to Ludhiana.
as there is,
Burdwan, go on.
sometimes it is chance of implant breakage. Now, you have said that there is the bending of the plate. Then what type of plate should be used for better better avoid this implant breakage or any other things?
So I would suggest, as I said, if you stick to the basic principles of any fusion, the chance of union are still 92%. Okay. So that's still a very good success rate. Now, just in case if you do have the primary fusion failed, then you have to identify, like any non-unions, you have to identify what was the cause of it. Was it the patient factors or was it the surgeon factors? Have you actually aligned? So patient factors, we have already gone through it. I'm not going to repeat the whole
diabetes, smoking,
smoking, peripheral vascular disease. Okay, so all that stuff, severely obese, and the surgeon factors. Surgeon factors, as we discussed, few. Joint preparation is the key thing. Okay, you cannot leave a gap. You have to have good opposition. All cartilage has to go. At least 80 to 90% of cartilage has to go. And you have to do shingling, drilling. That's a must. And if you want to do, if there is a gap, you need to put some graft in that. That's one thing. And then first it's preparation. Second is stability. Have you given adequate stability? You can't rely on K wires only. You can't rely on only one screw and say, I will put in a cast and leave it. I think you have to get good stability so that joint unites. But sometimes it doesn't. And if you have the revision cases, and as I said before, you have to remove all the implants, go back to square one, assess the patient properly. You at that time in the secondary, you will have to put some autograft. As I said before, revision, all revisions I put BMP. I think it's expensive, but it really works wonders. And then also stabilize the joint. Okay, you probably want to put more implant, but good implant and get a good fixation. That's the key thing.
I think, is there, what he is asking is that
which type
you
of plate
showed
should be used?
use of multiple screws.
Yes.
But do you use a plate ever? And if so, what type of plate for an ankle fusion?
Okay, so there are different types of plate for ankle fusion. The anterior plate is a L type of plate. Again, you have two versions, as a short and a long plate. Lateral side, you have a lateral ankle fusion plate. Again, Indian and imported, you have that as well. And then you have an options of multiple screws. These are the three things you have.
Meerat, please go on. Meerat, you had some questions? Yeah.
The question from Ludhiana.
The most important thing is your screws should not cross at the fusion site. A majority of the failures I have seen is that they put in a good screws, but the screws they cross at the fracture site, which is a distraction force. and your fusion will never happen. So make sure that your screws should not cross at the fusion site. That's one very important thing. The another thing, that there is another view that multiple screws, they reduce the fusion area. You put in 6.5 mm, 3-4 screws, it reduces the fusion area. So people have gone to 4 screws of 3.5 mm. So think about it. That is also important, that not your multiple screws doesn't give good fusion. If you put in multiple screws, you're reducing the fusion area. That's also very important.
Yeah, Ludhiana, please go on.
That's the role of fibulectomy in the anterior approach of this ankle fusion. Fibulectomy.
Fibulectomy. Fibulectomy.
So I do not think from the anterior approach, through the traditional anterior approach, you will be, excuse me, you will be able to go as far lateral onto the lateral part of the fibula. Okay, you can just about go to the lateral gutter. That's about it, because all the ankle replacement, when we do it, we have to go through the lateral gutter. That's about it. And why would I do a fibulectomy? If I was to do it, I would not go through the anterior. I would go
So,
through
sir, if you are doing what Pradeep mentioned is that sometimes you would do a transfibular approach, which is a lateral approach to achieve, to go into the ankle and do your fusion. If you are doing a traditional anterior approach, which is what he showed, then you really don't need to go laterally and do a fibulectomy. You just need to take off the cartilage from the talar surface, that is a talar dome, as well as possible, and in order to do your fusion. I hope that answers your questions.
Okay.
Is there any specific indication where you would do a fibulectomy? Yes.
For me, if my patient is to go in future for ankle replacement, I will not go with a lateral transfibular approach, but that sacrifices fibula. So all other cases, I like to go lateral transfibular. You can correct the deformity, you can do the everything with the lateral transfibular. But the case is not like this patient of 55, 60 years where you're thinking of, no. It is where you want to salvage the fibula, you go with an anterior approach. Because that is how, so no question of doing anything to fibula when you go with an anterior approach. Yeah. You want to salvage fibula for later that total ankle replacement.
Right? With these words of wisdom from the Grandmaster himself, I think we call a close to this session of cold orthopedic videos. And I would like to, we will not be breaking as such for lunch, but y'all can pick up your lunch from outside and bring it in as the case continues. We'll get Samarth Thakkar to come up on stage and present again, take us through a little bit short quiz of some of the various important things that we have covered today. So we will not be breaking for lunch. We will be continuing, but the continuation will be along with with lunch. So people can fetch their lunch from outside and continue. Please go on, Samar.
Good afternoon, everyone. So we had a good discussion on lateral sided ankle injuries, ligamentous and bony. So now we have two quiz questions in pertaining to that. So literature, we all are aware of trimalleolar fractures, which is lateral mal, medial mal, and posterior mal. The new literature mentions a variant called quadrimalleolar fracture. So the question is, which is that fourth bony fragment for the quadrimalleolar fractures?
Yes, sir. Please go ahead. Yes. Any question? Yes, you're right. So anybody from the
Second one.
Yeah, yeah. Yeah, Burdwan, are you giving an answer?
Tilo.
Tilo fragment.
Hyderabad Leafort.
Okay, so Hyderabad is saying Leafort, Mumbai and Burdwan is saying Tilak's chaput fragment. Any other answers from delegates across? Okay, so if there are no more answers.
Jodhpur, Indore, Hyderabad. Any answers here?
Hyderabad, sir.
So we got all our answers, and then the right answer is Tilak's chaput fragment. But to be frank, Leafort is not completely wrong also.
So the new concept of quadrimalleolar fracture arises from the avulsion bony fractures due to the AITFL injury. AITFL is part and parcel of the ring injury concept of the ankle. So when the bony avulsion is from the tibia, it's the chaput fracture, and that has been termed as quadrimalleolar. Although if it happens from fibula, it's called the Leaford Wagstaff fragment. That is called as a quadrimalleolar equivalent fracture. Why it matters? Because when we have an injury of this sort, it is always a better idea to address the bony avulsion by bony fixation that would take care of the ligamentous instability. This is a generalization. Obviously, there are classifications for each of these fragments, and then the treatment varies based on that. So next question. So we have now interesting videos here for everyone. So this is a lateral sided ankle video. We see some snapping happening around the peroneal tendons here. And when the patient is asked to circumduct the ankle, at particular dorsiflexion eversion, we see a snapped peroneae. The question is, what structure is in pathology here? Anyone from Mumbai delegates? So the Mumbai delegate has answered inferior peroneal retinaculum. Anyone else from across?
Inferior retinaculum from Hyderabad.
Hyderabad is saying inferior retinaculum. Okay, anybody else? Alavar? Okay.
Any more takers?
All right, we come up with the answer, sir. I'm not giving you a third chocolate. Huh?
So the answer is a superior peroneal retinaculum.
It's not the inferior, it's the superior peroneal retinaculum.
The peroneal tendons stay in the retrofibular groove by function of bony anatomy, but also because of the ligament checkerines. The inferior is far below at the level of calcaneus. The superior is the important one. Now, the injury of this can be either acute or chronic. In acute, we see it sometimes in calcaneus fractures or in a severe sprain. In chronic cases, athletes with microtrauma adding up and causing this kind of a subluxation. Again, this is seen more common in cavovarus feet, but sometimes also in severe flat-footed patients. Thank you.
Yeah, go on, Samarth. One more question. We can be done.
Let's go to an anatomy question now. Let's stick to a simple anatomy question. Which of the following ligaments describes the Lisfranc ligament? We know Lisfranc is obviously a complex, but when we talk of the main Lisfranc ligament, which of these? Is it from the first metatarsal to second? Is it from first cuneiform to second? Is it from first cuneiform to second metatarsal? Or from second cuneiform to the first metatarsal?
Third option from Meerut. Third answer.
Anyone else?
Got an answer here from Bombay. Anybody else has any other opinions?
Between the second metatarsal and first cuneiform.
Answered that. Can you tell? I don't. Where did that answer come from?
From Meerut.
From Meerut, yeah. What was the answer? Can you please repeat it?
Between the second metatarsal and first cuneiform.
Between second metatarsal and first
metatarsal.
Okay. Anyone else?
Fourth.
First cuneiform to second metatarsal.
Cuneiform. First.
Indore, you're mute. If you want to answer, please unmute yourself. All right.
Okay. So
let's have the answer here. We have multiple different answers.
Yeah.
Let us see what the right answer is over here, Samarth.
The right answer is from second metatarsal base to the first cuneiform. Many of you answered it correctly.
Was it answered properly in Bombay?
Yes. Yeah, so it's important to understand that there is no ligament existing between first and second metatarsal bases. By virtue of this, we have that increased movement in the first TMT, and the second TMT is a stiff joint. The other important thing to remember is the second metatarsal base is recessed within the cuneiforms. It is notched within the cuneiforms. This confers a lot of bony stability, but in addition to that, the ligament confers more stability. And it is this ligament which is often avulsed, giving a flex sign on the foot AP X-rays of Lisfranc injury cases.
Right. Thank you very much, Samarth. We take a short break for 5 minutes for refreshments, and then we meet again to continue with the next session. And the next session is going to be a trauma session where we are going to show a bunch of trauma cases.
ये कब तक चलेगा भैया बस रिप्लेस का टाइम है 4:30 म्यूट है ना और नहीं है, वो तो आप मतलब माइक से बोलूंगा
लगा भाई सर अरे यार ఉన్నారు అందరు లైన్ లో ఉన్నారా ఉన్నారు పక్క ఏది తీసేయలేదు రికార్డింగ్ పెట్టావా రికార్డింగ్ అయిపోయింది వాళ్ళకి రికార్డింగ్ చేయట్లేదు చెప్పలేస్తావు ఏదో ఇచ్చేస్తున్నా చేస్తున్నా పూర్తిగా రికార్డింగ్ అవసరం లేదు రికార్డింగ్ ఏంటంటే క్వశ్చన్ అండ్ ఆన్సర్స్ రికార్డింగ్ కావాలి వాళ్ళకి అంతే ఆ క్వశ్చన్ అండ్ ఆన్సర్స్ రికార్డింగ్ సౌండ్ పెట్టవా నువ్వు సౌండ్ పెట్టావు నైట్ టైంలో నేను పొద్దున్న చూసేదే అనుకున్నా నీ అమ్మాయి వీళ్ళు మంచిగా కొడిపిస్తారా ఏంటి అనుకుంటున్నారు ఎవరు లేరు కదా ఇలా నా రౌండ్ అడిగినప్పుడు నువ్వు అడుగుతాను వద్దంటే అందరూ పట్టేది కదా సార్లు అడుగున్నా లంచ్ ఉందా లేదా లేదంటే ఒక గంట తినేసి వస్తాం అని చెప్పి బయట చేసేయచ్చు కదా ఏమన్నా పెద్ద మనిషి చెప్తాను మీ ఎక్స్పీరియన్స్ ఏమంటారు ఆయన లేదమ్మా మీకు అలౌడ్ లేదు అంటారు అదే అన్న ఆయన అంటుంది మరి అదే మరి నీకు ఆయన అందరు తెలుగులో మాట్లాడితే
पूरा 2000 मिला अभी multiple disorders nailing भी करता है सर साथ में होते हैं बट लगी बस
And then one is I know why you have a separate I go in your video copy बहुत बड़ा नवाब गाड़ी ले ले तेरे बिल्कुल सबमिट आप जस्ट कर दो बहुत बड़ा भाई कह रहे थे गाड़ी में बैठा था तब वीडियो कॉल करा फूलपुर गए होगा फूलपुर नहीं हम इसलिए नहीं बोले ना हाँ वही वही मैंने भी याद फूलपुर में हो फूलपुर बस अरे फूलपुर में होगा कंप्लीट है वहां पे भी वीडियो करेंगे इंस्ट्रूमेंट्स भी छोटे छोटे हैं हैंडी इंस्ट्रूमेंट्स माइक्रोस्कोपिक सर्जरी है हैंडी इंस्ट्रूमेंट्स हैं और ज्यादा आवाज में क्लियर कर इंस्ट्रूमेंट्स और बताओ आवाज नहीं आ रही है ना पहले अभी तो सामान सारा ले लिए मैंने कपड़ों को 4-5 तो पर और आरएस तो आरएस मिल गया कहीं बाहर है ना देखिए पर भी आ जाएगा Tapi village juga village. Baas na ro check लोग है बाहर. आया. थोड़ा सा सन्नाटा चाहिए. हाँ. प्लेट तो ना है. ना ये टेबल नाम हो कितनी प्लेट है. हाँ बिल्कुल. बियर की बोतल भी यहाँ पे इंदौर में. ठीक है मानते चलो करो फिर मैं यार बहुत खराब है अलवारा में सराफा प्रयागराज नवाब पेंटर बड़े अच्छे हैं भाई लोग ऊपर वाला कमरा फाइनल करते हैं उधर वाला सब करके धुलाई उलाई सफाई फाई कर रहे हैं सफाई करके धुलाई करके चमका रहे हैं ऊपर ये ठीक है 30,000 फ्रंट साइज है भाई फ्रंट तो अपना पुट्टी पेंट हमारे अरे पुट्टी पेंट मार बहुत लोग का दिखा हुआ 15 लोग कोई 40 है कोई 45 है हाँ तो दो मंजिला है ना पूरा सामना है बाहर भी है 2 मंजिला है ऊपर नीचे तो सामना है आंगन है गलियारा है तब भी मान चलो 40-30,000 को कोई बुरा नहीं तो ये हम ठेकेदार का दे दिया ना डायरेक्ट पेंटर कर दिया हमारा दोस्त है।
हाँ हाँ हाँ, तब सही था।
अब यही चीज ठेकेदार चार्जिंग वाली
पुट्टी वाला
यही सब कर रहा है, डिजाइन ये सब बना रहा है। डिजाइन का पैसा अलग लगा था। यही सब मेजर टेपिंग डिजाइन जो होती।
हाँ हाँ हाँ, जो वो सीलिंग बना ना, सीलिंग
दीवार वाली टेपिंग के पैसा अलग लेते, सिर्फ मेजर टेप कर दे या एक दीवार को 2000 रुपये लिए फिर अलग से ये अपने कमरे में बनवा देना। वही सब कर रहा है, लेकिन नीचे वाले कमरे में ही बनवा हुआ है। सिंपल सोवर बनवा देगा।
बस कोई बच्चे बस खुश हो पहना कर
पेंट है, स्टिकर थोड़ी है।
पेंट है,
पेंट है तो टेप से के डिजाइन बनाए लिखते लोग पेंट भरा।
तभी पेंट में कितना लगा पेंट में।
अरे अभी तक लग रहा है हमारे काम से कल 15,000 15 से 20,000 से पेंट में लग चुका।
25 पकड़ लो, पुट्टी भी तो है।
नीचे बचा है अभी तो ऊपर फ्लोर हुआ ना।
अभी तो कहा कि ऊपर नीचे हुई हुआ
पर कमरा लैट्रिन बाथरूम आंगन सब ऊपर होएगा।
ऊपर दुई कमरा।
अरे किचन में ना लैट्रिन बाथरूम आंगन है।
आंगन है
होएगा कम से। अभी नीचे बचा है, बाहर भी बचा है।
Hello friends. Everybody is requested to come forward for a group photo. Please finish your meals. Most of the persons have finished their meals. So we will be taking a group photograph now.
अपना धुलाई करो, अपना रगड़ लो अपना।
ठीक है दोस्त, फिनिश करो, करते हैं आगे।
अब तक में कितना रह चुका होगा?
3 एक दिया, 3 एक दिया, एक एक दिया, एक एक दिया, फिर एक दिया। अब आप पैसा ना मांगे, हम आपका खराब नहीं सारी के दे 4,000।
अरे हो जाता है
दिहाड़ी के हिसाब से देगा ना पैसा।
अच्छा
मतलब एक ही काम करो 7 दिन 14 100 दिन से इधर उधर रात ज्यादा पैसा नहीं देते भागो लेकिन
मतलब दीपावली पहले 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 था, बहुत पहले
पहले अपना कमाना गाड़ी 10 लाख पहले कमाना। तो ये मान चलो 20 तारीख को ना हो भाई, लेकिन 23 24 25 कंप्लीट करवा दो
पूरा।
आप लीला भी जोड़ते विधान भी जोड़ते
धुलाई बचेगा
उधर सब कर रहा है।
अरे सामान भी तो करो आज का भी
धुलाई कर कमरा थोड़ा से कर 15 का नाम जाएगा।
अभी तुम्हारे यहाँ बत्ती बिल कितना आवर है?
1314 से
वही हाल अपना 1314
स्टील पंखा परमानेंट जो जलन वो बताइए, बाकी जो जलन बता रहा है।
इस पंखा परमानेंट कूलर
लाइट जलता है रात रात भर, बाकी सब जगह पर हो जाता है। बाकी जहाँ जला तो सूता मेरा 14 चलिए भगने करके नहीं सोई आराम।
हम लोग डायरेक्ट नहा सकते
भगवान शिवन मोटर हाथ में बैठा रहता है। जो आया था कल। हाँ हाँ मुझे कहा कि खूब आजकल इंडियन नारियल क्या उग रहा है। इतना बढ़िया 21 समय अगर भी पैसा काट रहा है सही होगा। हाँ हाँ भाई के गोद में ले लेके हम तो इसकी समय सोची भी थी इस समय 330 लाख मुझे अंदर कर चुका होगा। काम तो करा था पूरा खाना के देखना खाना का देखा था सुखाना तो सूरज देखा था। मैनेजमेंट तो देखा था मैनेजमेंट ये भूल रहे हो साउंड आर्टिस्ट स्टेज और ये सब रहा है फोटो और वाल अबे आ जाता है नेक्स्ट संडे पे घर चले जाए थोड़ा देख ले अगर बैठे हुए मतलब पीछे में कमरा होगा तो शायद ये ब्राउन कलर वाला खिड़की दरवाजा लपन तो कब डाला है। काम करना अभी जब शुरू हो जाएगा 10 मिनट वाला दिखा दी निकल जाएगा प्रोजेक्टर ऑफ जी तो वहाँ तो वहाँ में ना हम कैसे और पागल प्रोजेक्टर बहुत चला हुआ है। ये जो लाल लाल बटन हुई का तो एक बार से दाबो ऑन सही बात है सही बात 1 2 जब बंद करना फिर वही सही बात बना पहले मैं जब लाइट चलेगी मान लो तो वहाँ लाल लाल बत्ती चलने लगेगा जहाँ लाल लाल बत्ती चलने लगेगा वही नीचे बटा एक एक दो रखो तो बत्ती नीचे नीचे चले लगेगा लाल से नीचे नीचे होगी और जब चालू पे बंद कर दो पीले में जरूरत नहीं जब बंद कर दो तो फिर ला दो मांग रहा है क्या चलन हो रही है यहाँ नहीं बेटे नहीं कुछ चोरी कर ऐसे उसको भेजो कर दे अगर ऐसे वो नहीं मुश्किल तो जैसे हिल रहा है काम अच्छी भाई हाँ हिल है ना हाँ हिल है ना ना कैसे आई है तो चली बाबू ने मार
ఓ నేను బోర్ రాను మళ్ళీ పోతే అంతే కానీ కాలుస్తూనే ఉంటారా
सुनो अनियो ले 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 हाँ एक बात ले ये ना समझो
నాకు ఒకసారి వెళ్ళిపోయింది ఆయన కదా అన్న ఆన్సర్ చెప్పవా అన్ని
पंद्रह 50 दाम 500 मंगवाए वापस कर देंगे करके
सर अभी वहां से स्टॉप है अभी तो बनी बता रहे हो कोई कोई दिख नहीं रहे नहीं लंच चल रहा है बेंच चल रहा है सर बोला था लेकिन ये म्यूट लगा देखिए रवि वो चालू है क्या अभी बंद है ना ठीक है ना दोनों पर्चे भेज दो देखे लिखे नहीं कौन सी दवा है भेजो हम देखते हैं हाँ तो जब तक सब लंच पे चलेंगे ठीक है जी सर जी जी इसको लोअर एंड कर दो वहाँ पे अभी बंद है हाँ बंद है ठीक है हाँ लंच कर रहे हैं आ रहे हैं ये रुंदा होता है अभी आधे घंटे में आ रहा Yes, yes.
Hello, friends. We are just about to start the session again. I take this opportunity to thank our sponsors, INTAS, Aquila Division of INTAS, who have made this wonderful meet possible. And this has been a very well-organized session and very knowledgeable conference by the Bombay Orthopedic Society. So I thank INTAS once again, and they are promoting their brands Gabapin Anti, etc. So I think we can help them, and I thank INTAS once again. Thank you.
Thank you, friends. Thank you for coming. Thank you so much.
Oh, very good idea. So, yeah. Pehले बोलो थे हम साथ चालू रखेंगे हॉस्पिटल इसलिए बच गया मैं इसलिए जो है कैसे देखना था इसके ऊपर एकदम साथ चल गया हाँ
Ages we can get. So even ज़्यादातर क्या कर रहे हैं कि volunteers or city or city खुल जाती है and very big customer and that is the way to go more so in the polio. Easy और वो
Hello, friends. There's a small announcement. I'm very happy to announce you that Indian Academy of Orthopedic Surgeons, popularly known as IAOS, is going to organize its fifth national conference on February 27th and 28th and 1st March 2026. So this is a very special conference where all the ideas out of the box, like ozone therapy, hydrogen therapy, pain portal blocks, Myra's way of fixation of fractures, and many more innovative ideas going to be discussed by many stalwarts of orthopedics of India. I request you and welcome you to attend this meeting. This is going to happen in Ludhiana only. Previous 4 meetings were held all over India and one in Nepal also. So I request you and welcome you again to join it. We are yet to bring out the registration form and all, but still it's just a first information. Thank you very much.
Kita jadi dua bisa ini hari malam kerja kita boleh terus
Hello. Gallery, gallery. Hello, well, to the post refreshment or lunch session as we move on to the next session. And this is going to be primarily a trauma session and showing you a lot of trauma related cases. The first case will be shown by Dr. Dhrumin Sangoi. He will take over from where we left the discussion in the last session on ankle arthrodesis, subtalar arthrodesis, and the controversial tibio-talocalcaneal nail. So let's give it to Dhrumin. Dhrumin, can you please go ahead and show us your tibio-talocalcaneal?
Can I have the presentation? Okay, so we are moving into trauma. I'll show you the surgery for TTC nailing. Although this is done for a elective case of severe flat foot, but you can use it for your trauma cases where you need a TTC nail. So she was a 68-year-old lady, high BMI, weight 110 kg, severe pain on medial and lateral aspect of ankle. And that's a right ankle which you are seeing. So that's the deformity which she had on the right side. From the front and the back, you can see there is hindfoot valgus, there is medial arch collapse, severe plano-valgus deformity. That's how she walks. So she's a home ambulator. Her foot is going completely out, almost ready to fall off. And she was struggling in pain. So these were her initial x-rays. These are not the x-rays when she came and saw me at this stage. I will show you her x-rays next. These were the initial x-rays. So what's the problem here? She is getting plano-valgus deformity. And if I put the marker and see that the talus head is starting to uncover here. So why does that happen? Because your tibialis posterior is not functioning. Your spring ligament has completely torn. Your talus is going down. So talus declination. So in short, these are all changes of flat foot. And when the patients come to us at this stage, we can do salvage. We would have avoided a TTC nail in this case if she had come at this stage by doing a double fusion like a subtalar talonavicular deltoid ligament reconstruction, spring ligament repair, all that stuff. But she came at this stage. So now see her ankle. So over 6 months, what has happened? The talus has completely dislocated from the tibia. You can see what the foot has become there, and it's completely flat there. So this happens, and then we have no option now. This is our hindfoot valgus view. That's the tibia, and you can see the calcaneum where it is going. The other side, she has a bit of flat foot. And that is the instability which she has on table. So this cannot be managed now with a double fusion or your spring ligament deltoid repair. It needs a stable, and her weight being 110 kg, you cannot risk doing a salvage, joint salvage procedure. So plan was to go in for a pantellar arthrodesis, TTC and talonavicular. So we are fusing the subtalar joint, the ankle joint, the talonavicular joint. It's a pantellar, sorry. Yeah. So lateral extensile approach for TTC nailing. Incise the soft tissues, go on to the fibula, dissect the periosteum out. Sorry. Okay. So floppy lateral or a lateral position is always better. You can take a lateral view, you can take an AP view of the ankle, and you can tilt your C-arm at 45 degree and take an axial view. These three views of C-arm you should be able to take before you make the skin incision. Expose the fibula, that's your osteotome doing a fibular cut. Always do an oblique osteotomy, otherwise the tip of the fibula will hit your skin and cause compromise there. Then you remove the fibula. You can remove a generous amount of fibula, as much bone graft as you need, that will help you. So once you do that, start reflecting the periosteum over the distal tibia and you will open up the ankle joint. So see the amount of instability which this has. So that's the Hintermann distractor which all of us use and has been shown that pin goes in the tibia, this goes in the talus, and you open up the ankle joint and then start preparing your joint surface by removing the cartilage. So you can use the saw blade, always use irrigation at that time, and then finish off with the osteotome and remove the cartilage. So that's the tibial cartilage going, and that's the talus cartilage. Try and keep the bone loss to a minimum. So use thin osteotomes. Finish off with a curette. So always after osteotome, some cartilage is always left. Now that is your subtalar joint. You have shifted the wires. That's your calcaneum. That's the posterior facet, and that's the talus. So again, remove all the synovium. remove all the cartilage. Now this was a flat foot, obese lady. The bones were very soft, so the cartilage just comes out like cheese. What is the end point of subtalar joint preparation? You should be able to see the FHL tendon medially. Once you see that, by moving the big toe, you know that you've reached far enough and you've prepared your joint. Multiple drill hole K-wires, as Rajiv sir showed in his talk as well. And after that, osteotome and shingling. So any fusion, you always have to go and do the K-wire drilling and the osteotome preparation. So once I did this, prepared the subtalar ankle, then you expose medially the talonavicular joint. So that's the medial side of the foot. And as soon as you open, you can see the talus head pointing towards you. So that's how severely flat foot and plano valgus she was. So that's the talus, that's the cartilage which is being removed, that's the navicular. Now you will tell there is such good cartilage, why are you removing and fusing it? Because you have to correct the deformity. This type of deformity cannot be corrected by soft tissue reconstruction. You have to fuse the bones. So that's the navicular cartilage. So again, Hintermann distractor, separate the talonavicular joint and see, this is how the talus pushes with the thumb and with this instrument. So that much talus declination was there, which you have to lift it up. So then all the bone graft from the fibula. So you have taken a big amount of fibula, that much bone graft is left. So everything goes into the joint. In this case, there was no varus valgus deformity, so you don't need a big chunk to correct that varus valgus. So you can mince it in pieces and put it in the joint. Provisional fixation with K-wires. Now sometimes this fixation, I will show you the C-arm pics after this video gets over. Even after provisional fixation, you can feel that your heel is still in valgus. So ultimately I had to remove those K-wires. I passed this nail and I put another provisional fixation, which is this K-wire. So your heel should be corrected. It should not be kept in valgus. It should come under the tibia. This is the 45-degree axial view which you do. So your foot stays like that, the C-arm moves. So once you prepared your ankle, subtalar joint, you put in the nail. I always put my jig laterally. Some people put it medially to put the tibia screws. I try and put it laterally and I go just above the fibula. So first the tibia screws go. So this is a system of nebula nail, which has a good compression for the ankle and subtalar joint. So once the two tibial screws go, then your talus screws goes. Then there is a compression device here. This is the PA screw. There's a posterior anterior screw which goes into the calcaneum. Once your TTC nail is done, then you have to come to the talonavicular joint. As you correct your hind foot valgus, your forefoot goes in supination. So when you fuse the talonavicular joint, you have to pronate the foot. Otherwise, patient will walk like this. So that's how that is the importance of understanding the deformity. If you correct the hind foot, what happens to the midfoot? And when you correct the talonavicular, you have to take that into account. That is an X plate which goes, and then finally the closure. So this is a TTC nail which many of you all do. So I'll go through this, and yeah, you can put a drain, always better. So that's the guide wires, that's the provisional fixation. Sometimes if you feel that the heel is still in valgus, you remove your provisional fixation K-wire, pass the nail from calcaneum to talus, and with that lever arm, you correct the hindfoot valgus and then go up in the tibia. That was the fixation of nail and a talonavicular fixation. And that's the axial view. I would like the nail a bit more this side, but again, this was a severe flat foot case, and it is in the calcaneum. The axial view are sometimes deceiving. If you do bit 10-degree internal external rotation, you can get this in center. That's her at around, I think, 6 weeks. This is the post-op alignment. Your calcaneum should be under the tibia. Your ankle should be at right angle, not in plantar flexion or dorsiflexion. So such obese lady, 6 weeks goes in walker boot. 6 weeks plaster, non-weight bearing. After then you start weight bearing in walker boot. And this is her at 3 months. So now the ankle, if some of you all must have seen the pre-op video, and this is our post-op video. So that's about TTC nailing. You can do TTC nailing in many procedures, all your fractures which are not salvageable, Charcot foot and ankle deformities. It helps you to correct and give a good lever arm right from calcaneum up to the tibia if done properly and correctly. Only the main thing is you should get your calcaneum under the tibia. That is the challenge. You can do it in failed fracture fixation cases. Again, diabetic neuropathy, fixed, failed, had to undergo a TTC. Yeah, thank you.
Very nice video of the tibiothalocalcaneal nailing. Very clear. And what I think for a long time we were emphasizing in the session 1, that even when you do a tibiothalocalcaneal nail, you have to prepare the joint surfaces adequately in order for a good fusion. You prepared the ankle joint very well. What about the subtalar joint?
Subtalar is prepared as well as like ankle. You have to distract it, remove all the subtalar has 3 facets: the posterior facet, middle facet, anterior facet. Posterior facet has to be prepared completely. Middle and anterior can be left. Whatever you access, you prepare. Posterior facet has to be prepared.
Right. Any other questions from the house? So this nail is a relatively new nail. Any specifications regarding the nail that we have to use?
So we have 3-4 companies available here. This nail is good in terms of the internal compression. They should have a compression device where you can compress the tibio-talar joint and the talocalcaneal joint. So that is the importance. You don't try and use a tibia nail or a femur nail here, because that will not give you the compression. It will not work for the general orthopods.
Okay, Pradeep.
Excellent presentation, Dhrumin. So coming back to the types of nail, I think you have to understand your implants very well. If it's a straight nail or a curved nail. So you get straight nails. The curved nails are around 5 degrees of valgus. The key is the difference in the anatomy and the entry point. If you do use a curved nail, your entry point will be different than a straight nail. So do not mix and match your operative technique when you're using different types of implants. That is the key message, because there are Indian companies also now which have a curved nail. So just be careful.
Sir, can I ask a question?
Yes, of course. Who is that, Ori?
If I am dealing with a ankle pathology and I am attempting a arthrodesis through a TTC nail, is it mandatory to fuse the subtalar joint, or I can go away with it?
So it is mandatory to prepare the subtalar joint. What will happen is the pathology is the ankle, but you have put a nail, you have put a rigid construct there, and you have not fused the subtalar joint. So there will be no bone bridging across. So the load on your nail will be more. Chances of screw breakage and implant failure will be more. If you get a solid fusion in the bone, the load on the nail becomes less.
And what will be your indications for fusing the talonavicular joint if you are attempting an ankle arthrodesis?
Yeah, so in this case where she had a severe hindfoot valgus, if you correct the hindfoot valgus, the forefoot goes in supination. So we have to correct the supination. We can do that by doing a cotton osteotomy, which is a dorsal cuneiform open osteotomy, or in such arthritic cases, old lady, obese lady, you fuse the talonavicular so that you can correct the supination as well.
But in routine cases, I do not need to touch the talonavicular joint.
If it is not arthritic, you do not need to touch. But if the forefoot is going in supination, you have to bring the first tray down. So you will have to address it.
So one question from Indore.
Yes, please go ahead.
So in particular in this case, when you have a valgus deformity, when you correct it in little varus to make it in the neutral, there is opening on the either in the lateral ankle joint on the lateral side or subtalar joint. So you put a wedge, any bone graft, or you prepare your joint accordingly. So it come in the neutral.
Yes, so that you can do in fixed deformity. Now, this lady was hindfoot valgus, but she was so lax that you can correct it manually with your hand and compress the tibiotalar joint. If it is a fixed deformity, then yes, you have to take your osteotomy cut like this and prepare a bone wedge laterally so that your valgus is corrected to a neutral.
Okay, so whenever we corrected, there is a gap on the lateral, mostly in the ankle joint.
Yeah. So yeah, so you can take you have a fibula, you have taken out the fibula. So you can take a fibula chunk and keep it laterally so that it acts as a strut and doesn't allow the whole construct to go lateral. So that acts as your lateral bridge and maintains the neutral position.
Okay, thank you.
Yes. You have to access the ankle joint, you have to access the subtalar joint, and there is no role of fibula once you put a TTC nail. Why do you want a fibula? So,
question, sir. Ludhiana. So this is regarding in a transfibular approach. Sir?
Ludhiana, no? Yeah, you are audible. Yeah, go on.
In a transfibular approach, the good thing is that we are able to see the entire joint and we can debride it. But are there any pearls when we do anterior approach? Because we cannot see the posterior part and many parts. So do we leave like that, or we, like as a surgeon, we always have that thing ki kitna zyada kar sakte hain. So are there any pearls?
Are you essentially saying that if you go through an anterior approach, can we avoid the subtalar fusion? Or are you saying that through an anterior approach, if I go, how do I do a subtalar fusion?
Tibiotalar joint only. It is difficult to go to the posterior side and do it. I mean, to make sure that it is completely gone or not. In transfibular approach, it's easily visible. Entire thing is easily visible. You can say, okay, entire joint is done. But from the anterior approach, it's not very easy to say.
You can't see the posterior part of the tibial joint. That is what you are trying to say. And you're not sure whether you've done an adequate excision of the articular cartilage at that level.
Any pearls so that we can decide, okay, this is.
Okay, so Dhrumin?
So yeah, so I think you have to go slow. First, when you open up anteriorly, remove the capsule, remove the osteophytes, and whatever you are seeing, start preparing. Start removing the cartilage slowly and gradually. And the key instrument here is hinterment distractor, which you see in all our videos, we have used it. So you should have that if you are doing this case. And if you see the posterior part, you have to put the hinterment distractor and clamp it open. You will be able to see the posterior part, and you will be worried that you cannot put your saw or osteotome, but you can always use a curette and remove the cartilage as much as is visible, and take the help of a C-arm. Put your instrument, take a lateral view. You can see that your curette is going to the posterior tip and remove the cartilage.
So you have to use a distractor. That is very important. The other tip that he is trying to give you, I don't know whether it's been very clear, is that as you go from anterior to posterior and you keep on removing cartilage, the cartilage on each side is almost 2 to 3 millimeters thick. And when you remove that, you can see more and more behind posteriorly as you enter into the joint. Okay, and you will be able to see much better after you will remove the anterior cartilage. When you actually start the surgery, you may not be able to see posteriorly, but as you keep on removing the cartilage, you will see more and more on the posterior aspect. Any other question?
So answering first, that if you are taking anterior approach and you want to prepare the subtalar joint, you can go with a sinus tarsi approach, add it, and you can do the subtalar fusion. My pleased to talk onto the debate onto straight versus bent nail. The nail which you saw is designed by me. And this is a straight nail. Typically, if you are able to bring tibia and talus in one line, it doesn't matter whether you use straight or a bent nail. The problems with the bent nail is you have to do it in a lateral or a prone position. Whenever there is a defect, you cannot adjust the holes, and that is where it's a compromise. Now, the case you showed, Dhrumin, your nail has gone medially. It would be advisable whenever you're dealing with the valgus, you preoperatively, before you push in the nail, you do osteotomy of the medial malleus, because the canal of tibia is lying more lateral than medial. So you're going to go medially. You're very, very close to the medial wall, and it could cut out medially. Beware of this. So you can do osteotomy of medial malleus. Shift whole talus calcaneus underneath the tibia and push your straight. And in cases like flat foot or a bad calcaneus malunion, if you are doing both ankle and subtalar, both fusion, then you may have to add a calcaneal osteotomy over and above nailing. Over and above nailing. So this case, probably you did not wanted to do medial malleolar osteotomy, you would have done with a calcaneal sliding osteotomy.
Regarding sir's question about fibulectomy, we don't necessarily have to excise the fibula every time. We can just flip the fibula posteriorly, approach it. What I do is remove the articular surface of the fibula on the syndesmotic side, make it freshen and reattach with screws. So it will act as an onlay graft. Because if you have to put bone graft, fibula is not a, it's a cortical bone, not a cancellous bone. You cannot put the cortical bone in the graft side. So it is good as a structural graft, onlay graft, rather than putting it in the joint. Fibula and attach it.
The total fibulectomy I do whenever I find that the volume of fibula will not allow closure, which is the case in Charcot. So that is where, otherwise, even going forward, you excise the medial half of the fibula and keep it, use it as a bone graft. So size of the fibula will also reduce, and you put in fibula back. You have a fusion surface between fibula and tibia, fibula and talus, and it gives an anatomical shape to the foot. And footwear, using the footwear becomes easier. That is why, as far as possible, don't do fibulectomy or slice it half, use medial half as bone graft and lateral half goes as a live plate, and it maintains the shape of both the malleoli. Patient is very comfortable using the shoe.
Some cases of Charcot or where there is talus is completely absent, and you have to put the volume, like it's a sir's technique where it's a bamboo hut technique. We excise the fibula, split it into two halves, and insert in place of talus, tie each other with a bond or something, and around the nail. It's like a bamboo hut. It's a great technique.
Any questions from the audience online? Indore, Ludhiana. I can see a raised hand from Indore. Indore, any question?
From Ludhiana. Curved nail or straight nails? I mean, like Synthes has got a very curved nail for TTC.
Yeah, Dr. Rajiv Shah just answered that question precisely, but still, I think, Dhrumin, can you just give a recap?
Yeah, so as sir said, if you get your tibia, talus and calcaneum in one line, it doesn't matter if you are using a straight or a curved nail. I always prefer straight nails because that's the weight bearing. That's how you have aligned your bones. But in where you have slight valgus of the calcaneum, a curved nail would also be useful.
Also, I would like to add one more thing. I think if you are as an orthopedic surgeon, we like straight lines. We like straight lines. So if your alignment is good, preoperative or intra-op, and this is what you want to maintain it with wires, then a straight nail is good. While if you're using a curved nail, you have to actually start slightly more varus, Because when you finally try to put your curved nail, that curved nail will actually push the whole thing in valgus. So that's what I was trying to say. Do not mix and match two different techniques, because when you start reaming for a curved nail, it will be straight. But when you start putting a curved nail, it will suddenly kick off in valgus. I have used curved nails, and that's why I'm saying. Normally, when you try to align it, it's 5-degree valgus, and when you put the nail, it goes into 10, 12 degrees or 15 degrees, which is what you don't want. So that's why if you're putting a curved nail, start slightly varus, and then go. The nail will push it in valgus.
Any other questions?
Whenever you need to add calcaneal osteotomy with your TTC nailing, go little anterior into the calcaneus with your entry of the nail, so that you could do osteotomy behind the nail. You don't have to disturb much. So your nail is somewhere here and calcaneus is behind. You can do varus valgus osteotomy. You don't have to, first do the osteotomy, then do the TTC nail, adjust both. That is the tip.
Right. So, any more questions? I can still see the hand raised from Indore. Indore, do you have a question?
No question.
All right, thank you. So, before we go on to the next talk from Dr. Rajiv Shah, who's going to talk to us about calcaneal fracture fixation, I would like to make an announcement for the people who are gathered here in Bombay and those amongst you who are online. I can see that I'm sure that a lot of people in Sangli, Indore, etc. are Bombay Orthopedic Society members. To all members of the Bombay Orthopedic Society, a big request is that we are trying to update the directory, members directory of the Bombay Orthopedic Society. For people who are online today from outside Bombay, you can fill in your data online if you go to the Bombay Orthopedic Society website. And to all those of you who are present here today, the forms for to add your data or to update your data in the BOS directory are available outside at the VAMA counter. Please fill up those forms so that they can be updated.
Sir, Zaveri sir.
Yes.
Sir, sorry to divert you from the topic, but I wanted that BOS should release the typical protocols for each fractures.
Yeah,
because
we should do that.
NABH association, they are asking many hospitals that you should have a written protocol either by the national association or any association which is very powerful like BOS.
Yeah, I think that's a very good suggestion.
Yeah.
And Dr. Ashish Phadnis is planning to do that when he becomes the president.
No, sir.
Thank you,
We
sir.
have
Thank you.
released the protocols book a few years back. Dr. Harsha Dargekar had done that, but we'll plan to make it electronic and get it up. There are a few legalities that when people want to refer to that and use it in a court of law, then that is when it becomes a problem. So we have a
Thank you,
protocols
sir.
book and a protocols app as well, which you can download it from the Play Store or the App Store. But yes, I understand your concern with protocols. So we'll send you a soft copy across.
Thank you, sir. Thank you.
So I'm going to talk on to calcaneus fracture fixation. I'm going to talk about open reduction internal fixation, how we really do it. And you must look at the x-rays and look at various angles, look at the position of sustentaculum tali, calcaneus. CT scans, if you can get, is always better. It is going to tell you about the varus, valgus of the heel, blast of the calcaneus, the subtalar articular surface of the calcaneus. When you do this surgery, patient is positioned into lateral decubitus position with the affected limb up, and you also use a bump, which is going to be one of the assistant. C-arm comes diagonally so that when you take an AP image of C-arm, it shows you the lateral image of calcaneus, and when you turn your C-arm, into lateral side, into the lateral this thing. Then an assistant dorsiflexes the foot and ankle, and you can see the Siam axial image of Siam. And you must see your preoperative broadens view 10, 20, 30, 40. This is 45-degree internal rotation. And you are doing 10, 20, 30, 40 angulation of Siam caudally, cranially, and you're focusing at the tip of the lateral malleus. And as you go from 10 to 40, you see the posterior articular surface of calcaneus. So these are the prerequisite. The another important prerequisite is to see for the wrinkle sign. Dorsiflexion and eversion of the ankle shows wrinkles at the level of the incision. This is the surest sign for you to go in and do surgery. Marking, you start marking your lateral malleolus, tendoachilles and fifth metatarsal base. Put in a K-wire from the base of fifth metatarsal. Wherever it goes up, that is the minimum size of your vertical incision. And I'm marking my vertical and horizontal incision is going to go with a gentle apical curve. And if you have an involvement of calcaneocuboid joint, which is the case here, I'm going to go more dorsally so that I don't hit peroneal, and I also go and open the calcaneocuboid joint. Typically, these limbs are taken quite posteriorly than what is described in our book, because you don't want to hit the nerve, sural nerve. The first step I do is I use a hammer. This hammering of the calcaneus reduces all the small fragments which are lying in their bad position. And then when I put an incision, I am very gentle at this level. But when I am going over the calcaneus, my incision is sharp, direct over the calcaneus and is cutting the calcaneus with the right up to the periosteum. And then again, here you should be very gentle. My towel bump is acting as an assistant. So whenever I want to open the flap, I push the bump up. And when I want to put in a wire into cuboid, I pull the bump towards my side. And when you do this flap dissection, you don't hold the flap with any of the instrument. I'm just retracting it with my forceps. My assistant is pushing the ankle into inversion, which helps me. And till I see the peroneal, I don't retract the flap. Mind you, this is a very delicate flap. You don't want to retract it. That's a peroneal, and that's a calcaneofibular ligament. And then only your assistant puts in the retractor. That's what I'm cutting is a calcaneofibular ligament. There again at the cuboid, calcaneocuboid joint side. That's the opening which you get once you have a complete kind of this thing. And we need to use K-wires which act as a retractor to the flap. One wire goes anteriorly into the talus, another wire goes posteriorly into talus, and the next wire will go into the cuboid. When you want to push in this wire, you pull the bump towards you so that eversion is created, and your pushing the wire into the cuboid makes easier. So that is how you use bump as one of your assistant. Once you put in this wire, make sure that you don't immediately retract. Push in a weight gauze because this flap has to be kept weight all the time. So I push in a weight gauze and then I bend the wire which acts as a retractor. So once this is done, I go ahead with my 14 steps of open reduction internal fixation of calcaneus fracture. The step 1 is reduction of sustentaculum tali when the constant fragment is not constant. Very, very often you do see this, that the medial fragment onto which we want to reduce is not lying into the correct position. The commonest way to do sustentaculum reduction is to pull that fragment from the lateral side, pull that medial fragment and reduce it during OD. But sometimes reverse may have to be done. You may have to push from medial to lateral, particularly when you have a compound injury. So push from medial to lateral, pass a temporary wire to sustentaculum. This is how it acts. And then you push in a wire. That would be the first step. Sometimes when constant fragment is not constant, you will need a medial distraction followed by reduction and fixation. With something like this, you reduce it and then distraction followed by reduction will help you like this. And very, very rarely you may have to put a medial incision and do open reduction internal fixation of this fragment, which many times is not in the position. And this would be a small medial incision where you can go between tibialis posterior and flexor digitorum longus. Now this kind of a compound injury required this kind of a push followed by a K-wire fixation, and then the later date I came in, I did the calcaneal fracture fixation. The step 2 is dissection of lateral wall and hinging it down and sometimes removing it and putting it onto the back table. So this is how you dissect the lateral wall and hinge the lateral wall down. Sometimes if it's a big piece, you remove it and put it on the back table. So that's where I am hinging it down. And then you pass a Steinman pin or a Sanz pin lateral to medial or posterior to anterior. This helps you to give traction, and once you give the traction, everything becomes clear, in particular your articular facet. You can see the articular facet here once you do the lateral, once you give the distraction with this ST pin. And the next step is removal of articular facet. It could be one facet fragment, it could be multiple facet program. So what do? You remove the articular facet because your reduction starts from medial to lateral. You have to remove the articular facet, put it on the back table, and then go on reducing it. When you have multiple articular facet fragment, this is the case many times in standard 3, standard 4. How can you deal with it? You have to take out all the fragments, draw these fragments on a mob, put them on the mob, draw it like this. That could be your first mob. This could be your second mob. And suppose you are removing the articular facet. I put it on the mob, draw it anterior, posterior, top, bottom, and then preserve it on the back table. After removal of multiple articular facet fragments, how do you reduce it? There are two ways. One is you do reduction and thread your K-wire or screw from medial to lateral. This is how it happens, that you push in a wire from medial, thread it over one articular fragment, again push in a wire, again thread the another fragment, and that's how you could do it. The another way is you reduce and thread these wires on trolley and put it back inside. Many times you need to do that. So you remove this fragment, put it on a trolley, pass one K-wire, another fragment, let that K-wire go in, and then you can put it back. The step number 5 is reduction of body of calcaneus with a sustentacular fragment. So you want to put in body back, articular facet back, and you want to reduce it. So how do you do it? You could use a hemostat, you could use a bone spike, any instrument, or most often than it, you use a lamina spreader to really reduce this body fragment with the articular facet fragment, and like this. The 6th step is heel height restoration, correction of heel varus, and temporarily fixing it. So once you do the correction of the heel varus, restore the length, put in a wire which goes from lateral to medial. Sometimes if the situation is very much comminuted, push this wire into the talus because you have restored the heel height, you have restored the heel varus. And this is how you push in 2 wire and go ahead. The next step is articular facet fragment put back into the reduced position and temporarily fixed. So whatever articular facet fragments you have removed, you put them back into reduced position, fix it temporarily with the K-wire. So that's how it looks. Be aware of not hitting on a medial side your FHL tendon and neurovasculars. This is how you do it. And on table, you put your articular facet fragment back, reduce it nicely, make sure under image that you reduce it nicely and fix it temporarily. The next step is reduction of body with the articular facet fragment and with the anterolateral fragment of calcaneus. Thereby you restore Gissin's angle. How do you do it? This is your articular facet fragment with the body. These are the 2 wires you put in, and then you reduce this anterolateral fragment with the punch and push in a wire, and thereby you have a kind of restoration of length of the calcaneus with 1 or 2 wires. So typically, this is how it looks. You reduce this and put in 2 K wires. This is your final picture of wires. You have a heel length restoring wire going from calcaneus to the anterolateral fragment body to anterolateral fragment. You have 2 wires restoring the heel height and varus, and you have 2 wires which are fixing the articular facet fragment. Once you have done this, you do image check. Most important image check is Broaden's over and above AP, lateral and axial. So how do you take the lateral? You put the C-arm into the lateral position. Assistant would pull the heel, pull the ankle into dorsiflexion with a sling. And when you put in such an image, this is the image you see. That's how you do the lateral imaging. You want to do broaden view, you tilt this C-arm cranially 10 to 20, 30, 40 degree. You are focusing at the tip of the fibula, and this ankle is lying into 45 degree of internal rotation. Now when you see, when you do 10 degree, this is how you see the articular facet. This is 20 degree, this is 30 degree, and this is 40 degree. So that's how you see your Broaden imaging. Step 11 is articular fixation, which is done outside the plate with 1 or 2 5 or 4 mm cannulated cancel screw. I typically like to do it first. Sometimes you could do through the plate also, but you're more safe putting the articular facet fragment reduce, then putting a plate. So that's the articular facet fixation. Now, when I talk of articular facet fixation, it is very important to take a sustentacular view. A sustentacular view, how do you take it? In a patient lying like this in a lateral position, tilt the C-arm to 30 degree. And this is the routine lateral, which doesn't show you the sustentaculum tali. But when you tilt C-arm 30 degree towards you, you see a beautiful view of sustentaculum tali, and you're going to go ahead and pushing your screw there. That is how you make sure that you're going into sustentaculum tali. The step 11 is obviously this, fixing this, and then you are going to reposition the lateral wall back. Whatever lateral wall you had reflected, you have taken back on back table, you could put it back, and then you can neutralize this with a plate fixation. Varieties of plates are there. You could use it once you are done with your articular facet fragment fixation. And the last step are optional steps. You could do dry arthroscopy for a subtalar reduction to make sure you have an exposure in front of you. You can put in an anterior and posterior arthroscope and maybe 2.7 and see the subtalar joint, and sometimes very rarely you can use bone grafting. So that's about open reduction internal fixation. Things may not differ much except the approach for a minimally invasive calcaneus fixation. Now the case, if you see, is a 32 years old male who had a fall from height. He was brought to us in 6 hours, and this was the CT scan, and we thought that okay, we go ahead and do MIS. For MIS, you need not use this position. There are 2 positions are used for MIS. One is a floppy lateral position, because many times you need to go for medial distraction for MIS. You need to keep either this position, or I also like to use hanging ankle position, which is done onto the lithotomy piece, where AP shows you the lateral and the axial is being seen with the lateral this thing, and you can also have easily look at the Broaden's view. Now MIS, the incision and exposure, you mark the fibula, you mark the 4th metatarsal base, and then a straight incision which is little posterior, little down, little plantarwards, because you don't want to hit the nerve, and you want to see the peroneum of about 2.5 centimeter is taken, and Once you are done with this incision, you can go ahead, incise the skin, and make sure that you have two flaps, one in dorsal, one plantar. Dorsal flap would contain an anterior branch of sural nerve, so be watchful about it. And that's how the whole exposure looks. Beneath is the calcaneus, here is the talus, and then you can do your articular facet reduction, pushing some hemostat or something underneath the peroneal, going into the articular surface, and you can lift it. I many times use what is called as a push screw. A push screw is a flat-ended, non-cannulated cancel screw which works like this Adnan Sami phenomena. I call it a push screw or a lift karade. A screw is passed here and then you go on pushing it, and it gives you the reduction. This is a very useful tool for MIS calcaneus. So it's a lift karade. So how do you do it? Now, case like this, you have a facet which is lying like that, and you're going with MIS. You put in a push screw here, you put in an ST pin. With ST pin, you maneuver it down. With push screws, you push it up as you go on up. This is on real life situation. Clinically, you put in a ST pin, you put in a push screw, and push screw goes up. You can replace that long push screw with a simple screw, or you can keep the screw and then you can put in a plate like this. Or sometimes the placement of plate, if you have a sinus star shape, you could do like this, or with a small incisions, you could always use hemostat to do. For a calcaneocuboid joint reduction, when you are doing MIS, sometimes it is deemed, then you put in two pins and Hitterman distractor, distract it, and then push the calcaneus this with the some pushing instrument. You have distracted it, and then you put the plate underneath the skin. And this is how you take a calcaneocuboid joint reduction. So back to our case, MIS fixation. This is how a Steinman pin to manipulate, followed by various wires for reduction. And then the plate was slided through the MIS approach. And this is how the final fixation looked like. That's all. Thank you very much.
Very comprehensively described by Dr. Shah. Calcaneal fracture, very, very often seen by all of us, often mistreated, wound problems, very frequent skin problems, very frequent inadequate fixation of substanticular tali, inadequate facet elevation, all common problems with calcaneal fractures. But I think he has given us a solution for most of those. If there are any questions in the house, we would be happy to take them.
Hello.
Hello, Rajiv.
Yeah.
Sorry, MIS fixation you showed the last one. You dealt with the calcaneal tuberosity and this depressed fragment of the sustent. What about the constant fragment, sustentaculum talus? That you are not shown.
So MIS you do with sender 2 and sender 3. I don't venture it in sender 4. In sender 3 also, half the cases I go ahead with open reduction internal fixation, half the cases I go ahead with MIS. But having said that, if the constant fragment is not lying into the position, the first step, whether you go for MIS or whether you go for open, you have to reduce that first. And that is why I like to take a floppy lateral position. Sometimes you need a medial distractor also over and above lateral distractor. So the first thing is the base onto which you are building reduction has to be in the proper anatomical position. So for a MIS also, if the sustentaculum facet tala is not lying into the position, you could push it with a punch and then you could reduce it and push in a K wire. So whatever you do, whether open or MIS, you have to reduce the constant fragment first. Your reduction is built onto that.
This is Dr. Sidhu from Ludhiana. Hi.
Ludhiana, please ask the question, sir.
Excellent presentation, Ji Bhai. What are your views about a new way of fixation, calcaneum Maros fixation of introduced by Mario Tangri from Italy? Any idea?
I have no idea.
Any of the other faculty? Abhishek? No, sir, we haven't. Can you enlighten us? What exactly is that?
So this is a non-invasive way of fixing calcaneum by some sort of K-wires with the external fixator.
Okay.
It's non-invasive. You can do the same day. Reduce by lifting the fragment from lateral side and fixing with K-wires. Not K-wires, special type of wire.
What I think sir is mentioning is you do a small percutaneous fixation, a percutaneous reduction, K-wire fixation, and then put like a small chest type fixator both medially and laterally. I think then you can mobilize the ankle as soon as possible.
Yeah,
So it's a percutaneous fixation.
that is possible. That can be done. But for me, the center one, I will go for percutaneous fixation. You don't even need anything. Center 2 and 3, you would need sinus tarsi approach.
Right. Yes, so Prasad.
Sir, what would be the indication for a primary subtalar arthrodesis in a very smashed calcaneum fractures?
Yeah, so you have really touched my heart. And this is where I absolutely differ from what present scenario is. So before few years, the only non-controversial statement for calcaneus fracture was Sander 4, where universally people said that Sander 4, you go for primary fusion. And one fine day we had an article, a review article in Indian Journal of Orthopedics by one of the legendary surgeon saying that Sander 4 should be reduced and we should do fusion later date. Almost all of them would go for fusion, but you should be reducing it and doing the fusion later date. So then what I did, I studied those days when I was asked to present at American Orthopedic Foot and Ankle Society's annual meeting, my work. 12 patients with 24 calcaneus, Sander 4 bilateral Sander 4, 24 cases, 12 patients. On right side, I did open reduction and fixation. On left side, I did primary fusion. And then we had assessment of this patient. Every patient who underwent primary fusion on the left side, they were very happy. We are talking of our patients. They are not insured. These people, they are workers. They have a fall from construction site or the 4th floor or big heighted falls. And they want single surgery. They are braid earners. So this thing is till I get a level 1 or level 2 evidence that Sander 4 you should be not doing primary fusion. I go and do primary fusion as a single surgery, and that's the one which my patients, our Indian patients, they like. Single surgery, they go back very early. Yes, these are very difficult, challenging situations. You have some rate of non-union also, but for Sander 4, I go for primary fusion. Because with a one review article, which has no validity, is not a level 1 or 2 or 3 or 4 evidence, I will not go ahead and do this. And we have still added that those were 24 cases. Now we have added another 6 or so. So for a Sander 4, bag of bones, I'll go with the primary fusion. And my primary fusion means when the patient allows you to go in, and that is at least 6 weeks, 4 to 6 weeks. When you have a wrinkle, then you can go in and do, not before that.
Right. I think very unequivocally answered by Dr. Shah. Any other questions?
I wanted to ask how many days should we wait for this MIS fixation in case of calcaneum?
So MIS, I showed the case which presented to us at 6 hours. and we did MIS. MIS, it is said that 24 hours, if patient present to you in 24 to 48 hours, go ahead and do MIS. It is a better procedure for that patient. Beyond 1 week, I think you will really struggle to reduce bad cases. So MIS as fast as possible, as fast as possible. Because then only you are very easily able to reduce these badly displaced fractures. Beyond 7 days, or I don't know, 10 days maximally, I don't think that will venture a MIS.
There's a
Respected
study
sir,
actually
Samarth
we looked
Thakkar
at where
from
we
Indore.
have done an MIS within 24 hours, and then you have a slight delay of 2 to 3 or 2 to 5 days and beyond 5 days. Actually, the complication highest is actually the first 24 hours. And then you have the 3 days, the immediate and so slightly delay. Then you can do, if you're waiting for 10 days plus, then you might as well do an extended lateral.
Hello.
Yes, please go ahead.
Yeah. Respected Rajiv Shah, thank you for an elaborate talk. The only question which comes to mind is, what is your plan and how do you address the different problems in Sanders 4 and achieve the primary fusion, like, deformity, loss of height, and combination and fusion, fixation? Means, please elaborate on that. Thank you.
So, Alok bhai, when you do primary fusion for the sender 4 cases, it is never within 3 weeks. Almost always required to wait for 4 to 6 weeks. And before starting the procedure, I almost always add stairs gastrocnemius release. Otherwise, you will not be able to restore the length. And then you take in extensile lateral approach and you try to reduce calcaneus to the best of your ability. It is not that you will be able to reduce it 100%. And there would be a gap, there would be a defect where you will need to put in a structural iliac crest graft. Very, very rarely I've used fibula also. But structural iliac graft, you would need to put in. Preparation of the talar articular surface would be easy. But preparation of the calcaneal articular surface, which is shattered, would be difficult. For that, what you will have to use, you will have to put in 1 or 2 or 3 K-wires into small fragments. Somebody would hold it and then you would take your curate and try to scrap it. Or you could just put in multiple drills. I rely more onto preparation of talar surface and putting a graft which bridges talar articular surface to the calcaneal tuberosity. And calcaneal tuberosity would always be good even in sender 4 and you would be able to put in the graft. You need to put in multiple implants sometimes and that is what you should be ready with. So that's how my primary fusion for calcaneus sender 4 goes.
Thank you very much, sir. Thank you.
So can I ask a question?
Yes, of course. Please go ahead.
What is your approach towards compound injuries, late presenters, wound infected? How do you deal in those comminuted calcaneal fractures?
Okay, so you ask a question which would take 1 hour to answer. Anyway, for a compound calcaneus fracture, if the wound is on a medial side, which is the case, that's a very good compound calcaneus fracture to have. That wound on a medial side gives you an opportunity to reduce the fracture in whatever possible way you can do. And then you do the debridement, you reduce the calcaneus, whatever best you can do, and come down again after 2 to 3 weeks from lateral side and do the open reduction internal fixation. When the wound on a compound calcaneus is on a lateral side, that's little dicey situation, but still you can get out by doing debridement at that go. During that lateral wound debridement, whatever fragments you are able to reduce it, put in multiple K-wires, and then wait for the 3-4 weeks, cover the soft tissue and go ahead and do the open reduction. But it is when the wound is posterior or the plantar, that is a very, very bad scenario for compound calcaneus fracture. Most often than not, the plantar wounds, they end up with the amputation. The posterior wounds are also very dicey. Therein, you would need to go in debride, you would need to give coverage, you need to use a VAC, and then you, whatever best possible reduction you can do, you do. Coming to the late presenters, beyond 3 weeks, if patient comes, I treat it as malunited calcaneus fracture. And then malunited calcaneus fracture is a talk in itself, and I don't want to discuss it at this juncture. But compound fractures and delayed presentations, I've just,
any role of
I think that answers.
Yes.
Indore, yes, Indore has a question. I can see a raised hand. Okay. All right. So there is no question apparently. Thank you very much, Dr. Shah, for a wonderful presentation. No, we'll wait. And can I request Dr. Ashish Phadnis to come up and present about approach and fixation of trimalleolar fractures? And along with him, we've got a short talk by Dr. Abhishek Kini, who is going to show the approach to the posterior, the various approaches for fixing posterior malleolar fractures.
Thank you very much, sir. And we also welcome the delegates from the BOS basic trauma course who have joined us here. And this talk was also sort of made with keeping them in mind about some of the इसको So these are some of the common cases that we come across in our practice. As a general orthopedic and a trauma surgeon, this probably will be the most commonest foot and ankle problem that we will come across. So I'll just take you to the video. This is a sort of a middle-aged gentleman and who had sustained a twisting injury. And you can see that, you know, not very uncommonly you see these ankles which are subluxed and there is a rotational element. So here, can I pause this? So if you see the space. So if you have seen the X-ray, it is a rotational injury. So there is a transverse fracture of the medial malleolus. There is an oblique fracture of the oblique non-comminuted fracture of the fibula. And there is also a chip of the posterior malleolus that has come off. This posterior malleolus can be of various dimensions. And long gone is the concept that, you know, we sort of, you know, conserve the posterior malleolus if it is of a particularly lesser size. However, now the questions are still being asked that whether we need to fix every posterior malleolus that comes with an ankle injury. But we still think as trauma surgeons that the posterior malleolus is a key to good fixation of the syndesmosis, and getting a good reduction of the posterior malleolus will sort of try and get the fibula back in the incisura and get a good reduction of the fibula in the incisura and stabilize the syndesmosis. So the patient is in a sort of a floppy lateral position because here you will need to get a good trajectory of the wire to fix the posterior malleolus. So the patient is in a floppy lateral position, and I have marked the fibula and the tendoachilles. The incision is about a finger breadth behind the sort of a bony margin of the fibula, so that you can reach both the aspects, the posterior aspect of the tibia as well as the fibula to fix it. The skin and the soft tissues are handled very gently because these are the injuries that are associated with a lot of soft tissue edema and soft tissue swelling. So a few pointers to this, as we teach in the trauma courses, is that you need to get the timing right. You need to get the tools right and plan what tools are you going to require for your reduction. And you need to plan a certain technique of reduction. So here, since the fibula is a short oblique fracture and it is not a very comminuted one, we have decided to achieve a primary stability by doing an interfragmentary sort of a lag screw compression. So what I tend to do is basically it is advisable to get the fibula out to the length, get a good reduction of the fibula, fix it using a lag screw. So the proximal cortex is over drilled and then the distal cortex is drilled with the appropriate sized screw. I've used a countersink so that the screw head is not prominent and it does not irritate the soft tissues or the peroneal. At this stage, I would not put a plate. It is so that you can visualize the reduction of the posterior malleolus. So if there is a plate or a metalwork that has come on when you're fixing the fibula, then the visualization of the posterior malleolus can be a little tricky or a little difficult. So keep a couple of wires or keep the holders or the Weber's clamp to sort of hold the fibula. Then keeping the peroneal, dissect slightly behind the peroneus tendon. There is a sort of facial layer. So once you incise the fascia, the fleshy belly of the FHL, which is usually a part of the injury and it is contused, comes into the view. So I tend to make a slightly lavish incision to prevent any sort of soft tissue, excessive soft tissue retraction. So make a gradual incision. The fleshy belly of the FHL will be seen very easily. And using a soft mop or your fingers, you can just push it on the one side and it becomes very easy to dissect. The next thing that comes in your contact is a sort of a fracture site. Here you can dissect bluntly and put a spike on the posterior aspect. So the whole posterior aspect of the tibia becomes visible. So you can visualize almost 4 to 5 centimeters of the posterior aspect of the tibia. You can't go any higher because of the vascular bundle which is there. But it is very easy to come at the tip or the point of the apex of the malleolus, of the posterior malleolus, and use a wire to sort of fix it in position. Here the lateral position becomes very handy, and a bolster, as sir had shown, becomes very handy because the trajectory of your wire should not be dictated by the position of the foot and the table. So it's very important that you get your trajectory correct. And once you have done that, confirm it under the image intensifier, and you can use a 4 mm lag screw to sort of fix the malleolus. Once that is done and you change the window again, now we come back to the fibula where a pre-contoured standard fibular locking plate can be used and the fibula can be fixed. Here, confirm the position of the fibular plate. Use wires to confirm that the plate is sitting adequately flush. These pre-contoured plates sometimes may have a tendency to fly off anteriorly or posteriorly, or the fibular ridge can come in the way. So just spend some time getting a good alignment of the plate on the bone. And once you're happy with the position of the fibular plate, then you can fix you can fill it in with the screws, fill in as many sort of locking screws in the metaphyseal fragment, and 3 or 4 screws as the fracture dictates in the diaphyseal portion. Once this is done, either you can do a provisional closure, because as I said that these are the injuries generally which are accompanied by a lot of soft tissue edema and a soft tissue swelling. So if there is a chance that this wound can be a problem, so do a provisional closure if need be, or if you want to do all the closure at the end, that is also acceptable if you are done it in a good tourniquet time. Expose the medial malleolus through a standard medial incision. Just make sure there is adequate gap between the two incisions. If you have gone a finger breadth posterior to the fibula, then there is adequately enough, wide enough gap between these two incisions for us to not worry about the soft tissues. So medial malleolus fixation, try to be sort of clear all the soft tissues from the fracture fragments. Here we are trying to clear the hematoma from the fractured surface. You can peek inside that sort of ankle joint through the anteromedial arthrotomy to see if there are any incarcerated fragments. The the image intensifier will also guide you. Otherwise, you can flip the medial malleolus. You can visualize the talus. Any articular scuffing on the talus can be seen. Loose fragments can be removed at this stage. And the medial malleolus is fixed using 2 4 mm cannulated cancellous screws. Try to be as perpendicular as possible to the fixation. Here we try to get a hold of the posterior of the far cortex in as many cases as possible. Sometimes the fracture line is oblique, so you might have to direct the screws posteriorly or anteriorly, in which you can easily get a hold of the opposite cortex. Once this fixation is done, Once the fixation is done, again make it a habit to check the stability of the ankle, to check whether any loose fragments are there. I mean, you should check it prior to the fixation and make sure no intra-articular hardware is there or the screws are prominent. At the same time, you can do a Cotton's test, check the stability of the construct, and once you're satisfied, then the closure can be done in the usual manner. So this is a post-op X-ray. So it shows a well-reduced sort of ankle talus within the ankle mortise. And as I said, checking the doing the Cotton's test or checking the integrity of the syndesmosis is very crucial. Sometimes we can have some anterolateral fragments of the fibula, but that can also be tackled with the anterior when you are reflecting the flap from the fibula, you can even tackle that either with the soft tissue stitches or maybe if required some soft tissue ankles. So, I mean, this is just a management of the posterolateral fragment of the malleolus. I think Abhishek, he's here to show you the various approaches used for tackling the other aspects of the posterior malleolus, especially from a posterior medial incision. So we can take the questions at the end of both the talks then.
End of both the talks.
Thank you,
Hello.
Ashish sir.
Mumbai.
I think we had made these models for the BOS foot and ankle course that we ran a few years back. So these are on sawbones. So these are on sawbones where we've actually made muscles with tendons. The yellow wire is the nerve, and there are some infant feeding tubes with red ink and blue ink as arteries and veins. So this is a posterolateral approach that Ashish sir just demonstrated. So this is the fibula and 1 centimeter or 1 finger breadth behind. So this is the sural nerve that can come in your way, and you should be very careful about that. So this is how you go. Only the skin has to be incised, and make sure that when you are there, it's approximately midway between the tip of the fibula and where the gastrosoleus muscular tendon junction comes. Come down, dissect carefully. Ashish sir, I think maybe this first and then sir's video would have helped better, maybe. This is primarily for our BOS basic trauma delegates. So be careful when you come on this layer. You have to be very slow. Look out for the nerve, and more often than not, you will see it. And then make sure that it's in the flap there. It's retracted posteriorly as you come down. Once you go in, you will see that then there is the peroneal tendon sheath which is exposed.
Right.
And then you will have the fibula anteriorly. So just underneath over here is the peroneal tendon sheath, and this is the fractured fibula that you see. So that's the fracture in the fibula. So once you go there, you can retract, go in the anterior window for the fibula. That's what Ashish sir showed. And once you go retract this behind, that's the peroneal tendon. This is the white color peroneal tendon. This is the muscles which are there. You can temporarily fix it. And then go behind in the window between the peroneal tendons and the FHL. So you open the sheath and you will see the muscular belly of the FHL. Once you open the sheath, the peroneal tendons come anteriorly, and behind you can see that's the FHL. This is here. And that would be your posterior malleolus. So again, we're just stretching it a little more.
That's the peroneal tendons, and that's the posterior malleolus over here. This is the Homan's retractor that you can place, elevating the FHL, and that's where you will have your posterior malleolus.
This will goes in lateral flap or in posterior flap?
The basic trauma, guys, any question on this approach? Niharika?
Hello.
Any questions?
Yeah. Hello.
So this was the posterolateral approach. Similarly, you can have the posteromedial approach.
Sorry, Abhishek, can I interrupt you at this juncture because I thought it is important.
Sure, sir.
Okay. The sural nerve goes in lateral flap or in the posterior flap?
It
I
goes
mean
in
to
the
say,
lateral.
if you are dissecting it in the posterolateral approach, the sural goes in the lateral flap or in the posterior flap. Means we have to go lateral to the nerve or medial to the nerve.
You have to go anterior to the nerve. You have to watch the nerve, and wherever you see the nerve, in whichever window you are working in, you have to push it away from your window. So it can be in the distal half or the inferior half. It can go in the anterior window or anterior flap. But you have to look out for the nerve, and you will see the nerve. If the nerve is crossing high, you might have to take it anteriorly right from the beginning. Most often than not, it crosses little in the inferior half or the in the inferior half, where you will get a window in front and back. So you have to look out for the nerve and then make sure that whichever where you are safe, you have to go there.
Thank you.
So this is a posteromedial approach. Again, the landmarks. Thank you. So this is a posteromedial approach. Again, the medial malleolus, midway between the heel and the medial malleolus. You have to watch out for the neurovascular bundle that comes over here. You can mark the neurovascular bundle and go slightly anterior to that. That's the medial malleolus. Here you have to be little liberal in your incision because you want to make sure that the retraction does not cause any tension onto your neurovascular bundle. That's the skin subcute, and there you will see tendon sheets of the tip post and the FDL. It's the tip post, FDL, neurovascular bundle, and then finally the FHL. So you have to come slightly anterior to the neurovascular bundle. You will see the red and the yellow wires over here. That's your neurovascular bundle. And that's how the tibialis posterior is over here. Or rather, that's the FDL. Tibialis posterior is more anteriorly. So you have to make sure that the windows that you make, respect, and that's the FHL. That's how it will be seen. The FDL, neurovascular bundle, and the FHL all cross over here, and the FDL and FHL will cross below the navicular on the foot or the midfoot at the knot of entry. So if you're making a window posterior to the FDL, you have to make sure that you are careful about the neurovascular bundle, and that's how it will be. That's the vein, the empty pipe, infant feeding tube, and this is the neurovascular bundle. So you can go through this approach, address the posterior malleolus, or sometimes even the posteromedial talar body fractures can come through this. That's the window. Any questions on posteromedial? We'll quickly, sorry, sir. So posteromedial, it's rotational pylons where there is a posteromedial fragment, medial fragment, talar body fractures, posteromedial where you've done all those things. You can approach it through that side. It's an old ankle posterior malleolus posteromedial rotational pylon, which me and Ashish sir had done long time back. Some of you all must have seen this also. Yeah, this is a very old presentation that me and Ashish sir had done long time back. She was a biker, no sir, if I'm martial arts. So this was the fracture. You could see this fracture over here. Maybe on the X-ray, whether to fix which approach, whether to fix or not, and if you are fixing which approach and what implants. CT scan the key thing over here, the CT scan showed us was there was a small die punch over here in the last two sagittal cuts on this. And there was a posteromedial and a posterolateral component to it. So approaches could be posterolateral, posteromedial, central, or arthroscopy assisted. We did arthroscopy assisted. We did posterior arthroscopy ankle. This is how we come in. This is what we see when we see. And this is the ankle joint when you open up the posterior capsule. And this was the die punch that we could see. And very often I feel, and that's why if you read, I think it was JBJS 1819 that said that, in spite of fixing the malleolus, there could still be a step on this. So we could reduce this with our probe, like you could just nudge it down. And once you've got that down, see, this is how it reduced. And then we could pass screws and hold it in place. Posterior malleolus didn't give us trouble. I think the posteromedial screw gave us trouble, no, sir? She was fine. So we did an arthroscopy assisted posterior malleolus fixation. Thank you. Yes, any questions? Posterior malleolus, ankle, bimal, trimal.
I have a question, sir.
Yes.
Sir, in isolated posterior malleolar fractures, is there any role of conservative management if the fragment size?
I think more than the size, I think the displacement and the articular step off would decide whether it can be or it should be conserved or can be fixed. Anything can be fixed, anything can be conserved. But ideal indications is if there is a step off of more than 2 millimeters in the ankle, ideally
Irrespective of the
you
size.
should decide. Sorry, sir?
Irrespective of the size of the fragment.
Yeah, irrespective of the size. So if it is a small sliver, invariably it would be more of a syndesmotic instability. So you have to check for all of those components. So arthroscopy also gives you an access to check syndesmotic instability. So the ligamentous laxities and the bony congruity, those two components would decide whether we need to fix or not fix.
So,
Yes, sir.
Abhishek, may I ask you a question? Given a choice, either of one, what would you like to address more importantly, the posterior malleolus or the syndesmosis?
Both.
Both.
There's no two way on that.
No,
One
because
is the
at times, literally, like the question was raised, if the fragment is too small, it is rarely fragmented. But yes, a too small fragment, probably under the capsule, just having a flap of the PITFL, but adding to the instability is there. So literally, probably, yeah, literally it cannot be fixed.
A good corollary to that is your own house, sir. In your house, there is a structure which has the beams and the walls and everything. And there are ligaments which also like the roof and maybe the interior designing. So it depends on whether you just want to live in like 4 walls or whether you want to live in the 4 walls with a good roof and a good interior. So all things contribute to a good home. So you just explain the patient that way, and that's how you understand it in your head. I think both are important. Like you can live in one of them, or you can live in a jhad ke niche also, but it depends.
Then my understanding was if you have reduced and fixed all the 3 columns majority of the time, forgetting about the caput or like staffade, means just ignoring them at the moment. If you have anatomically fixed all the 3 columns, will it require syndesmotic fixation?
It may still need a syndesmotic stabilization because we've studied and we've learned from trauma that when the bone avulses or like bone, one of the column breaks or bone avulsion happens, there could be a stretch in the ligaments. So even though you get the anatomy correct, like that's the bony anatomy correct, you still may need ligamentous stability to give function to your ankle joint biomechanics correctly.
Okay, thank you.
Yeah.
Good. Any question to Abhishek? Not Abhishek. Ashish.
Yes, sir.
Ashish.
Yes,
Sir,
sir. Can I just add something?
Yes, sir.
Alok bhai. Yeah, can I just add something?
Okay.
See, Mason's classification told us That smaller the fragment, more is the chance that there is an instability. Because it's an avulsion of PITFL.
Yes.
By and large, 75% of the syndesmotic injury would get settled down if you fix posterior mal. But that is not always true. And smaller fragment, almost always you would require a syndesmotic fix.
Rajiv bhai, Rajiv bhai,
Wanted to ask you.
Rajiv bhai here, Asif.
Yes, Asim sir.
Yeah.
Yes.
Mason is, he made a very drastic statement that in last 3 years I haven't done a single posterolateral. I do everything by posteromedial. Your take on that?
I do everything with modified posteromedial approach. Almost everything. That's MPM approach through which you can go to the posterolateral, you can go posteromedial, and more so when you have a delayed presentation. You're doing osteotomy of posterior malleus. You want to see where your osteotomy comes out. So it is a modified posteromedial approach. MPM approach is my go-to approach for most of my posterior malleolus. Or for acute that is the approach where you don't even need to go with posteromedial plus posterolateral approach.
This is for isolated posterior malleus.
Abhishek.
So this is for isolated posterior malleus, right? What you're mentioning?
No.
Any posterior malleus.
No. So, Ashish bhai, my question to you is, what is your take on order of preference of fixation in SER4 injury and in PER4 injury?
SCR, I think PER is pronation external rotation and SCR is supination external rotation. Yeah. So I think we'll just try to reverse the order in which they are broken. But for me, if I have to fix a posterior malleolus well, I need to get the length of the fibula. So that is what I try to fix first. And if that is a comminuted fibula, then it is a slight bit of a problem. But that will help me finish all the posterior lesions first and then turn the attention to the medial and the anterolateral one.
Because you fix the fibula first with an interfrag, converting into a fixed length structure, then you later on went to the posterior malleolus. Means what my understanding is to temporarily, I know, Raju sir, my understanding is ki, you hold the fibula in a reduced position, then you fix, because it's an intra-articular fracture having at times something more, means there is a loose fragment as well there. What is my color? Yeah.
So you can do that. So you can hold it with clamps, wires, fix the posterior malleolus well, be 100% certain. And most of the time fixation of the posterior malleolus will be like fixing the anterior wall of the acetabulum. It's an indirect reduction where you see the end of the, you match the apex to the apex. So you presume that the articular surface is now
Indirect reduction. The idea is always an indirect reduction until unless aided by orthoscopy. So it's an indirect reduction for the posterior malleolus. Am I right?
Yes, sir. And Dr. Rajiv Shah has some other contrary point.
I know.
See, it's a myth that you have to first fix posterior malleolus and then fibula. The situation is sometimes so warranting that fibula is very much comminuted and you want to bring it out of the leg. So it is at that time you fix fibula plate first and then you want to do, put in a plate for posterior malleolus. The way forward is to put your ankle into 45 to 50 degree of external rotation on table and you would be able to see posterior malleolus complete.
Yeah,
Yeah, I wanted to ask you, Abhishek, that when you put that washer, it is on the convex surface, either posterior malleolus or the medial malleolus. So what happens is it does not sit tight over there and the screw keeps rotating. So I would rather not use a washer medially or on the posterior side.
can be, especially the posterior malleolus. So what we are doing is, that's what sir also said, that, when we are trying to hold the opposite cortex and when the screws are biting in the opposite cortex, this washer, it only may not exert the entire surface of the washer pressing against the bone, but it will still be more than the tip of the screw that otherwise would have pressed on the bone, especially in an osteoporotic bone. We just want it to not sink in. That's the whole point. So with this washer, instead of a 4.5 millimeter radius, it might, or rather if I take 9 millimeters diameter of the whole washer, it might touch maybe 7 millimeters, which is still more than the 4.5 millimeter screw. So it just increases relatively more, and my whole purchase is against two cortices. Yes, Pradeep?
So when the fibula is badly comminuted, when will you be sure, you will be satisfied that the fibular length is maintained?
Tough question. I think that's one of the reasons why you make sure that the opposite side x-rays are done pre-op, especially in a pronation abduction injury, that the length is maintained. You should know where the fibula tip comes on the opposite side, and then you can dime sign this side in comparison to the opposite side. Tough question. Not just the length, but I think the rotation is also extremely difficult to gauge on table in a traumatic situations.
All complex trimal fracture, it is always advisable to paint and wrap both the sides and see that. That is the only way forward to restoration of fibular length in a very comminuted situation. And there are very few instances where you would over lengthen fibula. Right. So try to err onto slight over lengthening than under lengthening.
Correct.
I always paint and wrap both the sides if it's a very complex one.
So do you use any distractor while fixing the fibula in this situation?
Interment distractor.
The other way to do is what you do is you take the distal fragment only, you get matching of that internal part of your fibula, the lateral part of your talus, and you fix it with a wire. Okay, put a wire through the fibula or through the lateral malleolus into talus. So that is constant, and in between, then you decide if it's a lot of comminution. If you want to do a primary grafting and put a long plate.
Okay.
That is what I would do for your comminuted. Question for Ashish: do you always now put a lag screw for your fibula fractures?
So we moved on. I mean, there was a time when we used to start putting smaller plates, 2-hole plates, and then the AO started coming. But then, having thankfully working with Abhishek, we found a lot of stiffness, and then with bulky implants posteriorly. So I moved back on erring with minimal implants with screws. That's my go-to implant. Sorry.
But for your fibula fracture, short oblique, long oblique,
right.
do you put a lag screw?
Yeah, generally, if it's laggable, I mean, if I can get a good primary stability, I put a lag screw.
I don't put lag screw. I think I reduce it, put with wire, and I put a plate. The reason is, and the thought is, and there's been a big discussion happening on that as well. When these patients come for removal, right, you usually put your lag screw from anterior to posterior. When you want to remove your lag screw, you always have to lift up the whole thing.
Flap. Yeah.
And then, what are you doing? You're lifting up your syndesmotic ligament. And you're then removing the screw. Invariably at this time, when we counsel a patient, you don't tell them 6 weeks rest, 6 weeks in walker boot. They start walking. What are you doing actually? You lifted up everything, removing it, and then now mobilizing it.
But yeah, I mean, I get your point, but generally the lag screw won't come as low as that. I mean, it will come sort of in the metaphyseal diaphyseal region.
Don't put it.
So one more. Yeah, Samarth.
But then you're removing a plate anyway, and then do a separate incision, faff around it, and then remove it. But invariably, in the last 3-4 years or even 5 years, I have not put a lag screw, and I find no issue with it.
Can I
You
ask?
can have to. I mean, you can hold it and put up this thing. There's no sense. I mean, there's no problem with that. But I would be more happier putting a lag screw, freeing my hands, going behind.
We did that, but come removal, you see when you want to remove that, you lift it so much up that you effectively, I get scared. Boss, I'm removing your inferior, your syndesmotic ligament to remove that lag screw. And you counsel the patient for removal of implant, right? So you can't leave that screw inside.
So can I ask a question?
One more point to add on. Yeah.
There's another question from Dr. Samarth Thakkar. Yeah, we'll just take that.
Yeah. Just a point to add, a newer concept, which is the ring concept or a quadrimalleolar concept, where I felt the AITFL is also an important stabilizer and which should be addressed in all trimalleolar fracture. So it is now a quadrimalleolar rather than a trimalleolar. So what we do is do posterolateral, fix posterior malleolus and the lateral malleolus, medial side, fix the medial malleolus. Even if it is unstable after that, you open a small anterolateral approach, fix the AITFL. Even still the syndesmosis is unstable, then we put a tight rope or syndesmotic fixation. Any take on that?
Yeah, see, the one point if you want to take home from all this discussion is ankle fracture is all about stressing. When you induce the patient, stress ankle. When you fix one fracture, stress again. When you fix another fracture, stress. You do your syndesmotic fixation, stress. You could have dealt with problem. And once you feel, oh, I'm done, again stress. That is what is going to give you the successful end result.
I add one more thing. Almost every ankle fracture get a CT scan done. I think that's what the point was. You will find that your bimalleolar becomes trimalleolar, your trimalleolar becomes quadrimalleolar. So then it comes to so your question is, your posterior malleolus is there, you fix your posterior malleolus and you're still fine. And a lot of people probably don't stress the ankle. You need to still stress the syndesmosis. And if it is opening up, then either you have missed your AITFL fragment or a AITFL injury, interosseous injury. In those 20-25%, you need to fix the syndesmosis. And that's why get your CT, study the CT yourself, and do not look only at the 3D recon. You have to sit down and look at all the views.
Sir, can I ask a question?
Yeah.
So I'm dealing with a mid-shaft tibia fracture with a distal fibula fracture. The syndesmosis is not involved. So in what scenario I should fix the fibula and where I can go away without fixing the fibula?
Your best shaft with a distal fibula. So if it's a fibula fracture at the same, so you're talking about a mid shaft fracture tibia.
I have to do tibia interlocking. So
yeah,
I should be doing a fibular fixation on what parameter if the syndesmosis is not involved?
If the syndesmosis is not involved and the tibia and the fibula are at the same level, then I would probably fix the fibula as well to get more stability, because then that tells you about the violence of the injury and the chances of getting a good reduction is there. And you don't need to make it a very rigid fixation. You can just pass a tense nail or some kind of minimalistic fixation to give that resistance against any deforming forces.
Any criteria of say 5 centimeter above the joint line you need? I mean, it's not mandatory to fix the fibula. Is there any criteria of some sort?
No, not that I am aware of. That is there any defined criteria that if it's above 5 centimeters that you need to fix. But we generally tend to fix if there is a fibula and a tibia, we generally tend to fix the fibula as well. Sorry.
Even in Mesoleo?
Yeah, that's what I said initially. Yeah. There's one more thing I would like to add to Dr. Pradeep's point about the CT scan. So this is something I learned from Dr. Mangal Pariyar, that he had a CT scan of a normal ankle, 2D images of the level of the syndesmosis just handy in his phone for reference. So that, a lot of times the syndesmosis, you may feel that the incisura may feel that it is sort of slightly open or it is not quite, concentric. So you refer to the normal side of another patient also, you would see that, you get a perspective. So every patient, you might not need to have bilateral CT scans, but yes, there is a lot of variation even in normal individuals. But it helps just to have an image of a normal CT scan of the syndesmosis, a 2D transverse image at that level.
It's quite interesting how evolution has happened in the radiology people. I remember when we started it, when you asked for a CT, you would always get a CT of both legs, and Kalkani sir and everybody would agree. And now they're specifically giving only CT of the same leg.
And I don't know.
Yeah, they give the CT of only the one leg which you wanted. And if you ask for the other side, they charge it 2x. Though the ankle is there straight, right? It's in the same. You get scanned both sides. But these guys have now done it the other way because we are doing more and more 3D printing. So we need the normal side. So it's 2x. So if you want to see the syndesmosis, you specifically need to ask for it.
Pradeep, we can charge
Very much. I think we'll call this session to an end. and move on to the next case. Those were a lovely case and a very lovely demonstration by Abhishek of the approaches. And we now move on to Dr. Rajiv Shah, who is going to talk about fixation of the fifth metatarsal fracture, what is called as the Jones fracture.
So I am given a title, metatarsal and Jones fracture fixation. So far as metatarsal fractures are concerned, it could be a talk without much of the video. But the Jones fracture, tuberosity fracture, it could be with the videos. So most of the forefoot fractures can be managed conservatively with plaster cast, except certain fractures. And the indications for forefoot trauma fixation is peripheral re-injury, first and fifth, cases with shortening and displacement, some segmental injury, multiple re-injuries, and cases with the bone and tissue loss. And how do you do that? With K-wires, screws and plates, external fixation, combinations. It could be open, it could be percutaneous. Talking about the first metatarsal fractures, if they are unstable and displaced with angulation of more than 10-degree, displacement of more than 3 mm, with an articular involvement, shortening or rotations, they require fixation. So cases like this, they are the injuries of peripheral ray. You would need a fixation like this, or a case like articular involvement with a fragment would need fixation like this. Talking about the central metatarsal fractures, if there is a gross displacement in sagittal plane or a dorsal angulation or open injury, or if they are a part of multiple metatarsal fracture, then they would definitely need plate fixation like I have shown here. It is the multiple metatarsal head, neck and fractures which are quite common with an articular involvement, shortening, rotational deformation that you need some kind of fixation. This was a 26-year-old male physician. 3 weeks he presented. And the question is, should you accept this? If you see his injury films, this were all injury films like, and this was at presentation. Can you really salvage it, or should you be doing conservative management? Look at the way this metatarsal heads are lying. It is a distorted metatarsal parabola which would result into abnormal pressure areas. And this patient would come up to you with cons and callosities. So for such multiple metatarsal neck shaft fractures, we do MIS surgery. K-wires are used as a joystick. It is a joint sparing intramedullary K-wire fixation, which is a spanning fixation where you do fanning and jamming of the K-wire. The way it is done is putting a patient onto tibia frame, tibia nailing assembly, and a towel bump underneath the foot so that you have a place for introduction of your implant. And what do we do? A joint sparing pilot hole with 2.5 mm K-wire is created into the base of metatarsal. And then it is replaced with a passage of a thin band K-wire, which could be 1.5 mm. And the tip of that K-wire is blunted. And then you pass this band K-wire across the fracture site with your rotatory T-handle movements. It looks on a video like this. You keep it reduced and pass that wire. You need to have traction as your reduction tool. And sometimes you're using K-wire as a joystick to keep that reduction maintained. You just turn the band K-wire and that is going to give you the reduction. Your placement of the band has to be strategic. One more K-wire will pack the cavity, jam the cavity. It will also maintain the length of the metatarsal. And this is how it looks. If you have a proximal fracture, this could be the configuration of K-wire for proximal fractures. So that case which I showed
of a physician was treated with multiple K-wires closed MIS. This was like you could push such fractures, you can put in a K-wire MIS without spanning, without violating the joints. When you reach to the end, you rotate and hammer a blunt K-wire, which would maintain the metatarsal length. And this is what we were invited to write into AO Manual of Foot and Ankle Trauma onto this joint sparing minimally invasive intramedullary fixation. Coming to the fifth metatarsal fracture, when such sharp fractures are with shortening and displacement, you do need fixation. Cases like this, you would need fixation with a plate fixation to maintain the length of metatarsal. Some selected cases, you could do MIS K-wire fixation also. The same technique, put in a pilot hole, a wire, remove that wire, push in another wire which is blunt tipped, bent, push it in, reduce and fix it. This is how it would look. But the bottom line is when you're talking about the fifth metatarsal fracture in zone 1, which are avulsion fracture with displacement of more than 3 millimeter, comminuted avulsion fractures, all this requires surgery because this fragment has got attachment of peroneus brevis. You could fix it like this. You could use a K-wire plus tension band. You could use screw plus tension band. But I'm going to show you the video of avulsion fracture of fifth metatarsal base. This was a 32-year-old male, had a twisting trauma and had a bony avulsion of peroneus brevis. Patients, this is one position into which you can put the patient, the hanging assembly of tibia nailing, and you could wrap it and you could easily see imaging like this. You could put in a bump for easy introduction of your implant. The another position could be a lateral position, and this lateral position you could put in a bump to level the knee and ankle and see the imaging AP as well as lateral. The planning for such a case could be a suture anchor through which you tie peroneus brevis and remove the wire fragment, or you could do pull-out suture and remove the fragment and do it, or you could use a mini screw if the fragment is good enough in the size plus or minus tension band wiring. Typical instruments which you need multiple dental picks for reducing these fractures, and you need a small fragment drill. You start with your marking. Patient is in the lateral position. You mark the peroneus brevis tendon and the fifth metatarsal base. And you also mark your incision, which goes for another 1.5 centimeters from the tip of the fifth metatarsal. Your exposure starts where you expose the peroneus brevis, which is lying dorsal, and that's a bony fragment, little comminuted here. And that's how you expose. Once you have exposed, you again delineate that fragment which moves, and that's a tendon of peroneus brevis, which I am showing. Then a suture anchor is used. Make sure that your suture anchor reaches the opposite cortex and it catches hold of the opposite cortex. That's very, very vital. And you check on the C-arm, you've gone to the opposite cortex. You also check the strength of your suture anchor by lifting the foot. And then your typical suturing starts. You pass the sutures through the peroneus brevis and attach it. Your fragment may lie anywhere as long as you attach your peroneus brevis to the bone. You are done. This is how the this thing looks like. Coming to the zone 2 and 3, that is John's fracture, which is into the watershed area. You typically like to do fixation in young patients who are demanding, patients who are obese, patients who have a cavus foot. You do this, and this is a John's fracture. You treat with an intramedullary screw. I'm going to show the video of a John's fracture in a case of a 32 years gynecologist with a John's fracture. She was treated with a walking boot. And this is how was her first X-ray. She presented to us at the end of 8 weeks with pain and inability to walk. And obviously you see that there is hardly any healing into this. So delayed union or non-union, literature has reported 7 to 4% rates, and a refracture is up to 40%. And that is where the indications for surgery for Jones fracture are acute fracture in an athletic, acute fracture in the very high demand patient, cases with non-union or revisions, and the cases with the cavus foot. I like to operate this cases into patient position onto lateral side and C-arm is going onto the opposite side. And the first thing you do is to do image check, AP and lateral. When you turn C-arm into the lateral position, it shows you the AP image. When you keep C-arm up, it shows you the lateral image. And then you start with your markings. Markings are done for screw entry, which is about 1.5 centimeters proximal to the tip of the fifth metatarsal. So you have a leeway to really go into the metatarsal. This case I also marked for the bone grafting. And the first thing you do is you put in a wire which is high and inside. And typically what I like to do, I like to make an entry with a 2.5 mm or a 3 mm wire, which is going high and inside. And then once you check this wire under the C-arm, you advance this wire just distal to the fracture site. So I've checked it into the AP and lateral, and this is how clinically it looks. And once you advance it just beyond the fracture site, replace this thick wire with a guide wire and check your imaging. Guide wire is pushed further. You would measure the screw, pass the screw. Toe extension is very, very important to remove all the slack. And this is how the final images looks like. Yes, you could go in for airball. You could have non-union. Some adjunct procedures are required in cases where you have a cavus foot, do lateral displacement calcaneal osteotomy, longus to brevis transfer, and dorsiflexion wedge osteotomy for first metatarsal. That's all. Thank you very much.
Thank you, Rajiv bhai. So,
any question?
please ask your question.
Alwar. One of your cases, you have shown a suture anchor for fixation of the base of the fifth metatarsal. The bone is not in its approximation, but you have made sure that the peroneus has come back with the suture anchor. So is bony approximation not necessary?
If you get it, it's good. If you don't get it, it doesn't matter. Sometimes you can excise the bony pieces because your whole idea is to give an insertion to peroneus brevis tendon, which is a very important tendon for doing the eversion.
And as far as the metaphyseal fracture of the fifth metatarsal is concerned, can we do plating in that case where you have shown with a screw fixation?
See, the stress fracture which comes between the zone of Jones fracture and the shaft is better treated with an intramedullary screw. You could as well go in and do the extramedullary fixation in form of a plate, which has little more complications with screws because you are quite subcutaneous and then you are exposing everything. So I would go ahead with an intramedullary screw. Sir.
So that means Jones fractures should be fixed because it is different from fracture of the tuberosity of the fifth metatarsal.
Jones fracture, it falls into a watershed area where there is less blood supply. So by and large, Jones fracture requires fixation. But then coming back to your question, it was in 2020 that American Academy of Orthopedic surgeons conference, they wanted me to talk on to conservative management of Jones fracture. The topic was given 1.5 years prior. And I said, what the hell? I treat Jones fracture with surgery. They said, whole world does that. You show us the result of conservative management of Jones fracture. You have another 1 year and 4 to 5 months. So we developed and devised our own protocol to treat Jones fracture conservatively. And we showed case study of 22 cases, where the first plaster was given a complete Biloni plaster in dorsiflexion and eversion. That was there for 4 weeks. The next plaster was a weight-bearing short Biloni plaster in a neutral position. That was for 6 weeks. It was at the end of 8 to 10 weeks that patients were mobilized, and we could show that out of 22 cases, only 1 case went in for the delayed union. All other sportsmen, marathon runners, they all united. But whether our patients are ready to wait till long? So you're looking at a case of a sportsman or an obese person or a patient with cavus foot, high demand, where you definitely go in and after intramedullary screw fixation, you give a splintage for about 3 to 4 weeks, start mobilization, non-weight bearing for another 2-3 weeks, and then look at the X-ray, look at clinical this thing, and can start mobilization weight bearing. It could be in a dynamized way. So you could start with a walker, go to the stick, go to the walking without this thing. And mind you, clinical union always precedes radiology. So don't go on radiology. Go on clinical evaluation. Yes, Dhrumin.
Can I request Alwar to silent mute themselves? Y'all are very loud.
There is a question by Dr. Dhrumin that if patient presents at 3 months and there is no union, if I do, I add bone graft. So this 8 weeks post-trauma gynecologist, I did add bone graft. I've not shown it, but I did add. I agree that only is, so it's a good fixation. It's like a hypertrophic non-union, but sometimes you want to be extra sure. That's why I added the bone graft.
Also, as a comment, I think when we are doing an intramedullary fixation, we have to make sure that you get a 4, 5, 6 and a 7 mm screw. And invariably in an Indian patient, we have that 5 mm screw, which should be long enough to have that, which not very many companies have it. You can't end up with a 4 mm.
Pradeep, can you give me a single example where you use 6 or 7 mm screw in fifth metatarsal?
That's what I'm saying. So 6, otherwise it's very short. You don't get it lengthwise. You have to have a purchase in the distal cortex.
My plea is don't go as long as far as you go. It's a curved bone into which you are putting a straight screw. So typically and don't go like beyond the neck shaft, this thing. Otherwise you are making such tough situation that you will have a fracture. And literature has shown that. So typical screw size is 4 mm, 4.5 mm, maximally 5 mm diameter. And the length is not beyond 40 to 44.
What I'm saying, so 5 mm screw, two companies only making it, or 2 or 3 companies. On a routine basis, you do not get a 5 mm. Now only in the last 2 years we have been getting it.
Yeah.
Rajiv, I think you are using a compression screw, which is not cylindrical, it is conical, where the base is broad and the apex is narrow. That is the screw that you are using for this, because if it is just going into the medulla, it's not going to cause any compression. So it's a broad at the base and narrow at the. So that's what you are using, I think.
I was to request Gautam by that, remove this talk from, because I had no good video of John's. And then in the last week only, the case which I showed, I did yesterday. In whole night yesterday, I sat and so Now I have started using the screw which has got a radial preload, which is having a differential pitch. Otherwise, I used to use a head screw with a head. So head in itself, when you push it, will compress. And at the same time, if you saw, all toes are extended. So all slack is removed. And when you push the screw, it gives compression. Another important tip is that when you're putting a screw which is going beyond the fracture side, assistant holds the metatarsal between great toe and the thumb. Index finger and the thumb. So you don't allow even rotations to happen. So dorsiflex all the toes and hold the metatarsal with a finger and a thumb, and then you tighten it.
Rajiv bhai, you talked about the multiple metatarsal fracture fixation, and you showed ideally that you should put two wires, but the cases you showed, you had put only a single wire in.
Yeah. So
and this thing. And the other, just to add to it, just my question is that they are all put percutaneously, and then the foot is edematous, and you have bent them percutaneously. Doesn't it cause any skin problems over there?
Not really, because once you fix the fracture, once the unstable situation goes into stable situation, the edema starts reducing very, very fast. And coming to this, use of one or two K-wires, if it is a single metatarsal, where you have a kind of metatarsal support, you could get out with one K-wire. Sometimes our bones are very, very small in diameter. You could have to use only one wire. If permitted, I will always put in two wires like an ender nail to jam pack the cavity.
Also, when you are putting them percutaneously, the chances of tendon injury over there.
No, these wires are put from the flat triangular medial or lateral surface of base of metatarsal. Nothing comes there. It is skin and bone. You palpate skin and bone, put in a pilot hole, check it on, and then bend your K-wire. It goes like on a T-handle, like an ender nail.
Right. We've seen that with the hand where they use the bouquet technique.
Yeah.
Where they put in 2 or 3 wires and they fix it. But they usually cut the wire at the its entry into the bone, and they bury the bone so they don't have to remove the K-wire, so they don't have to remove the K-wire subsequently.
Yeah. These are removed.
Rajiv sir?
See, on second metatarsal, you try to be more on the lateral side than on the medial side. And even if you are on the medial side, you're going from the base of medial aspect of second metatarsal. You're not going to injure the dorsalis pedis. But artery is just going in between and plantarwards. If you see most of my cases, I have gone from the lateral aspect. If at all, the lateral aspect of the base of second metatarsal. Yeah, so you don't encounter the nerve or artery. But sometimes the configuration of fracture is such that you need to go from the medial side. Then also it is not a problem. It's not a problem. Right? Because you're going into the shaft from the base. You're not hitting the nerve or artery. You can always palpate nerve or artery. You don't use tourniquet when you're doing these cases.
Rajiv bhai, we move on to the next talk, and that is from Pascal. He's going to show us a video of how to fix a Lisfranc's injury.
So to follow up with that regarding the dorsalis pedis, we'll just show you in this video. I'll be able to show you where the dorsalis pedis is exactly going. So that's why I think sir did not mention about dorsalis pedis injury, etc., because the course is a little bit different from what was asked. Okay, so speaking about Lisfranc fixation, Dr. Zaveri in the morning, the first thing he told us is give your conclusion at the beginning. So that's the thing at least people remember. So my only conclusion for this is that what you have to understand, there is no role for any conservative treatment in this. There is no role for plaster application. And there is no role for definitive K-wire fixation. If you have like a degloving injury, etc., yes, you can temporarily hold it with K-wires just to maintain it in place.
But otherwise, permanent fixation, there is no role. So these are my only 2 points that I want to make today, and the rest of it is kind of straightforward. So I love talking about Lisfranc injuries, especially so that we can change people's concepts of what it is. You have to understand the foot is not as simple as what people think it is. It's a very intelligent structure, very intelligent part of the body. There are 3 parts to the gait cycle to keep it simple. That is the heel strike, the midfoot, and the toe off. So the Lisfranc area or the midfoot area is involved in at least the midfoot and then in the toe off, right? So we have to get stability. In order to understand fixation, you have to understand normal anatomy to understand how you should fix it to at least go to that portion. So what we have to understand, you've got 3 columns, the lateral, middle, and the medial column. So the lateral column, that's 4, 5, because our method of fixation is just by K wires in this, because it has to be flexible, because your 4th and 5th metatarsals are attached to the cuboid area over there. So this has to help you in basically stabilization when you put your foot down. The middle column over here, that is 2, 3, that requires a little bit of a hybrid fixation, means not too rigid and not too flexible, because this also helps you get your balance better, and it transfers weight onto the first tarsometatarsal joint, which should be your most rigid fixation in case you do have to do it, because that will help you get a good toe off, right? So if we understand the 3-column technique, it will help us understand how we are supposed to fix these fractures later. So if you don't understand this, you will not understand why we fix it the way we fix it. The other technique is that if you still go to the AO manual, somebody spoke about protocols and globally accepted protocols. If you still go to AO, up till about 1.5 years ago, they said that you have to fix Lisfranc injuries with screws. But if you go to the Indian Foot and Ankle Society and most foot and ankle society, you'll see that everyone is using plates now because we have really good plates available, and we've moved away from screws. Everybody used to keep talking about keystone, keystone. I never understood it when I was a postgraduate. But now when I went up and looked at the picture, you understand the keystone is the guy right in the middle on top there. So if you take it down, your entire arch, or if we do an actual section of the foot, you'll see it looks pretty much like this. If you take out your second metatarsal base, you can see that the entire arch is going to collapse. So every time they have these debates at all these conferences, what do you fix first? 1, 2, 3, 3, 4, 5, etc., whatever. Understand one basic thing. Your second metatarsal has to be fixed. The Lisfranc, it was asked in the quiz. Second to medial cuneiform has to be your strongest fixation. Baki sab you can see later on. Okay. So case is a 60-year-old female. She had an injury in a road traffic accident and she had pain and swelling in the foot. Luckily, they examined and they found that she had a grade 2 injury. She had multiple fractures in the foot and she had a Lisfranc injury. So if this is basically just showing you all the, this is how a foot looked, and you see the actual things. You can see the crushing injury. You can see the keystone sort of configuration, which I'm talking about. You can see on the volar aspect, there are ligament basically avulsions over here, and you can see that, it is crushed. The second, the third, fourth, and fifth are all involved. Now, the question in this case is there's a lot of debates because you've got a CT scan done. Sometimes you can do an MRI before the case itself, and you know how many ligaments are also involved. So you have a rough idea as to how much fixation you require to do. Right. So when you do a CT scan, in this case, it's kind of obvious, but it's in the minimally in the minimally displaced patients that makes decision making. So you can plan your fixation better. Because if, for example, we are using a single incision in this situation, right? And we only do this once the swelling comes down. There is no emergency to do a Lisfranc fixation. You don't have to post the patient within 2 or 3 days and saying this is a dangerous fixation. You have to wait for the swelling to come down because you're going to be making 1 or maximum 2 single large incisions on the dorsum of the foot. So you need to wait for the skin. You need to see your wrinkle sign come up, right? And now why I said you have to decide pre-op itself, whether you have a lot of first TMTJ involvement along with the Lisfranc, or is it mainly 2 and 3, right? Because based on this, you plan your incision, because either you'll base your incision over the second metatarsal, or you'll either do it more medially or more laterally, but over the second metatarsal. So if I have my first joint involvement, I always make my incision on basically the medial border of the second metatarsal. If I know it's only 2 and 3, then I basically put the incision more bang on the central of the second metatarsal, so I can work on the second and third with a single incision. So most important in any surgery is that you should know how to plan your surgery as far as position is concerned. You may or may not have assistant, but basically you have to do the positioning based on how you would expect the C-arm to come in and out over there so that your fixation becomes easier. So I don't do it in supine. I don't think anyone does in supine. They always do it with the flex position, like we can see in this scenario. We've got the patient lying down in supine position, and we can put a small bump below over there, like a folded sheet, and then stick it to that to the base, and we've got a side support on this side. So basically, our C-arm can come vertically over there, and there's no problem. If you put a bump over there, it helps an indirect reduction of your metatarsals because it's giving the support below that, right? So this is the position what we would go for. Now, these are the two incisions what we use, and there's also, so there are three, you can either do a single incision, that is through the second metatarsal over that area. The lateral incision could be between the third and fourth websites, or third and fourth metatarsals rather over there. And you can even do a medial incision, which is on the inner aspect if you're suspecting a first tarsometatarsal joint instability. So now this is in this video over here, we have to do a single straight incision. So in this case, I've gone over the second metatarsal base. Before I forget, you also have to check for the dorsalis pedis and the posterior tibial artery before, right? So that we know that we're having some. Yeah, so when we go down over here, I'm going over the second metatarsal, and it's a nice deep cut over there because again, like I said, the problem in foot and ankle is wound healing. So if you have a nice thick skin incision over there, you can basically go directly towards the bone. But obviously, like I said, if you're going over the second metatarsal base, you kind of will miss the dorsalis pedis artery. And a lot of times people might say, what happens if you cut the dorsalis pedis artery? Nothing will happen. I would always suggest that you isolate the dorsalis pedis artery because there has been a few rare cases where sometimes the patient's dorsalis pedis is the only supplying artery because the posterior tibial artery has gone for atherosclerosis. Then you're going to end up with the problem later. So when I'm coming to this, when I come to this video over here, remember this, there's certain anatomical landmarks which we have to keep in mind is that the extensor hallucis brevis, in this case, is your lighthouse. Okay, so basically it starts, and if you basically move the muscle belly, you will find out that is your middle cuneiform. Your middle cuneiform has to be visualized because your second metatarsal base has to sit over that. And just medial to that, you'll be able to see the dorsalis pedis artery. So in this video, when we can see you can see easily the medial, the extensor hallucis brevis, and you can see the dorsalis pedis artery, which has been isolated over there with the infant feeding tube, right? So it is cumbersome to get this. Sometimes people have heard at conferences saying nothing is going to happen, but I always, if you can find the dorsalis pedis artery, which you will find in most cases, you must isolate it and you must protect it. At the same time, what we can see over here is that that's the Lisfranc joint over there. It's a nice L-shaped step off over there. And you'll be able to see the Lisfranc ligament avulse. This is not the most difficult situation. When you're examining now intraop, you have to make sure that there's no tarsometatarsal of the first instability or the intercuneiform ligaments, whether those are intact or not, because that will also help you plan your fixation. Moving to the second video, obviously the foot is not as contused as the first video. So it's a little bit easier to appreciate the anatomy over there, where you have the EHB tendon, which rises over your rather your middle cuneiform. So that helps you start planning out your fixation. So it's simple and straightforward. I have to get my second attached to my medial cuneiform. That is the basis of this entire fixation. And after that, we can use, I think everyone has spoken about using the Hinterman. That is the most trusty instrument that you can use in foot and ankle surgery. Because a lot of times, what you need to understand is that a tarsometatarsal joint is an extremely deep joint. We might be feeling it's probably about 10 millimeters or 20 millimeters. It can go up to about 30 millimeters. It's a huge joint and you have to see it. Because a lot of times ligaments get basically interposed in between and you can't get a good reduction. So it's extremely important to visualize the joints. Now coming towards the reduction, simple and straightforward. Because of the position of my foot over that bump over there, I can, and it's towards the end of the bed, I can dip my hand down, because a lot of times what happens is that when you're aiming for this, so if you go back and look at AO, they always talk about coming from the medial cuneiform to the base of the second metatarsal, but we do it opposite. We do it from second metatarsal towards the medial cuneiform because it's basically easier to do. In this scenario, right, you have to hold the reduction with your reduction clamps or a towel clip like that, and then pass a K wire. And at the same time, you have to just pass your drill. So we can use a nice 3.5 cortical screw over there to cause good amount of compression at the Lisfranc joint. What you have to understand is that you're not going to breach any cartilage in this area because this is the non-articulating surface. So when you go in over there, the first thing is you stabilize it. You can pass in your 3.5 cortical screw. Okay, so now we can see this on the SYMPOSIUM. This is in general the toolkit what you would require basically for your Lisfranc fixation. Nowadays you have a lot of these low profile plates which is variable angle, so it makes your life a lot easier. It depends, like I said, on the stability or instability. If you have basically, if you've got no expenses, is not an issue, you can use 2 or 3 plates. But if expense is an issue, then you have to cut down and you can use one of these X plates. The problem when you put one of these X plates isn't over there, is you really have to manipulate the dorsalis pedis so that it doesn't come in between your plates. I think that's a bit of an issue. So that's something that you have to keep in mind. Like you said, every time that you have to, if you overstabilize the first tarsometatarsal, a lot of times patients have problems with that post-op. So now in this scenario, we've reduced the first, we've reduced the second and third. And this is just the video showing you, these are the types of plates which you can basically bend and you can contour it to the shape. It's a variable angle plate like that, so it's easier for you to pass in your screws. You don't have to worry about missing, etc. like that. And these are very low profile plates. Like I said, for fixation now, what we see is that the second and third, we do plating, right? For the first also, you can consider putting a plate if it's highly unstable. If you have intercuneiform, you need to pass screws in between over there. But 4 and 5 is we always pass K wires, right? We're not going to try and fix 4 and 5 with any rigid fixation because the patient is going to have a problem there. As you can see, it's a single large incision which you can basically access to the first, second, and third, right? So you don't have to worry about cosmesis in this scenario. It's a nice single large incision and tends to heal without any issues. If you can see the, I think that is the post-op X-ray of that patient. She also had multiple fractures for which we had passed K wires through that. And when you look at the other X-rays towards the other end over there, this is the patient which had basically first, second, and third instability, for which I had to do a dual incision technique, and I have used the X plate in this. So these are different type of plates that you can't use. Again, most important thing with any foot and ankle surgery, don't forget this. As soon as you finish your surgery, you shouldn't feel happy. You should check the SpO2. It's very important. Don't forget to that, especially in these cases. So mine is always post-op is very aggressive, is non-weight bearing for the first 2 weeks, and so that your wounds can heal. What you have to remember is that in this scenario is that you can start ankle range of movements because you're not touching the ankle joint. So you don't want any stiffness to develop at that portion over there. Unless the patient has got the K wires sticking out, if you've got like fixation 4 and 5. You can start heat weight bearing in a young patient if they are compliant on a rocker bottom boot on the heel like that between the first 2 to 6 weeks. But ideally, it should be at least for 4 weeks non-weight bearing, and then you start weight bearing on the heel. So full weight bearing without the rocker bottom boot is between weeks 6 to 9, and then you can return to high impact at 12 weeks at that. There are several debates as to whether you should go for fixation versus fusion, etc. for Lisfranc injury, but I think that's a different topic altogether. It depends on your duration. This is just for acute Lisfranc injuries. We're not going to be talking about fusions.
Pascal, that was very nice. Lisfranc's injuries, I think when we were in our residency, were highly mistreated and very badly treated in this thing. I suppose now people understand it a lot better and are doing better surgery. It's open to the house. Any questions over here in Bombay? Yeah, Rajiv bhai.
Sir, do you
So,
still wait
Pascal,
for wrinkle sign?
Pascal, when you have to treat 1, 2, and 3, don't take such incision. That definitely would end up into some kind of skin issues.
I use a
So take a
medial
medial
incision.
Yeah. You have
That's what I
seen-
meant
you
in
have
the
shown,
3
yeah.
type.
So take a medial incision onto the medial posterior part of the medial border.
Yes, sir.
And then the incision between second and third, more towards third.
Yeah.
That would
Yeah, so
not
that's right.
eliminate.
I've not shown that, but because we've spoken about it, sir, if we can do the medial incision, so the 3 incisions that will be possible for that.
Right? Yes.
Sir, Ludhiana, primary fusion or I know you and you said, that, but this recently it came out like primary fusion is better in. I mean, it's not a very big study, but again, what is your take?
No, fair enough. I think every year the IFIS ka matlab, every year there is the debate, should we do primary fusion or should we do fixation? Uh, this this topic, I think Rajiv Shah sir has spoken a lot about doing primary fusion because of the lack of movements of that. I don't know whether the thought process changed. If you ask me, if it is highly comminuted and it is, say, somebody who is not very physically active, then I do consider doing fusions. But I always prefer doing fixation. If it is anything delayed, if it's 6 weeks, etc., post-op like that, then I kind of go and more towards fusion like that. But I prefer doing fixations during acute cases, not primary fusions.
What is the logic?
The logic is that
there is no movement in that joint. How does it matter?
No, there is movement. It's about 5 to 7 degrees of movement, like sir says.
You can't be just on fixation versus fusion or less frank. You have to identify which ray is unstable. Is it your first ray, second ray, and third ray? Second and third, yes, you can go away and get away with a fusion even in primary. But first ray, even in, and we presented our work as well in last FSCon. Even if it is a 3-month mark, joint looks good, subtle instability, I would still fix it and not fuse it. That 6-degree movement is very, very important of that first TMT joint. Again, it's not a blanket fusion versus fixation. It is more detailing about what your patient wants, which joints are involved.
I also think that I mean, I think what sir said is right, because every time, even if you have a list frank and you fixed with a plate to that first tarsometatarsal patient, you'll have to remove that implant. And once you remove the implant, patient feels better. The other thing is, I think, with respect to like in a Schatzker type, I mean, type 4 calcaneal, where you say, I'll do a primary fusion, those patients seem to be more happier than when you do a Lisfrank's primary fusion. So that's why for that reason, I would probably try and do a stabilization of my first Lisfrank and then think about fusion later. But in a calcaneum shattered, I would say no, a fusion works much better, because a lot of times you do have, and you can do these comparative studies on the patient itself. On one side, you start off and say, okay, I'll do the fixation of the calcaneum. It's very difficult. And at the other side, you get tired and say, no, I'm just going to do a fusion of it. And you can compare these cases, and that fusion patient does much better. But on the Lisfrank, I don't think it works like that.
In these Lisfranc injuries which are maltreated, you see, you find that the entire 4 metatarsals are totally shifted laterally.
Yes, sir.
So what are those injuries and where they have missed those?
So most of the times, sir, I mean, one, if it's treated by local treatment, if they just undergone malish or hardware treatment, then it can go like that. The second thing is, I think a lot of times if people see that they've done K wiring, remove the K wires, it still might look good. But then when patients start to walk, it gradually drifts out and goes laterally like that. So in those cases,
so
I
on
would
the
do a
lateral
fusion.
side,
Sir.
you require fixation?
So that's 4 or 5, sir. So lateral side, you just have to do a flexible fixation. With 4 and 5 is with K wires. 2, 3, you have to do it with the rigid fixation, sir.
As we can see, just try to move your 5th metacarpal. Mobile it is. And you move your 1st or 2nd metacarpal. Similarly, in the Lisfranc, fourth and fifth are the most mobile metatarsal. You never do rigid fixation, always K-wire fixation on the lateral side. Another point regarding fusion versus fixation. Earlier studies say that fusion is more beneficial than fixation. But with the newer generation of these plates, pre-contoured plates, nowadays fixation is also equivalent to fusion as the recent studies. Earlier, the trans-articular screw fixation was the more important. I mean, they used to do, there were no plates. So it's better to now fix rather than fuse. I mean, it is my view.
Sangli, please go on.
Hello. Is there any role of Lisfranc ligament repair other than bony repair in the Lisfranc injury?
Oh, you can. If you see the ligament over there, I think you can obviously suture it back to it like that. There are some cases where there is a pure Lisfranc injury. Those are the guys, I don't know whether it's for their good luck or their bad luck. They do an MRI and then you can see that the Lisfranc ligament is the one which is gone, but there is no shift. In those patients, you can do either you can do a primary ligament repair or you can use a small tightrope and you can fix that.
Right.
Hello.
Mirat? Yeah, Mirat, please go on.
Sir, what is the treatment protocol in a case of Charcot's foot, and if that patient lands up in a Lisfranc injury?
No, that's a totally different. That is not a Lisfranc. That is a midfoot Charcot arthropathy. That is totally different. But you must identify it. I guess your question is that if it is a Charcot one, you cannot be thinking that you are going to get away with just simple plates, etc., and all that. You require extensive debridement. You need something like beam screws, etc. So it's a different ball game altogether. So don't make that mistake.
No, but he has raised a fantastic point. So many of cases in a diabetic patient who comes to us with just simple sprain, you must keep an eye over it because they could get converted into Charcot.
Yes.
So many of these Charcots are treated like midfoot sprain, and it turns out to be, diabetic destruction of the foot. So you should have eye onto all diabetic patients who are coming to you with just a midfoot sprain. They will have some edema. You feel it. It might be slightly hot also. And the only thing is that you need to keep an eye over it and you elevate such patients for 2 minutes and all the swelling and everything would go. That is diabetic Charcot, acute.
And sir, if the medial cuneiform is severely comminuted and we are not able to put the home run screw, how are we able to hold that second metatarsal and medial cuneiform? If it's severely comminuted medial cuneiform.
I'm not. I think maybe they will.
So in those cases, you should not put the home run screw. You can put just wires inside. Make sure your reduction is good, and then probably put an X plate or an H plate. Let's say reverse U plate you have. Use that kind of fixation. Okay. So sometimes yes, you can't put a home run screw. Like also, if you have a fracture of the base of the second metatarsal, you can't do that. But make sure you get the reduction right. The key is assessment of your Lisfranc joint reduction. That's very, very important.
So,
I have a question from Bardhaman. Yes, please, Bardhaman, please ask.
In acute scenario, what will your timing of surgery till you use for the wrinkle sign or you operate it early?
I'll wait for even 2 weeks until the skin condition is good, sir. Because otherwise, your complication is your skin breaks down and your implants are exposed. So there's no point in hurrying the surgery.
Right. So the answer, Burdwan, is that wait for the wrinkle sign, let the edema go down, wait even for a couple of weeks, let things settle down before you go in and do something. Any questions? Yeah, occasionally you may even have to do, I'm getting a response from Dr. Pradeep and Dr. Rajiv Shah that maybe you might have to do surgeries in 2 sittings also.
I want to ask you, fractures of the base of the second, third, fourth metatarsal, there also the foot shifts laterally. So that also will be synonymous to Lisfranc?
It's like a variant, sir. It's not a true list rank, but it becomes a variant in this scenario. So in that case, maybe you can just put a straight plate between the two and cause compression at that. If the list rank ligament is not involved in it, so then you can just put a plate over it, sir. Or you can fix that metatarsal base, like what Dr. Rajiv Shah had shown in his previous case.
Or if the second metatarsal base is comminuted and you still want to fix the left spine joint, you could go to the third and put in a wire from third, which should go into the first. And you can put in a left spine screw that also. Third to second, third to first.
So, thank you very much, Pascal. That was a nice presentation. And before we start the last case, which is the most interesting of this afternoon lot, the talar neck fracture fixed through a transmalleolar approach by Pradeep, I would like to do the honors because Dr. Rajiv Shah, who has come from Baroda, has to catch a flight back. So let me do a thank you ceremony here. Rajiv Bhai, thank you very much for coming all the way from Baroda. The moment I called him up and I said, I want you, he said, okay, tell me when, what, and he has been here since morning, left home at 5. A small gift from the Bombay Orthopedic Society and personally from me, from Amravati and Nagpur. Thank you very much for coming, sir. We are honored with your illustration, your fame. You are so humble, so nice, always ready to help out. Thank you very much, sir. Thank you. अरे 2 मिनट ऊपर बात करते थे अब बता नाना छोकराओं ने खुश था the second person I would like to thank before I thank the rest of the people is my secretary of the Bombay Orthopedic Society who has organized this meeting today, done a wonderful job. Thank you, Ashish. So nice. Thank you. Can we get a photograph? Two of us. We've not had any since we became president and my secretary. That was there. I would also like to thank Pradeep. Pradeep was in Udaipur to attend the wedding wedding anniversary of his in-laws. I think the 50th wedding anniversary of his in-laws, but he came all the way, he made his way back right in time so that he could join us for this function. Thank you, Pradeep. Just hold on. All right. And then we've got this whole set of youngsters who have, brought a new light to Bombay ankle foot. Till about 6 months ago, I had never heard of anybody beyond Pradeep Moonot in ankle foot surgery in Bombay. And suddenly now I realize that there are so many young chaps who are doing such a lot of exciting work. I met Dhrumin for the first time about 4 months ago. And since then, I've come to know he's doing some excellent work. Dhrumin, can I get you up here? Thank you very much. Yes. And we'll have a faculty photograph at the end of this, yeah, if you don't mind. Pascal, somebody just told me, "Arey Pascal hai na?" Bola, "Kaun hai Pascal ye?" Well, Pascal hai ya Rascal hai? Huh? But I'm very impressed with Pascal's presentations. I was telling Ashish earlier this morning that he is a person whom we should rope in for future meetings. Pascal, good job. Pascal will be the law soon. Shyam Thakkar, Shyam, I met for the first time last weekend at the Master Series program in KEM Hospital. Very impressed with his presentation. Immediately told him, you must come for this program. And he was kind enough to agree. And even this morning when Pradeep was a little late, I was a little worried. So I requested at the last minute, Shyam, can you do something? He said, sir, certainly I'll put something together and present it. He was very sporting. Thank you very much. And the youngest of the lot, and that is Samarth, who has just come back from his fellowship and he has started practice. and he was here with all these lovely quiz questions to keep us interested. Thank you very much, Samarth. Last but not the least, I would like to put on record here the phenomenal work that Intas Aquila has done for us. All our BOS outreach programs, all our live surgery symposia have been sponsored by Intas. Sponsoring is one thing. You can, chalo paisa de diya. But these people have gone today, since morning. The first people to come here were the Intas people. They've been here since morning. They've been on the job, on the ball, coordinating with all the centers across the country. So I would like to place on record my thanks to Mr. Jagrup Singh, who is the Vice President of Intas Pharma, to Prabhakar, who is my colleague and friend from Bombay over here. And I would like to place on the thanks to each and every Intas representative across India who has helped us facilitate these fantastic events. I would like to thank the delegates who are here today in Bombay, including our past president, Professor Karkanis, who has been here since morning, actively participating in this event. Thank you, sir, for being here. Your presence means a lot to us, gives us a lot of support and confidence. And I would like to thank each and every person from all over India who has been there, whether it is Ludhiana, whether it is Sangli, Prayagraj, Indore, Alwar, Hyderabad, Burdwan, Dibrugarh, Meerut, Sangli. Everybody who has been here, every delegate, I hope that you all have gained some from and some take-home messages from our meeting today. For us, it was great. In the people from the Bombay Orthopedic Society, we've had a grand time bringing forth this program to you. And we are very happy that all of you were there joining us. I hope you all have enjoyed the program and will join us again on 17th of November for the next Pediatric Orthopedic Live Surgery Symposium. Can I pass our mic over to Ludhiana? Ludhiana, your thoughts, anything you would like to contribute?
Thank you very much for a wonderful session we had. We all really enjoyed. Thank you so much.
Thank you. Let me pass on to Prayagraj. Prayagraj. Indore.
Hello.
Indore has been keeping us on our feet this afternoon.
Because
all the
without
difficult questions.
Oh, no, Dr. Zaveri, without spine, feet doesn't have any value. So I congratulate you first of all for organizing such a wonderful live event. And believe me, it is very easy to be a critic, but to present a case, it takes a lot of guts and means, dare. So I thank you from behalf of Indore Orthopedic Association of Orthopedic Surgeons of Indore. I thank you from wholeheartedly from all the foot and ankle surgeon devoted who are practicing at Indore. I thank you all the faculties who have demonstrated excellent work and hope to see you again.
Thank you, sir. Thank you. We will see you because on October 26th, Bombay Orthopedic Society is doing an outreach program in Indore, and it is going to be on musculoskeletal tumors. So I look forward to meeting you over there, sir. Hyderabad, I can see Dr. Ravindranath is no longer there, but any comments? Burdwan?
Thank you, sir. It was an excellent program. We are waiting for such program in future. Thank you especially to you also for conducting such an wonderful program.
Yeah, thank you, sir. Thank you very much. Dibrugarh, can we get some bites from you?
Yes. It was a very wonderful program. Thank you. And we hope to meet again sometimes like.
For sure. I think let me take this opportunity again to invite each and every one of you to our annual conference, WIROC, Western India Regional Orthopedic Conference, which is going to be in December from 26th to 28th December. because it is our Diamond Jubilee, this conference is going to be a big event with lots of never before events. In fact, we call it the never before VIROC. You're going to see some incredible stuff, and I would encourage each and every one of you to attend VIROC and join us in the festivities. Let's move on to Meerut. Meerut, last word, some final words from you guys.
Thank you so much, sir. We all have benefited a lot from today's CME, and we had so many postgraduates also, and everybody has taken home good message on foot and ankle surgeries. Thank you so much.
Thank you. Thank you. And finally, Professor Saraf, he's been there since morning. Sir, thank you for joining us.
Thank you to you all. It was well organized, quite motivating. We learned so many things. Thank you.
Right. And thank you again to all the people who are gathered here in Bombay. A quick faculty photograph before we move on to the last presentation, which probably is the best of all of them. And that is from Pradeep on the talar neck fracture fixation.
Sir. Hello. Thank you, sir. Hello. नहीं अपन उनसे सुबह अपने से बात नहीं कर पा रहे तेरी का भी बात है ज्यादा ही बता रहा देखा मैं वो के डांट बता बात कर दी बैठे हां ये अपने से डरा तू क्या जानो कहीं जा रही तू क्या समझा रहे हो घर करके छोड़ और क्या ये डॉक्टर चौपड़ो बैठा है भजन लाल की लाश सुनती आस पास लाल में सर से आज मजाक मार के आपको भी बस सही दवा करते हैं तो सही पहले लाश में भी रहा इसको छोड़ दस हजार में रोटी भी देते हैं घर तक छोड़ देंगे और कहते हैं छोड़ देंगे बोले तो छोड़े 15 दिन की दवा ले और डॉक्टर चौका मनरेगा में पैसा और मनरेगा अभी चाय आ गई ना 4:30 यार कितने पे हो
Okay, any questions on any previous talks or anything burning stuff happening? Okay, so last talk of the day.
रात में फिर बुला ले रात में फिर बुला ले अभी से चालू कर दे हमारे लिए तो चार अरे कहना पूछा ये लास्ट पे
वीडियो है
इसके बाद एक वो गाड़ी कर गया ना
ये रहेगा ना फंक्शन F3
सबसे रोतला है टॉपिक है ना मतलब इसमें रिजल्ट की प्रॉब्लम है अभी सारी टॉपिक ऐसे कर रहे हैं यार आप
Okay, fantastic. Thank you. Yep. Great. So we'll be talking on talar neck fractures. So 22-year-old female came with history of trauma, sustained this kind of fracture. And clearly you can see now, yes, there is something happening in the ankle joint. There is a double shadow of the talus, something there. Okay, and also looks a little bit of comminution. So, sake of time and everything, let's carry on. What would you do? So just go through that. There was a tip of the fracture of the lateral volume नहीं है क्या? Volume है? नहीं है. Okay. Thank you. No. Anyway, so you saw that fracture. Now read your CT scans, and that is the reason I have put the CT scan. You can clearly see somebody's taken the pen away, but go through the whole thing. That's a tailless body. You can see that's not a single fragment. There. Okay, that's not a single fragment. There's a lot of pieces happening on, a lot of things here. You see, that's not normal. There's a comminution, that's your fibula, that's on the lateral side, medial side, posterior side happening. Here as well, there's comminution happening in the front as well as at the back. So this is not going to be a straightforward stuff. And here you can see that's going through the neck from the lateral side to the medial side. And that's your CT, 3D CT sometimes helps. So gets you that orientation. So lateral side here happening. Okay. And then if you go through the medial side, here it's a posteromedial fragment as well. So anterolateral comminution and the posteromedial comminution, both sides. Okay. So what are we going to do? Aspect as well or not. That's what also there is a comminution here as well. So that looks more on the lateral side. That's a fibula. So that's a lateral side. Fracture line coming through. This is a medial side coming through. Look at it. Significant comminution there. More so posteromedial side, large fragment posteromedial aspect. Lateral side is okay. Lot of fracture line, but it's not comminuted as well, which is normally what you normal talus fracture where the medial side you have compression, lateral side you have a tension fracture. Medial side there's the fracture line which going through it, a small fragment there as well. Again, there it is. There, lateral side. If you look on the medial side, there's more of posteromedial comminution. Okay, so you can do it conservative or you can operative. If you want to do operate, what type of approach would you use? Would you use a single approach, dual approach? And then if you want to use a dual approach, what kind of approaches you're going to use that? So all these are the questions which you should be knowing and answering before you start operating. So with the kind of displacement which we had, young patient, it was decided she would need an operative approach for this. Of course, a dual approach, and we'll go through it which one we have used. So dual approach was anterolateral posteromedial, supine position, okay, like a TKR. You can internal external rotate as well. Start with an anterolateral approach first. We have gone through those approaches. I'm sure in the basic trauma you would have done that. Okay, from the fibula right to the base of the fourth, open it up. You see the extensor tendons there, the retinaculum, open it. There it is a fracture hematoma, and you can be right into the ankle joint and into the talar neck. You reduce the fragments, everything. You make sure the fragments are reduced and then hold with multiple K wires. And you want to make sure, here you can see my punches there, making sure these pieces are held in place and multiple thin K wires are put in. And that's where you can see here clearly 2-3 K wires have been put, different sizes, because you would want the bigger fragment probably a 3.5, smaller fragment 2.5 headless screws. Okay. Also you can see here the reduction and everything is quite nice. And the key thing is you need to learn for talus fractures how to check for reduction is the canale view, which you do is internal rotation, that's 15 degrees, and the beam comes 75-degree cephalic. Okay, so there it is, internal rotation and then 75 degrees. And that's what you need to see. There you can see the whole neck in line, and you need to make sure there is no step at all there. Once that is done, screws are inserted, 2.5 and 3.5 mm headless screws. The anterior process is nicely sat. Headless to headless screws, we have used it. And here you can see that fracture is anatomically reduced, no gap felt, and 2 screws which we had put. So these were 2.5 screws. These are 3.5 screws, headless, and it's very stable ankle, stable fracture. Yes. So that was closed up, and then bolster removed, patient turned slightly, and then a posto-medial approach was done. The incision is between the medial malleolus and the Achilles tendon. Then move around. Or posto-medial to move around. So FDL and a neurovascular bundle, you want to go through it? Neurovascular bundle. Can you see that? That's your neurovascular bundle. So let's see if I can get in there so that there. And you need to make a big incision to have a small window because there's a lot of traction happening and it's a thick capsule is there. You need to incise that capsule. And it's very thick, so it's you really need to have a good dissector, periosteum elevator. There it is. Once that's done, then it was easy because the fragment was not too displaced. Reduce it with a hand. That's a fragment there, holding it with a hand, and then putting it couple of wires. So hands up, how many people actually have a K-wire driver in your OT? Only 3. Nobody else. These cases, and especially small bone cases, you cannot do it without a K-wire driver. And a step forward, if you see my drill, this is a small hand drill. This is not your striker 8 or 9 drill. The striker 8, striker 9, these are heavy drills. These wires are 0.9, 1.1, 1.2 mm wires. These will bend. So what my point is, if you are doing more and more hand and foot work, you need to invest in small handset, small drills, so you can do it easily. Life becomes much easier. You're not faffing around too much on that. There, one headless screws you put in, and then it's stable. That's your joint there. And that's what the other fragment, which is also sat nicely. So we didn't need to put a screw. Okay. So that's all that needs to be done. Secure in this. So that's your final fixation done. And here again, she was in a plaster for 2 weeks and then range of movement exercises started and 6 weeks weight bearing mobilization. Okay, so here we did not need to do a medial malleolar osteotomy. The question is if a medial malleolar osteotomy. So a posterior fragment or a tubercle, you cannot access through medial malleolar osteotomy. Medial malleolar osteotomy is required if you have a neck which goes really up into the body, or you need a body fragment or body fixation. This is from I didn't have any pictures or good videos, so just a thing. Medial malleolar, you take a big incision, you drill, pre-drill and pre-tap it beforehand. So you know when you're doing your screws, you just need to pass it through it. And then you do an osteotomy, a vertical osteotomy, which you come right at the shoulder of your tibia or the ankle joint. You come through to the saw up to the cartilage, but the cartilage is broken with a sharp osteotomy, not with your saw. Okay, there are various ways you can do a transfer straight away or you can do a chevron. Once that's done, you flip it, you can hold it with an ethylon or heavy ethylon, retract it, and there you can see, you can see you can see the whole body and to the neck, but you can't see the posterior part of your tubercle. If it is posterior part of the body or the posterior part of the tubercle, you need to have a posteromedial or a posterolateral approach. There, you can see the whole body, but this part you will not be able to access. I have had burned my hands and fingers with this. So only the body and the neck, not the posterior part. Any questions? Thank you.
Questions from the audience about talar neck fractures? Yeah. Can we go back? Yeah, thank you very much. That was the last case. If there are no questions, Alwar, where is Alwar?
Indore,
Yeah,
Indore.
Alwar did not get a chance to tell us about their comments about. I can see there was a big group of people in Alwar who were sitting and patiently listening to us right up to the end. Thank you very much to all of you. Please tell us, give us your feedbacks, how we can improve, sir.
One question from Indore.
Sir, good evening.
Good evening.
Of Alva Orthopedic Surgeon Association, I want to say thanks for interactive session as well as excellent program. Yes. For Bombay Orthopedic Society and INTAS people.
Sir, one question from Indore.
Sir, I have this one. This
Yes.
time can be 3 to 10 in next time.
Can we do what?
The time should be rescheduled 3 p.m. to 10 p.m.
Okay, you are saying it should be in the evening.
Yes, sir. Yes. Morning difficult, every OPD and all that.
Yeah, sir, that's a good suggestion. We'll do it today. Of course, there was the India-Pakistan match, so we did not have the guts to keep people away from the match. Yeah. Indore, one last question from you.
Sometimes there is some small fragment or combination on the medial side of the neck
Speak
and
a
body.
little louder.
So sometimes there is a small combination, a small fragment on tailor neck and body junction around the sustentabular area. How to tackle these small fragment?
I didn't understand the
So
question.
there is some small fragment
There
of
is
combination
some
on the medial side on the sustentacular area. How do you tackle that?
So if there is a comminuted fragment but not displaced, you don't need to operate. But if it is displaced, then yes, you would operate, and you would, with the aim when you go inside that the larger fragments you will fix it. Smaller fragments may just leave it there with the soft tissue attachment, or if it is significantly very small, you can just remove it. I think that's what my aim. And in this case, that was my aim. There were multiple fragments, but my aim was to make sure that these fragments are put back in place and the larger fragments are fixed up. That's all.
Thank you.
Thank you.
Hello. Hello, hello.
Yes, who is that? Please speak.
Thank you, sir. Thank you so much.
Hello, hello, hello.
Hello. No, I think it's just a mistake. I think we have caught, I can't hear what somebody, if somebody is trying to get through to us, please speak. Oh, thank you. All right. With that, we bring this program to a close. I was a little remiss in not mentioning the excellent work done by Mr. Ivan and his team of audiovisuals. We have had a seamless connection throughout today and very beautifully managed. Congratulations and thank you very much. So with that, we close the meeting, we disperse and hope to see you in November for the Pediatric Orthopedic Symposium.
Sir Indore, thank you so much. Thank you so much. Hello. Hello.
ऑडियो गिरा दिया वहां तो उनको आवाज नहीं आई क्या हेलो
ये लोग जाते हैं बिल लगाएंगे ना तब तक ये तो काम हो जाएगा नहीं हो गया सर